Cancer doesn't discriminate. It can affect any of us.
This is Living with Cancer is a program created to support all people in their cancer journey, especially those of us facing challenges.
Get resources for older people living with cancer. Understand the importance of screening. And find tools to help live life beyond your diagnosis.
Learn more at thisislivingwithcancer.com.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.
The Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
This meeting has singularly been able to propel forward many of the concepts that are changing the field throughout the world. So even though you guys think that you're just sitting there as participants or audience, just through your social networking, just by sharing ideas, just by changing referral patterns, other institutions are going, well, crap, you know, we better set up a PET scanner, or gee whiz, we better get into a more aggressive mindset about therapy. I like this meeting. I like talking to patients. I think patients get it much better than doctors. So for me, that's why I come and speak to you. And for me, the privilege is simply that some of you are doing better, all right? That's all I need.
Hey everybody, it's Alex at the PCRI and welcome to the 2023 Moyad Scholz Mid-Year Update. This conference is designed with you in mind. It's for prostate cancer patients and caregivers to learn about the lifestyle, the advanced prostate cancer treatments, proton therapy, prostate cancer imaging, and so much more. We received hundreds of questions, and through the Q&A with Dr. Scholz and Dr. Moyad's moderating with the speakers, we'll be able to answer them today. What you're going to see is a previously recorded broadcast from our in-person conference 2 weeks ago, but I will remind you that our helpline team is on today with our physicians able to answer your questions, and so go ahead and leave them in the chat box, or you can email us at info@pcri.org. So right now we're going to have a short invocation from a prostate cancer patient who's been a good friend of ours for many years. His name is Rabbi Elliot, and I'll be right back.
Thank you, Lord, that one day does not go by without your oversight or understanding. Thank you that you are faithful to your own word. Thank you, God, that same word declares you as the healer and a great physician. We come to you thanking you for the other physicians you've raised up for men and women. And we ask you that your wisdom and your insight and your plans for our health and healing would be revealed in this critical conference this very weekend. Bless this time, dear God. Amen.
So right now we're going to be covering advanced prostate cancer and its side effects. We have an incredible speaker. Her name is Dr. Elisabeth Heath, and she is the Associate Center Director of Translational Sciences for Karmanos Cancer Institute in Michigan. She does an incredible job of contextualizing prostate cancer in an advanced category, but she also talks about the different types of treatments and their individual side effects, and also the importance of genetic testing in this category. I hope you find this informative, and if you have questions, again, email info@pcri.org or leave them in the chat.
Yeah, I've heard about this conference for so long. You guys are like the true pioneers. I've emulated a similar format in my hometown in Detroit, Michigan. That's how Dr. Moyad and I tend to cross paths, and we love to share information, and we have, I think, very separate practices out there in the state of Michigan, but it just shows you the true diversity of this cancer. You know, it really doesn't care where you live, what part of the country, who you are, your age, your race, your background. It just is there. So our job here, and it's a little loose on the timing, I think, right, Dr. Moyad? He's like, 10 minutes, 3 hours, go with that. I said, okay, well, my job, I think, is to maybe take you on this journey of where we are with all of the treatments with prostate cancer. Because you know what? All of a sudden it got kind of complicated. And the more complicated it is, in a way where sometimes you're keeping up, bad news, the doctors are trying to keep up too. So as we're keeping up, we're not keeping up all at the same time. If it's all that you do, like myself in academia, maybe it comes a little easier. If you're in a busy all-around practice and you're seeing a prostate patient followed by a breast cancer patient followed by a head and neck cancer patient, it gets a little tough. So you in the audience, whether it's virtual or in person, it's up to you guys to advocate for yourselves, for your family, for your neighbor, for your community, because it's gonna take all of us. That's why, what was said on the video is so true. What's important here is it's a collective community problem, and we're only gonna solve it with all of us showing up. A little bit about myself. I've been in Michigan now for 20 years, and my practice is in downtown Detroit. If you guys are ever around, come visit us. We definitely have a less hectic airport. I can say that 100%. LAX is, wow. That's all I have to say, wow. Part of the things I think that, that sense of overwhelmness happens in prostate cancer, but if you have metastatic disease, it's even more overwhelming because you feel like you hear a time clock. And maybe it's meaningful friends and family who says, would you see that doctor yet? Did you go on that website yet? Did you get that supplement yet? Really confusing. And why is that? Because everyone wants to help. Everyone wants to help. Everyone wants you to be better. But I think knowledge and education is the first step. And whether it's this conference or going on different websites, it is so critical to educate yourselves. And guess what? What I say today may literally not be true in 3 months and in 6 months. And our information train, so if you're me and Dr. Moyad and Dr. Scholz, we check Twitter, yes, Whether you're a Twitter person or not, however you get your news, there's usually something new every 24 hours. So our scientific news cycle in the world of oncology is turning over almost every 24 hours. And that is overwhelming for the physicians. So sometimes when I see folks, the first question is, how does my doctor not know this? And it's a matter of loss of trust immediately. And the answer is, well, he or she may not have had time to look at said website because they're doing something else. So the way to approach that is, hey, did you hear about the latest and what do you know? And maybe give that person a little bit of time to catch up. But it's got to be a team effort. I could tell you what I love about giving this talk 20 years, from when I started is there's more stuff on the slides. It used to just be, well, it's androgen deprivation, and sometimes I squeak in the word chemo, right, Dr. Scholz? Other than that, it's, well, we're gonna just keep talking about hormones. And no, trust me, we're still there, but there are still other options. But before we get into it, there's something new that's occurred. And you guys always see the slide of how many prostate cancer patients get diagnosed and how many deaths per year. These numbers change. The American Cancer Society does a really good job of spitting this out. And you can find this on cancer.org. There is a publication that the American Cancer Society has a section in their program that looks at just statistics, like really solid statistics. And these numbers we tend to obsess about because as a society, you want to know, is this thing going up? Is this thing going down? And the good news is most people are diagnosed with local disease, so you hopefully don't need me. I might be the person that sits in the middle, and are you for radiation? Are you for surgery? And the answer is, we walk through it, we figure out what's right for you. But we know now that metastatic disease, which used to be just a line item, hey, it's metastatic disease, you're stage 4 out of 4. What we know is that every person with stage 4 is different from one another. The complexity, not just physically, it's now genomically or genetically so different. And the placement of your cancer. Are you a 4 because you have a little itty bitty lymph node? Because, we made the staging like that, blame the pathologist. I hope there's no pathologist viewing right now, I will disclaim that, but it's the way we just sort of put the staging. But is that the same as a person with liver metastases or lots of bone metastasis? No, and you know that because one person might have a stage 4 and be quite debilitated, and another person might have stage 4 and be perfectly fine and walking and running and doing all sorts of things around town. So it's very complex, so it's not a one-size-fits-all solution because you're not all the same. But here's the new data, literally super up to date. We are going the wrong way, guys, with prostate cancer. We were doing great for a hot minute. Incidence and death rates, we were making a difference. Look at what my bullet points say now. The cases have increased 3% per year from 2014 to 2019. What? Did that say increase? We're going the wrong way. That is a shocker when the American Cancer Society and other cancers, everyone's doing better. You take cervical cancer, wow, that HPV vaccination has done something. Those numbers are way down, thank goodness for your loved ones. Prostate cancer, it's up. The incidence rates is higher in black men than in white men. We've known this, but to now have that actually be higher is even more disturbing. And if you look at advanced disease, which is what I'm talking about, look at those numbers, up. So how are we in this pickle? Well, the proportion of men diagnosed with distant stage disease has doubled in just that last time frame. Doubled, not a 2% change, nothing. We are talking that we are now, as a collective community, facing a different challenge, which we may be in this pickle because we sort of got completely derailed with screening. Screening was sort of the most mixed messaging you can get. I always say when I run our health fairs and our discussions, it's the most wishy-washy answer on the planet. Should I get my PSA screened, Dr. Heath, Dr. Smith, Dr. Scholz, Dr. Moyad? Well, let's talk about that. What are we going to talk about in the midst of your colonoscopy screening, skin, seatbelt awareness, you know, all sorts of other things that you're talking about, diabetes, hypertension, cholesterol with your physician? Are you really going to have a 30-minute discussion at shared decision making? Because at the end of the day, they say, well, what do you think I should do, doc? Right. So that sort of, I don't really know, and then the number went down, and you poll a bunch of doctors in the room, we're all going to give you different answers. So what does that mean? It means those are the numbers we're looking at. So one, you can see communication is critical, which is why you're all here today and part of PCRI. But number two, what are we going to do about it as a community? Seriously. So you are all involved somehow, whether you're here as a patient yourself, or you're here for a loved one, or a friend, or someone in your community as a supporter. What are you going to do about this? We have a real problem. I put that challenge to Dr. Moyad and Scholz about what are you guys going to do about that, because it's going to take the collective, all of us, to decide whether this is where we want to go, so that my discussions of all the advanced prostate cancers are not what's the main issue. It's the, can we really reduce this number? So I put that out there as sort of action item one. What are you guys going to do? Are you going to spread the word some more? Now with real data, like, oh boy, we're not screening, we're in trouble, everybody's coming in more advanced. And the pandemic did not help. So one of our events we run in Detroit is, gentlemen, check your engines, and we pair up with Harley Davidson, because I had a Harley Davidson diehard in my practice, and he has since passed, but we do it every year to show up, because men take care of their bikes and their cars more than they do themselves. And when we say we're going to have a shared decision-making moment about PSA, you all said, oh, that's so great, I don't have to go to the doctor. No, that's not what we said. We're having a shared decision-making moment. Yeah, we're not going to the doctor. Got that. Thanks, Dr. Heath. Right. So we need to, as a collective community, think about that, because you all know in this room that this is how we doctors think about prostate cancer. So if you go from the left to the right and you say, am I local? Am I somewhere in the middle where my PSA is going up and down and driving everybody crazy? Or am I really getting a lot of treatments now for my advanced cancer? How we do drug development, and I've done drug development for 25 years, and what does that mean? It means I really want to get a drug that's going to cure prostate cancer so I don't have to look at you guys on a rainy Saturday in LA. But it takes a lot of effort. So how do we do that? We have to think of that in these terms. It's not to say you're in a box. It's how we think scientifically, and most of the advancements are all in the green boxes. So all of these castration resistant, you know, we all hate that term. By the way, there's sort of a movement to change the term. I think you all should get a vote. You know, for years we've been telling you you're going to have to be castrate resistant, and then all of a sudden you're going to change it. So now when you Google, it's going to be another hot mess of my hormone resistant. What am I, doc? I don't know. Stop Googling. That's probably the thing. Or go on PCRI to get the information. But part of it is all of the dollars spent is really to work on folks in the green boxes. So is that important? Sure, because you get a vote in that. As part of advocacy, we know that the toughest cancer to do anything about is folks in the green box. It's not to say we don't have treatment, we just need more. And how much more? So here's the list. First of all, I remember giving this lecture, and we kind of literally had 3 boxes. It was ADT, a little bit more of ADT, and docetaxel, chemo. So let's run through this, because we're just going to pause here. So this is the complete list. So when you see your doctor, no matter what stage you're in, one of these doohickeys in the boxes is going to pop up in your discussion if it's needed. So the things that are in orange are all chemos. So I've only put generics, so that it's easier in how we communicate to one another. So mitoxantrone, 1996. And you're like, wow, I affectionately call that Smurf juice, because it can sort of make you pee blue. So why is that not out there? Well, because the data shows you don't really live longer, but it does help you feel better. So have I, as a medical oncologist, used mitoxantrone in my patients? The answer is absolutely, when needed. but it is an older agent. It's not to say old is no good, it just means you gotta think about how to strategize. Docetaxel, cabazitaxel is the staple of what's in our, toolkit. So those are words you should be familiar with. Sipuleucel T is the first immunotherapy that was approved. It's not for everyone, but there sure is a huge audience that would benefit from Sipuleucel T. And all of these drugs have an FDA approval. So none of this is clinical trials. None of this is anything that, you can't get. These are all FDA approved drugs. And then all the ones in lighter green are the hormone pills. So some of you are maybe new today and don't know what the hormones are. We'll talk about that in a minute. And some of you have heard these terms now for the last 10 years, and we just keep adding more things in the green boxes, because that's how we advance drug development. So you have abiraterone, enzalutamide, apalutamide, darolutamide. Those are hormone-type pills. Then you have radium-223, which is in a box of its own. Can't really tell, it's a different colored blue, I think. But that is a radiopharmaceutical. That is the stuff that Marie Curie discovered all those years ago and got a Nobel Prize. When I say that, and I say, listen, my kid's 5th grade, project a gazillion years ago actually is a real drug that we give, it's a shock. But it's available today for the right person. Relugolix is the new oral androgen blocking drug. That's sort of the, instead of the shot here or here or here, that's the oral equivalent. Let me just take a quick poll. Who's heard of that drug, Relugolix? Raise your hand. Okay, so it's not the whole room, right? So one day it's gonna be the whole room, because that means you guys have been aware and educated on that is an oral version of the injectables. So that's something maybe to ask your physician to see if that's something that you should consider, because the side effect profile is different than the injectables. And then lutetium, 177 PSMA. The hot topic of all hot topic. I've never heard 4 letters be discussed in my practice so much than in just this past year. Everybody wants it. Boy, oh boy, are we struggling with it. We're going to talk about that as well. And then who's heard of the red box, olaparib and rucaparib? Raise your hands. Okay, that's even less than Relugolix. So we're going to talk about that. It's a whole brand new class of drugs that may be relevant to if a portion of you, or is it all of you? Oh, yeah. We're still figuring that out. And then you have the bone drugs that are in green. These are ones to strengthen your bones in case you have a lot of cancer, in case you have thin bones, which, as we age, men and women, we also are at risk for fracture. So these are things. I want to know, a show of hands, anybody in the room that knows every drug in the box, who's ever heard of it? Raise your hand. Now it's the smallest amount, and your votes don't count, by the way, people. Your votes don't count. If you did raise your hand, I'd be really worried. But I think there was maybe 3. Out of this whole room, I don't know virtually how many, but it's on us to know all of them. Because you could be sitting in your doctor's office, perhaps with a friend or yourself, and then you say, wait a minute, let me pull up my boxes. And this box might change, If I get invited back when it's sunnier and warmer and I can walk outside without getting rained on, there may be more boxes. Now I gotta tell you, our breast cancer colleagues, they probably have 50 boxes. So they got us beat by a lot. So they've been more successful because the women with breast cancer go on trials like nobody's business. You call women to action, boom. You call men to action, you're like, okay, no, thank you. So it's gonna take you guys to tell the next person to say, I was on a trial, it was no big deal, and I was really glad I did it because I helped the next person. If we don't endorse it ourselves, this community, to share with others, we're gonna be in a bit of trouble. So, is it still, though, all about androgens? It's all still about androgens, guys. No matter how many times I'm up here, I can't get away from this slide. Just like estrogen drives breast cancer, testosterone drives prostate cancer. It doesn't matter how many times we swing that, how many times we try to do drug development to not focus on that. The cancer relies on that like fuel. Since I'm from the Motor City, I think of the areas in the left, which is a whole bunch of drawings that really, short of some of the investigators, we don't really look at that closely. But what do we know? We know if we shut down testosterone, kind of the cancer stops growing. So in a Motor City analogy, if you put away the gas, the car doesn't run. You still got a car, still hanging out in your garage, on your street, doesn't really go away. It's not like the car gets absorbed, but it doesn't run, there's no gas. On the right side is when the car says, maybe I don't need gas, I got plenty of electricity. So now it moves. So the car is still there, and when it becomes and develops resistance, it's using a different fuel to go. So we now take all of those other areas coming in, and all of drug development is, okay, I see something coming at me this way, knock that guy out. Oh, I see something else coming that way, knock that guy out. Can't solve the issue of getting rid of the car, although there are attempts to destroy it. And we call those androgen receptor degraders. But it's hard to do it. It's like saying we're going to get rid of all the cars on your street at any one time. Really hard. You could take away the gas pump, then the cars don't go anywhere. So a lot of our drugs that you just heard of is kind of in this way. Now, is that fun for you guys? Well, you get to see your PSA drop. Woo. What happens to you guys though? Well, then you're in menopause. And when you're in menopause, like women, you get women-type menopausal symptoms. So I call that manopause. Hot flashes, weight gain, higher cholesterol, trouble with maintaining your blood sugar, hypertension. What is that called? It's called metabolic syndrome. I think Dr. Moyad gives an awesome lecture on metabolic syndrome and what you can do about it. It's a thing you all can fight against, but we're lousy at it in our world. We're lousy. We tell people we're gonna now go move, and we're gonna walk, and we're gonna do what we do in Detroit. We have a CrossFit program. I don't know how my guys do the CrossFit, but yay. Bottom line is, you have to fight against it. And then you have to share the word that this is one way to help mitigate some of these side effects. But we can't seem to get away from it. There are a lot of efforts, though, to try to develop drugs that don't take away your testosterone. So everyone feels this, everyone knows. We are just trying our darndest to come up with a path forward. So it's not that we're not listening, we're trying, but it's really hard as a strategy to overcome. So I just wanted to put that out there. Okay. Let's talk about what's sort of new. Now you guys know all of the ingredients of all the things we're going to talk about today. The world changed a lot last year in this group. So now I put it here, metastatic hormone sensitive. So it's kind of in the middle of that journey box, so that you are not green yet, you're still in the blue box, but you come with spread disease. So with the rise now of cancer that we just talked about, the statistics, what you're gonna see is a lot more men coming with advanced disease. So what am I seeing post-COVID? I'm sure others in here will say, well, I didn't know that back pain was something. I thought it was just, you know, I'm getting older and I have back pain. Oh shoot, now my PSA is 2,000. And that's what I get now in my practice. I went to the ER because I thought I raked or shoveled or something, and it's actually cancer in my back. It's devastating. But when you come there, the old way of doing it was, well, I'm gonna just provide a shot or get rid of your testosterone. And some of you have actually elected for surgery. It's not to say taking away your testicles is not something that's happened. So I want to recognize that, because I have men in my practice that opt for that because they feel that that's what they want to do. Options, 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 as long as you know that that's what it's about. And we started throwing in chemotherapy on top of that. And that was 2015. And then you see those other names that are now familiar to you, abiraterone, enzalutamide, apalutamide. And then, what happened in 2021? Oh yeah, we just threw in now both of them together, and 2022. So it's not that you have to know this. It's to know that, number one, all of the things here have a survival advantage. So The message here is you need, when you first show up with spread cancer, you need more than an injection. You need something else to go with that. And I have to tell you, that messaging isn't out. It needs to be out. It is your mission, action number 2. You gotta spread the word that if you know somebody in this position, this is important. Why? And there's no quiz on this, by the way. I put this to also show that scientifically we know everything that I just listed helps a person live longer. Doesn't cure anyone, but you live longer. So if you know that it's more than an injection and I need something else, well, what's the trouble, Dr. Heath? Seriously, what's taking so long? Okay, and I'm just saying this for the triplet. Let me tell you how we're thinking about this in big bucket terms. Your single, which is just your injectable, or how you get rid of that testosterone, remove the gas, versus the double, which is now doing that plus a pill, versus the triple, which is doing that plus the pill and chemo. The things that are double and triple is the standard of care today. So when I say there's action number 2 is that unfortunately the majority of people out there are still getting only the single. We are leaving money on the table at every which turn. That means people's survival. So when you look at this and you say, I don't know anything about curves, I don't know what you're talking about, oh, there's Kaplan-Meier, hazard ratio, blah, blah, blah. Trust me, on a good day, I don't know what I'm talking about either. However, what do I know? I know when things make you live longer, and when you need to know that as a patient and as a loved one. And we say, well, how do you know if it's a double or a triple? These are some of the things that your doctors are using every day to make decisions. So this is the inside peek of, you're in a restaurant, let me see inside the kitchen what they're doing. Here's how we think about it. Sometimes it's as simple as I always use a pill because my team knows exactly how to do it. 90% of the people have this insurance. Bob in the front desk knows to call prior authorization, and everyone gets the pill with no copay. Because we know these pills are anywhere from $10,000 to $15,000 a month. And if you don't know that, come join me in my practice in Detroit, when people have to be stuck paying copays. And I'll just put as a plug here for the state of Michigan, we have no oral chemotherapy parity, which means that as a cancer patient, your insurance might say no problem on the docetaxel, not so much on the pill. Wait a minute, let me say that again. So if I was in a state that had this law, as a cancer patient, if my insurance covers chemo, it should also do the same coverage as one of these pills. That's right, Dr. Heath, absolutely. But the 7 states don't have that law. Your insurance says yes to chemo, good luck with the pill. So you have structural things within each state that will be different. You have insurance that will be different for every single man. Medicare, I swear, I have never seen so many nuances of Medicare in my life. I got that plan, I didn't get this plan, I have a sub-plan of this and a double sub-plan of that. No idea what they're talking about other than, what do you mean it's a $2,000 copay every month? For years, unacceptable. So sometimes it's, well, I kind of really want to give you this, but your heart's not so great. You got a defibrillator and a pacemaker, and you've been in and out of hospital with heart failure. Maybe one of those pills isn't the way to go. Okay, but guess what? You get to weigh in that decision. You guys, as the patients, you go, listen, doc, I'm hearing you. I'm kind of afraid of your list of adverse events and side effects. Holy mackerel. Maybe this isn't what we're gonna do. Right, but you know the best part of that decision? You got to make it together with your physician. So it's not something that you should just take and say, okay, that's the answer. Advocate for yourself. You say, listen, okay, that's great, I was heart failure, but my heart failure was 10 years ago. I'm fixed now. My diabetes is under control. Why wouldn't you entertain that from me? Be your own advocate. And then, of course, the no coverage issue. Push back. One company may say no. You wait another few weeks. You make your team go back. The number of times I am re-appealing is too many, in case anyone's listening. Please make us stop doing that as doctors, thank you. But it's so hard, you guys. I'm literally on the phone fighting for every patient because sometimes it's a different person on the phone. Sometimes January 1 of a new year shows up and the rules changed. What do you mean the rules changed? I don't know, some policy went in I'm not aware of, and you had coverage and now you don't. You had coverage from patient assistance and now you don't. So be your own advocate. Don't just take it, oh, we can't do this or you can't afford it. Not in 2023. And then these are the issues that we think of in our practice about, well, do you throw in the chemo as a triplet? Do you throw it in? So we use things like, well, gosh, do you have liver or lung metastases? That's what visceral mets mean. Or do you just have a lot of bone mets? And then we kind of worry you have high volume. So if you Google now, there's a lot of that wording around, high volume, high risk. They're two different things. So high risk is, are you a Gleason 8? Who here knows his Gleason score? Yeah, that's almost everybody. So, you know how, now you know stuff. So if you're like, well, shouldn't I be getting this chemo because you did that biopsy after you told me I had stage 4 disease, and doc, I'm a Gleason 9. Shouldn't I get something else or at least have a discussion? I think your physician might be shocked that you asked that question, but you've been empowered. You know what to look for. What if you have that and liver metastasis, and all you need is 2, and you say, there's data, give it to me straight. What am I getting? Single, double, or triple? And let me tell you, the world, because now we look at what are we actually doing. So there's the academic version, like, well, Dr. Heath wrote a paper, Dr. Scholz, Dr. Moyad, and we say this. And then when you go, okay, well, are the doctors doing what was said? That's what real world is. So we look at claims data. And claims data is what you actually prescribe, and who and where and so on. These are 4 different sets of real world. Half the people that I just was talking about, they don't get a double or a triple. They're getting a single. That is disappointing when you know there is a survival benefit. I'm not curing anyone, but the survival benefit is an additional 15 months. You know, in oncology, you always hear, oh, it's good 2 weeks, 2 months. 15. So if you were getting just the double and you were just getting the single, your survival will be different from one another by a significant amount. How are we doing globally? Well, here's the global data. Everyone is doing it differently worldwide. Now, some of that is because the rules are all different from each other, right? Because if you're in Europe or you're in Spain or you're in Japan, you have access to different things and the rules are different. But what you see is still a large number of green boxes. You know what the greens are? The singles. Yikes, so this is not a US-based problem, this is a global problem. So you share that knowledge with everyone. You gotta be at least a double, and for the right patient, a triple. And this is a nice study that Steve Friedland, Dr. Friedland did, in terms of why don't doctors do it? And I just wanna get you down to that last bullet. Top 5 reasons in a chart review why people don't get the double. Well, I'm kind of afraid Mr. Smith's not going to tolerate it. You might feel terrible. Okay, but shouldn't we try it first and then Mr. Smith can tell you that he feels terrible and you adjust? Hey, there's lack of data that says it's not going to work. I just told you tons of data. I showed you all sorts of beautiful numbers. What does that mean? Oh, the data's there, they're just not aware. That is 31% of the people. Those are doctor's notes. Whoops. We're not educating even ourselves, so we're doing this again and again and again. Worries about payments. Number 1 concern. I'm not going to go bankrupt or bankrupt my family because I have to take a pill every day. And then also just, I'll do it later. So all of these are things we think about. What about the triple? What if the chemo? Let me tell you what we use. This is the look again behind in the kitchen of a restaurant. What are my parameters? So Dr. Huria, who's left us far too soon, was a total pioneer in geriatric oncology. And what she did was look at factors that we use in everyday practice to figure out whether you're strong enough, whether you're fit enough for chemo. So if you're older, we kind of worry. If you're getting a regimen that's for genitourinary cancer, oh, that's you guys, prostate cancer, genitourinary cancer, we kind of worry. Here's another one. If you fell, what? Yeah, my one question that always throws everyone off, have you fallen at home in the last 6 months? And the number of times I get a, well, how'd you know I fell? Well, because I know to ask the question, aha. And let me tell you, I got a bunch of stubborn people in the state of Michigan who just feel compelled to go outside and do things himself. And there's a lot of falls because they're unsteady, because they're weak, because they don't have core strength. So that's important. What if you can't even walk 1 block? So when you're looking at all of this, what happens is an importance to recognize it's not just I'm willing to take the chemo, that I am physically fit to take the chemo. Very important. So why is that? The higher you are on this scale, the more likely you're going to have a terrible outcome with chemo, including death. So a grade 5 means you're no longer with us. A grade 3 means you got hospitalized for the chemo. So when you say to me, hey doc, am I gonna do okay on this chemo? I go, I think you are, because I looked at the factors that I'm worried about, and you're okay. I think you're gonna do great. Or, okay, I looked at the factors, and now you're just scaring the heck out of me, so we're not doing it. But that is a decision made together. Double or triple. Now moving on, we're now moving to the green boxes in our journey. So now these are all the resistance, like, okay, we've done all this. And now you see the difference immediately, which is, we just talked about a double and a triple coming in. All the studies that we've done in this green box space have had no lead-in. Just, I had an injection. So now everybody's asking everyone, okay, well, if I just came in and said, oh shoot, you know, this, I think my cancer got electricity in the car now, what do I do? And then I go, okay, well that's great, because we're just gonna move on to this algorithm, when in real life you go, ooh, you know what, we were sort of treating that already over here when you were in the blue box. What are we gonna do about the green box? And now we're all shaking our heads like, uh-oh, now it got complicated. Where it's not complicated is chemotherapy in the mix? Yes, if you didn't get a triple, chemotherapy is still something you should do if you're in the green box where the hormones don't work anymore. You have 2 of them. This was already in that big list, right? So just to reset everyone's memory. But where's the new stuff? I've had chemo. I've had all the hormones. I'm just gonna stare at you until you tell me what the new stuff is. And you know what the new stuff is? The stuff that only 3 of you raised your hands, which are PARP inhibitors. So you have an entire new class of drugs that nobody's heard of, and it's now all the discussion points where now, you know, our last meeting, you had medical oncologists sort of go at it, you know. Listen, we're a bunch of nerds, you know, for us to get into a fisticuff, it's gonna take a lot. But the verbal fisticuffs are out there because everyone's like, well, is my patient gonna get this? Should we do that? We're a little confused ourselves. I'm not confused. It's all just having a strategy. So you guys in your journey, you need a strategy. So what's new? What's new is we figured out how to leverage what we know when your DNA doesn't work so great. The chemo that I was just talking about busts up your DNA and all your good cells and your bad cells die, right? That's why many of you say boo to chemo. But there are targeted drugs that say, well, okay, well, let's back up a second. Sorry, it's the only Bio 101 lecture we're gonna have right now, this one slide. If your cancer cells or your normal cells replicate, meaning there's 1 of me, there's 2 of me, there's 8 of me, how does it work to repair itself in case something goes haywire? On the left are all the hits, right there. DNA is a double strand, meaning there's 2 strands to kind of get the messaging across. If one of those strands break, there is a pathway that's ingrained in that cell to fix itself. If you have a DNA double strand break, There's a whole nother pathway. Oh, that looks familiar. What is that BRCA1 and 2? Now, who's heard about the breast cancer gene 1 and 2? Raise your hand. Okay, and most of that is because you either have a female family member in your community or your immediate family that's had breast cancer, ovarian cancer, and she has basically said, oh, I did some testing and I'm BRCA1 or BRCA2, or Angelina Jolie, who has BRCA2 mutation, which means that there is a problem in repairing the cell. Now, do I want my cancer cells to repair? No, I do not. I wish it just would and die. That's the goal. So we get that, and we get that this gene, this BRCA1 and 2, completely has changed how we think about prostate cancer. And just right off the bat, how many of you are familiar that having this gene or genetic abnormality sets you up to have prostate cancer? Raise your hand. Not enough. It should be everyone in this room to recognize that. That is a missed opportunity that not just affects your generation and yourself, but your children and their children and their children. So this is the one other thing, action number 3, that you must understand from today, that this gene and its family members have made themselves a nuisance and a target for us to try to do something about in prostate cancer. So what do we do in terms of treatment? I'm going to run through just a few slides that will look overwhelming, but I'll tell you, I'm running it because I'll tell you that in our world as the physicians, we haven't come to a consensus. So the first thing is, we actually have an FDA-approved drug, which is known as olaparib. For those of you who have family members who are women with breast or ovarian cancer, they may already be on this drug. Or pancreatic cancer, that's a shocker for a lot of people, may be on this drug. It's also approved for prostate cancer. There's the indication right there as of May of 2020, when we are deep in our pandemic. This was lost in messaging, completely lost. Who heard of it? Anyone? Nope, no giant splash like lutetium, right? Everyone heard this thing got approved and it was everywhere. So it's approved for those who have this abnormality and who has had one of those hormone pills. Okay, so where is that now? Should we combine things? Now we're in the combo phase. Everybody's like, well, one of these is good. Shouldn't 2 of them be better? You just told me a triplet is good, a doublet is good. Sure. Here's a study. So the study results are the following. If you combine these 2, it really works in everyone. Just this alone, this statement generated so much controversy, not because we don't believe the data, it's just we don't think it's intuitively something that makes sense. It's like if you have a DNA thing, like, oh, I have this problem, I have a drug for this problem, shouldn't it only work in that group? Now you're telling me it should be everyone who walks in. I should just get a double. So I could tell you that right now the matter isn't settled. But us not being settled doesn't mean you should be unsettled. It means you should ask, should I get 2 of these? Of course, nothing in oncology is straightforward. Here's a similar study using a different combo, and it only worked in the people who had the mutation. Oh, man. Okay, let's not get too worried, because now there's another study, because you know we like to do many at the same time, and this combination with enzalutamide did work in everyone. So you got the first one, which is good in everyone. You got the second one only in those who have genetic abnormalities, and you have the third one, which is good in everyone. Yep. Thanks for catching up. That's where we all are right now. And now we have a second drug that, again, I know you missed the announcement, because this is May of 2020 when we're all hunkered down during COVID. This is another pill that's got FDA approval in those with the genetic abnormality. I'm sure most of you have never heard about this, but it's FDA approved. And now this study was done, which showed that, hey, after you've had a bunch of doublets, you can move straight to this if you have the abnormality. Wait, what? Right. If I've had a bunch of doublets when I was a blue box, and now I turn into a green box resistant, I can go on this if I have an abnormality. But shouldn't I go on another doublet? Right, your entry point was totally different, and that's why we're all still squawking to one another and haven't resolved it. What's it mean for you guys as patients? It means ask if the drug is even something you should be treated with. Let us worry about this kind of minutia. This is when all the nerds in the room are blip, 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 blip. It has nothing to do with you guys. You just need to ask, is this drug ready? Now, are you gonna know you have this if you don't check yourself? No. So who has had any type of genetic testing to even know what kind of genes don't work right in their system? It should be everyone in this room. It is now standard of care. Let me show you a free registry called Prostate Cancer Promise, where you can get this for free. They ship you a kit. If you're worried about insurance coverage and so on, it's a saliva-based test. They send you the kit, you get the answer back. Everyone should know their status, because if you have this, you could pass it on to the next generation. So I'm gonna put that up there for a minute. Prostate Cancer Promise. It's free. It is United States wide, and they will ship to you anywhere. These are the other flags. Let's say you don't know. Look what made it to the bottom. Metastatic prostate cancer. All the stuff we're talking about right now, by our national guidelines, if you have that, you should know your status. If you're sitting here anywhere at a stage 4, at the bare minimum, you need to have testing. That is question and action number 4. If you have not gotten tested, you need to ask if it's appropriate to get tested. Because why? You might also find other abnormalities that have nothing to do with the breast cancer gene. So the other testing we do on your actual cancer are things that might get you immunotherapy. So immunotherapy is a whole different class. It's made the news for lung cancer and melanoma and kidney cancer and bladder cancer, but prostate cancer, not so much. The only time is if you have this particular status that shows up on your testing. And let me tell you, I have one recently, and his PSA was 3,000. I gave this medicine, it went down to 2. Boom, because he had this. If you have the target, we have a drug. Just want to make sure. Now, does it work in everything with immunotherapy? Okay, not such great news. You've now got a whole bunch of combos with immunotherapies that don't work. So is that important for you guys to know? Yes, because the newer way to think about this, and it's not to also forget about Sipuleucel T as the first immunotherapy, the new generation of ways to think about novel things is CAR T. Now, who's heard about CAR T treatment? Usually in leukemia and lymphoma and multiple myeloma, the liquid tumors. In prostate cancer, this is an avenue of getting T-cell directed treatment that is specific to you to really try to kill the cancer. I'm also going to mention another directive is PSMA, but you will have an in-depth discussion about PSMA, twofold. Action item number 5. I promise you we won't exceed 5 today. 1, imaging. Is this appropriate for you to find your cancer? And 2, treatment. So these are the 2 types of imaging, and your doctors will know, and this is what it shows. This is actually my patient. The left is a bone scan, doesn't look great with all the dark spots, but you could see the middle and the right side is the PSMA. Look at that middle. All those dots in your skeleton is cancer. And this gentleman's PSA was 4,000. So the imaging, how you look at something will matter. I know you're going to have a great discussion about this, but it's also really helpful if you have a teeny itty bitty part too. You don't have to have widespread disease. You can also just say, why is my PSA of 1.8? It's driving me crazy. I had surgery. I don't understand. Go look. Here's an example. See the giant arrow with the lighted part on the right? That is a lymph node hanging out there. You treat the lymph node, your PSA might go away. That is another way to think about advanced cancer and targeted treatment. And there are many trials. So the current indication is if you had one of those pills, if you've had a chemo. So there are trials, this one's closed, but there are trials around you that might be available. Lastly, you have radium. So what we were talking about with Marie Curie, this is still an appropriate treatment for men who only have the cancer in the bones and you're hurting. If you're that with no liver or lung, this is still an FDA-approved, makes you feel better, longer survival treatment. We've gotten away from this. This is on the, you know, the list. Everyone's forgotten because a shiny new object showed up. Don't forget. That's why I keep the list really comprehensive, because you can always go back and go, what about that? And then I go, oh yeah, we just never talked about it. It's not a matter of talking about it, it's knowing. There are 983 interventional trials available that is open and accruing throughout the US if you go on clinicaltrials.gov. All you gotta put in is prostate cancer and whatever stage. But that is a whole lot of trials for you to participate in. You don't have any advancements that we talked about today without going on a study, because that's how the world works to develop drugs. So CAR T is the rage, but you have to be the appropriate patient. Think about what we talked about, the fitness of the patient. Bromodomain inhibitors is another sort of agent that's now really starting to take off. Androgen receptor degraders, let's get rid of the CARs, not just take away their gas. That is one out of maybe 1,000 targets that we work with. At Germanus, we have 100 prostate trials that are always open because I serve such a diverse group of patients. If I don't have it, I share with University of Michigan and Henry Ford and so many others around me. It is critical. But do this for yourself today. Figure out who's on your team to make this happen. Because if I wanted radium, I need a nuclear medicine or radiation oncology doctor. If I wanted lutetium, the same. If I wanted chemo, I need a medical oncologist. If I'm still having problems with my prostate, I need a urologist. If I have trouble with my nutrition and diet, I need one of those experts on my team. This is just the list. Figure out who's around you. I would encourage you guys to actually make this, write this. You see your doctor, say, that's my team. This is my team that helps me get from point A to point B. You're now part of my team. Not, should I keep this doctor because now I'm seeing you? Nah, everybody's on the team. And this is going to be growing as we have better and newer drugs that come through. This is my last slide. Lots of options. If you are sitting in the audience, whether virtual or here with a stage 4, lots of options. Do not despair, just ask. If your doctor doesn't have something for you, ask to be referred to an institute that has maybe different options. Nothing can be lost with another opinion. That's 1. 2, understand how we think so that we can better help you think the way, to approach this. So it's a journey. Figure out which box are you? And sometimes you can just take what I wrote up there and say, Doc, where am I in this journey here? Because I got lost. Sometimes we get lost. I've had patients in my practice, I'm there 20 years, I have a patient that I've treated with stage 4 for 15 years. We're definitely lost, except he knows he's way over here on the green box. He just waits for the next trial to open. So figure out where you are, and if you have not gotten tested, whether it's looking at an inherited panel at minimum, or if you're spread disease with what we call just a cancer-centric panel, get tested. Ask about it. If you don't know, go on that registry. It's free for everyone. And please try to think about enrolling in a clinical trial. Thank you so much for your attention today, everyone.
That was awesome. I'm not just saying that because you're from Michigan. Honestly, people, we were talking, how good is that in terms of being comprehensive?
Was that helpful, you guys?
Absolutely.
That was helpful?
Honestly,
okay. Good.
I've been doing this meeting 15 years. Of course, you know how I feel about Dr. Scholz, but she's my, let's see, I'm trying to make this, you're my Dr. Scholz in Michigan, right? I mean,
thank you.
Yeah,
what an honor.
It's that, and I hope you come back soon because I know you have to go today. So let me give you a quick update to the audience. Go to slide 5, please. Her slide 5. That's I love that slide. Ooh, I love this slide.
Says it all.
This is like a game show. It's like it's like picking. All right, can we talk about before we go into this slide? No, I'll talk about this slide right away. Here's the controversy.
Yeah.
Lutetium, so here's our newest approval. Last year we're jumping up and down. We're like, this is unbelievable. We're going to get this, and it works. It works. And now will you tell them the story? I'm trying not to, and then just tell them what we should do with that story.
Does anybody know that there's a story? Let's start there. Or is he just talking about what he's worried about? Raise your hands if you know there's a story. So right there, see, Dr. Moyad? A lot of people don't know there's a story.
There's a big story, and so I want you to tell them.
Yeah.
Please.
So anytime we get one of these drugs, the first question is, okay, great, thanks for doing the study. Okay. The second is, when can I get it? Right? So pills, you go to your specialty pharmacy, it might take a week or a month, but usually these companies know, like, you get an approval, everyone wants it, so let's go. So it's just, again, back to cars, because I'm from Motor City. You get a new car, ooh, I want to get out there and start test driving. So lutetium-177 has been, really on the cusp for years. So this has been a topic for advocacy, this has been a topic for patients and imaging and so on. So we finally got it approved, and they had one of what I would say an extremely rocky start, because somewhere along the way, who's ever figuring out supply and demand didn't get it correct. So if many of us in the room know that we have an imaging and you're lit up like my patient and you want the drug, I, as your doctor, should be able to refer to our radiation doctor so that he or she could prescribe the drug and we're on our way. And because everyone is doing that, there's no supply. And the no supply is not just US, but worldwide. So the second hiccup is just communication. So what are we doing today? We're communicating with one another, talking to one another, sharing. The communication from, unfortunately, the company has been quite sparse. So we are kind of talking amongst ourselves, almost like, okay, I've got 5 slots, what do you got over there in Grand Rapids? And what do you got over there in Ann Arbor? And we're kind of trying to negotiate, and what we found out recently is anybody who wants to start today cannot. There is not enough supply. The only supply that is available is if Dr. Moyad is started a patient and there's 6 treatments, you have to commit to the full 6 treatment for the person who started. That means if you are a patient who's eligible for it today, you cannot get it. Now, if you just heard me talk today and we're excited that there are options, how is it that one of the biggest options that's available is really not available? It's really unacceptable. And so at this moment, we are extremely worried, have had ad nauseum conversations with the company, which is Novartis, and this is not a mystery. I know those of you who may know Novartis, they do great work. It's just the planning of it was so incredibly poor between the lack of access, not enough, they actually are building 2 new centers. 2 new centers, who's done building anything? You build a house, it's gonna take a long time. These are nuclear grade isotopes. You're not gonna just do this and stock up a bunch of pills. This is real challenge. Now it becomes not just an access issue, but now we have disparity in prostate cancer, we just talked about, of which groups are not getting the best treatment, who's got the highest mortality, and now we don't even have access for those who are in underserved communities like the one I serve in Detroit. So the levels of just unacceptability just keeps growing, and that's where we are.
So we don't expect to see this drug administered for many more months, so people who qualify for this drug need to talk about all these other options ASAP.
Correct. So why this is important is I never focus on what I don't have. So you've been educated, now you know. But what else do we have? So I gave you how many trials are available. There's the box. Many of you don't even know the drugs on the box I mentioned. Ask that of your doctor. So there are alternatives. Don't get hung up on this is what I want and I can't get it. We'll be stuck there a long time. Okay. My estimation is 6 to 9, if not, my realistic estimation is 1 year.
Clinical trials. Here is what I would say to you. You've got almost 1,000 clinical trials. So if I'm a skeptic, I'm saying, I don't want to get stuck in some trial where someone's experimenting with me and we don't have any data, or if I get a placebo, what's the point?
Yeah.
So can you just answer, I know you're excited about clinical trials. How do I get excited about clinical trials or get excited about finding a trial that works for me since there's 1,000?
Yeah, 2 things. 1, you have to make sure you're eligible for the trial. So although there's a lot, for where you are right now, there may be only a handful, and it may not even be in your neighborhood. So you got to even figure out what's the question. Number 2, most trials, especially if you're in the green box, no placebo. That is unethical. If you had spread disease, that's not ethical to have placebo. And number 3, every single drug, well, that was on the screen, was on a trial at one point. So you don't know if it's going to work until you finish the trial. So there is a sense of altruism that you have to have. This is going to help the next guy. So that's a lot of it with trials.
Yeah, and do you find that if I go into a trial, the trials you're working with, do you find that if we see something working, can I cross over? Can you explain that a little bit?
Yeah, so a lot of trials are built like Ford makes great trucks, I'm going down this way, and Chevy makes great trucks, I'm going down this way. If at some point we find out, don't kill me anyone from the car company, Chevy makes better trucks than Ford, then the question is, well, should then everyone get the Chevy truck?
Well put.
Some trials do that and some do not. But your recourse is, okay, well, I'm not staying on the trial, get me off that trial and I'll buy my own Chevy truck. So you don't sit there getting told what to do, you actively participate. At any point you're not comfortable, we say stop. Any point you don't feel good, you say stop, time out. Perfect. Trials are there to help you. It's not to tell you what to do, it's there to help you beat your disease.
I want to talk about bone drugs.
Yeah.
So a paper came out a few months ago in JAMA. It said men on hormone therapy, according to this database, less than 10% of them get screened for osteoporosis. And if they get screened and they go on a bone drug if they need it, it reduces the risk of fracture. And I looked at this paper, which I have, and it said less than 10% of the men on hormone therapy are being screened for osteoporosis. Is that true?
That is true.
So what do we do?
Well, let me ask you, how do you screen for osteoporosis? Anybody know? Is it a questionnaire? Yes, sir. DEXA scan. Who's ever heard of a DEXA scan? Okay, should be all of you guys in this room. So women know, because we get screened for osteoporosis all the time, you know, as we age as women, we lose bone strength. With men, because you're now in a forced menopause state, as we were talking about, it's really important to know your bone density. Now I have to tell you, Medicare will usually only cover it every 2 years, but either your primary care can do the screening, which is perfectly fine, or your urologist or your oncologist. If you're on any type of hormone drug, injectables, orals, you need this test done, because we can take one of those, either one in the green box, to help strengthen. Because what's the worst thing that'll happen? Fracture. And when you get a fracture, it hurts and it limits your lifestyle. So let's not get a fracture. Now that's, again, you always talk about vitamin D and calcium and all those nutrients and, you know, some exercise as well to help strengthen.
Yeah.
But it's the same thing. We have studies to show these 2 FDA-approved drugs help.
Yeah.
But it's not being administered. So what can you guys do? Advocate for yourself and ask, hey, is this something important? Now the other part that somebody will bring up, because this always happens in conversation, is, well, I don't want this thing to happen to my mouth. So it is a very small percent of people have what they call ONJ. and that stands for osteonecrosis of the jaw, which sounds horrible. Because it can be horrible if not managed, and our dentists really don't like this drug, but they'd rather know that you're on it so they can follow along with you on your dental exams than you not being on it at all. And all it means is just the gums kind of erode so you get to see the bone. The fix, stop giving the medication and it should be fixed. So it's empowering yourself to know that is a very small side effect, but something you should know about.
Great. Now, yeah, people ask me to do a lecture on deficiency of vitamin D, and the title of my lecture was, there's not a deficiency of vitamin D, there's a deficiency in DEXA. I just thought that would be a cute saying to get people to remember to go get their DEXAs done.
Yeah.
That has virtually no radiation, and it's safe, and that's how women get diagnosed with osteoporosis too.
Yeah.
Okay. Can we talk about genetics now?
Yeah.
So here's the two genetic drugs you talk about, olaparib, rucaparib right here.
Yep.
So are you saying that anybody, okay, there's my opinion, and I want to know where it's going. Are you saying that anyone diagnosed with prostate cancer today in the audience should have this genetic test done, the BRCA test?
Yes, so let's talk about the test.
Okay.
There's two types of ways we think about genetic testing. There's what you got from your mom and your dad that makes you you. So that is your original blueprint. You had nothing to do with it except that's just you. So that is what we call an inherited panel. Now there are 1,000 companies doing these kinds of testing. Most of us know that BRCA1 or BRCA1 and 2 have a family of about 10 other cousins. So people get confused, they're like, but I had my BRCA1 and 2 test done. But what you really want is a more comprehensive panel because you want to catch all 10 other family members, all the cousins. So what's like a cousin? PAL-B2, so literally PAL-B2, CDK12. These are genes most people in this audience have never heard of. But if you have one of those cousins be positive, you can also get the treatment in the red box. So everybody's like, well, I don't have the BRCA, I have RAD51. Okay, you're eligible. So that's confusing, right? You're like, wait, you just told me it's a BRCA. Right, because we put the bucket of inherited genes as only BRCA1 and 2. That's one. The second piece is you don't have that. So you're gonna say, well, how many people have that? So in what you get from mom and dad, it's about 10%. Okay, so that means 90%, your blueprint doesn't have anything that you have to worry about. But for the 10% of you that have this, you're gonna pass it on to the next generation, potentially, and then they may pass it on to their children. So if the one thing you do right, which is check yourself if you've got metastatic prostate cancer or high-risk prostate cancer, then you know whether you pass it on or not. And there are genetic counselors. As you can see on my team, I have genetic counselors because it's not up to you to explain it. So I had a patient say to me, I don't want to get the test because I don't know what that means for my family, and I literally have like 12 grandchildren. I go, that's not up to you. You will have a professional help guide you to figure out what do you do next in terms of talking. And families come in all shapes and sizes. So these are, again, for blood relatives. So you might have, stepchildren and blended families. These are going to be for blood, generation. Now, your cancer does things all on its own. So cancer itself, meaning it's not something I'm passing on, but now my prostate cancer, let's say in the liver, is getting tested. I can blueprint that today. How? Sometimes we take a sample. So sometimes your doctor's like, I'm going to take a sample of your liver and then I'm going to send it for blueprinting. I could tell you that sometimes it's 18 to 20% of the time that cancer has something in this family. That's 20%, you guys. 20%, that's a high number for people to be able to directly get those agents in the red box. So 10% that gets passed down, 20% that's only in the cancer. So most of my patients have it in their cancer only and not in their original blueprint. So their kids and grandkids are fine, but they themselves, we have a different path forward because now we know his particular cancer. There's some of you who say, well, I don't want to undergo a biopsy. You know, the needles, I don't want to do it. They now can do liquid. So you take tubes of blood, and we can then check that. Now that is a super complicated lecture, will take us a week to go through. But there are whole companies, and we partner with many of them. You literally take 2 tubes, and they check the DNA from these cancer cells floating around from your original prostate to the lymph nodes to the liver, and whatever is shed around in the bloodstream, we can capture that on the blood test. Guess what? That's blueprinted too. So we call that liquid biopsy. So tissue biopsy is only for the person. Liquid biopsy is only for the person. And then blood testing or saliva is to know your original blueprint. Does that help?
That makes sense. I can tell you stories of primary care doctors, and here, other places, they said, what's liquid biopsy? I called any random company, the company called them, they were offering it themselves, you know, within weeks later to the prostate patient. So you think that everybody should at least have that discussion, about getting that genetic panel done. And that makes me happy, because I just cannot believe how underutilized those tests are.
And it's also, your inherited is a one-time. So if your doctor did it 5 years ago, that's the same. You're still you from mom and dad forever. You only need that once. The stuff in your cancer, if you're in the green box, can change. So how you were 2 years ago is not how you are now. These cancers like to, you know, kind of pick up a lot more genetic mutations. That's how they get worse. That's how they know how to escape a bunch of routes. So you can get repeat testing on those.
And the results you see with those specific drugs, the people who are BRCA positive, have you seen like really robust responses with these new drugs?
I would say the #1 sort of leader in that family is the BRCA2.
Okay.
So those are the folks I see the most response. And I mean like, 3,000 to 10, that kind of thing. Yeah. The other family members are so-so. So the one that's getting a lot of traction in our field is ATM. Really tough, because we're not sure if that should be a family member that's, you know, we don't know if that's a slacker in the family, just sort of like, hey, I'm here, but they don't really, you know, there's no real activity. But that's the chatter on the science end. So you hear, well, my doctor said he was talking to another doctor, and then she said this, and da-da-da. Don't worry about that. So that's on us. Sometimes we almost think out loud too much, and then you guys get stuck into that conversation. And you know, when people talk, they talk, and then you're like, so at the end of the day, what does that mean? You can say that as patients. You can say, that's great, I'm glad you guys all had a blah, 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 but what's it mean for me right now? So if I had a patient with that mutation, until there's really new data that says no, I would offer it. Because you know what? It's like anything else in our world. We give it for a little bit, it doesn't work, you're gonna know. You're gonna know. It's not like you're signing up for 2 years. You're gonna know by the time you check the next PSA.
Great. Before I ask you the last few philosophical questions, we're going to talk 2 more topics. The first one's chemotherapy. Chemotherapy is really weird, strange to me, because there's perception and reality. Can you tell me who qualifies for chemotherapy, and maybe you want to throw in your opinion of why it still just gets such negative perception in the field, when I don't think people realize its use is expanded and it's actually doing more good in a lot of places. But I don't want to. Tell me your thoughts on who gets chemotherapy and how to look at it from a more positive standpoint.
Let me just take a quick poll. Who associates chemotherapy with something bad?
I used to.
Okay, now I get the whole room to raise their hand. Finally, towards the end, you all raise your hand. Because whether it's media portrayal or their family experience, you know, whether you are a bone marrow transplant chemo person stuck in the hospital for 3 months, or watching a movie from the 1990s where somebody's throwing up their guts, you know, into a bowl, to just that narrative has never changed. What got better? We have better drugs to control nausea, vomiting. The chemotherapy associated with prostate cancer is on the end of the spectrum where nausea and vomiting is not even in the scale. So we use drug like cisplatin for other cancers, platinum drugs. Those are the hard ones, but even those we can control very well with drugs. So as chemotherapy matured, all the supportive medicines along with chemotherapy got better too. Is it active? 100%. It is, to me, a missed opportunity if you do not get chemotherapy. I'm not saying you can't push it off, that you can't delay. Absolutely, you can do all that. But at some point when it's go time, and this is what I say to my patients, when it's go time, it's go time. It's literally once every 3 weeks for 1 hour. Aren't you surprised when I say that? Everybody has like, wait a minute, it's gonna be weekly and I'm gonna get all sorts. Nope, it's one lousy 1 hour infusion of one drug every 3 weeks. That's it. It is active. Don't put it away until you know you're not a candidate. So who's not a candidate?
Yeah, who's not a candidate?
You saw my scale. See how it's not a mystery? So if you're kind of more frail, or you're like, uh-oh, I've got all these other things going on that maybe has nothing to do with my cancer. People with really bad diabetes have neuropathy. This drug can make it worse. But in general, most people are candidates.
But do you have to wait for many courses to see if there's a response? Are you seeing, is it after 1 or 2 courses or cycles that you can see whether or not it's really taking? I mean, how do you approach that with patients?
I think it's usually you give 3 of these, so in about 9
3.
weeks you know.
Okay.
Yep. But guess what? You almost know after the first one, not because of the numbers, but because you'll feel better. Because uncontrolled cancer makes you feel terrible. No appetite, no energy, I feel lousy. Even if you're getting chemo and your cancer is controlled, you will feel better. People are often shocked that they actually feel better on chemo. Well, because you're killing your cancer, so you're controlled.
Are you telling me, Dr. Heath, that my quality of life improves on chemo if I'm getting a response?
Yes.
That's where I used to not like it, and then you realize that that's true, right? I mean,
it is.
It's the perception and reality in prostate is painful. Okay, thank you. So I've never talked to you about that.
Yeah.
Immune therapy. Okay, it's not just the COVID stuff going on, the mRNA stuff. The Moderna's got stuff going on in cancer. We've had Provenge.
Yep.
So can you make a comment on Provenge that a lot of people could qualify for now? Yep. And then tell me about these new special immunotherapy drugs, and how I would get one for me.
Okay, so the purple, Sipuleucel T, is FDA approved. It's been approved since 2010. That's you getting treatment that the cells that we take out of you gets rejiggered and excited and taught to see the cancer, gets reinfused. Complicated, right? You think vaccine, it should be an injection and I'm done. But there's a process to that medicine. What do we know? For the right person, it works. And who's that right person? Those with minimal metastatic cancer, kind of like right in the beginning of your green box journey. Oh, my PSA is 6. I've got a few spots. I feel great. I'm still coaching Little League. Like, what's the problem? No pain. That's the right group. And if you're African American, that's the group that has done the best. Now, I got to tell you, we've talked about disparities, how, the numbers are worse for the black men in our community with prostate cancer. That's the one drug where it's actually better in that particular group. Never seen before. So I see a lot of men who are African American in the Detroit community. That is on my list of medicines to offer, but it's not for everyone. It's not for the person with uncontrolled cancer of 3,000 PSA and feels lousy. Not that PET scan you saw. That means it's already too far away. Now, the next in line is everything else, the pembrolizumab, which is Keytruda, the nivolumab, which is Opdivo. These are things on commercials. You see it for lung cancer and so on. Doesn't really have any role in prostate cancer right now. And all of those trials, they were a bust. They added nothing to you just being on a pill. So that we know. 5 years ago, we didn't know, now we know. CAR T is very, very specialized. So the hyped up sort of next generation version is, how do I get my T immune cells to go find the cancer? CAR T is really only for very specific few. CAR T, you have to get chemo like you're about to get bone marrow transplant. Big doses of chemo to almost wipe out. So I have patients undergoing CAR T in Detroit. What I say is, it's like when your computer is so messed up and it doesn't matter how many times you try to fix it, sometimes all you got to do is go to the wall and go, wait 30 seconds. That's what you do for CAR T. So we wipe out your bone marrow with big doses of chemo, get the slate clean, and when your cells come back, Then we reinfuse the rejigger T cells, and that is the most aggressive way that we can think about immunotherapy for prostate cancer. But think about it, for you to get that level of chemo, we really need to be fit, not have a huge heart condition. You're in the hospital for several weeks, really intense.
And what's the biggest breakthrough you think is coming down the pipe? And I say, in my world, because there's so much cancer in our family, down the pipeline means in the next 12 months or 6 months. Like what area is getting you so excited that could be a breakthrough that we have to be watching? And this is not a stock tip.
No
People
stock
always
tips.
ask me, this is the same I dealt with my family. We were always looking at trials.
Yeah.
What are you excited about?
I think the next wave is not really immunotherapy or targeted agents and so on. I think it's actually in the world of theranostics. So the PSMA is one target, but that world has a gazillion targets. And it's this idea, if I can see it, I can design a drug and then you can treat it. So there are many, so if you look at all the companies out there, it's not just PSMA.
Yeah.
And also for the record, it is in prostate patients, but PSMA is expressed in all sorts of other cancers, not to derail the crowd, but that is a head scratcher. I thought it's only in prostate. Nope, it's in a whole lot of other cancers. But there are targets that can be imaged that then you can design a drug, a payload, you come in and kill it. That's truly personalized medicine. I hope we get there.
Wow, I mean, that's quite a plug for our next speaker. I didn't even know you were going to say that. All right, don't leave. I got her gift. So last question. Ready?
Ready.
And then I give you your gift. So what you don't know is that we are on a couple boards to try to get free health care to men. We do that big thing, the screenings at the Lions Stadium. Yep. Thousands of men get free screenings. And so we're involved in a lot of volunteering. And then so a number of people we work with get governor's awards, like the highest award. And so one of our colleagues got one recognized by our governor this year for outstanding service. And I'm reading the list of people who won governor's award, and one said Catherine Heath. And I'm like, who? What? Can you tell me who Catherine Heath is, who got a governor award, and how old she is?
Oh boy, yeah, so that's my youngest daughter. She's actually a junior at Duke University. Go Blue Devils. But she is a really STEM diehard, even though her major is in public policy. When she was a high schooler volunteering in Detroit, she said, you have a problem here, Mom. I said, that's never good for a dinner conversation. She said, I have options to go into the clinic and meet all these people and help. Where are my peers? So she created a program called Focus STEM Next Gen. Visit the website. It is really a way to engage our high schoolers to be excited about science and healthcare. And we've done everything from in-person programming that she made us do, because we all work for Katie, and moving into the virtual space because of the pandemic, and now we're actually on the metaverse. So creating programs and really encouragement for those in Detroit, which most of those schools are 90% free or subsidized lunch. So a really compromised group. And my daughter was and still continues to spearhead this so that everyone gets access to that type of awareness this early.
So she got recognized by our governor, so it says a lot. And,
thank you.
And so now she's destined to become a prostate cancer oncologist, right? That's the pressure. So I leave you with this, but we're going to send it. I'm not going to be taken on the plane because it might break.
Right.
You and I are out of towners. We don't know this Hollywood thing. I just come in here twice a year and wow. And I thought, what's appropriate to give Dr. Heath for her first visit here? Because this is another way of making sure you show up again in a year or two for the big work conference. And I thought, let's give her an Oscar.
Oh, wow.
It says Elisabeth Heath, Oscar for Best Oncologist Ever, PCRI.
Oh my gosh.
There you go.
Seriously,
Thank you.
guys. Thank you.
So we got to escort Dr. Heath out, so otherwise Delta Airlines is going to be upset with me. All right, so
I'll get that.
Thank you again.
so much, everyone.
All right. I just really wanted this to make it happen one day. There's a guy in the audience named Dan Epstein, Mr. USC. He's been a part of this thing since day one. He's been great to the organization, and we put this all together. I'm telling you, this is a really special moment to see 10 celebrities, I think it's a total of 10, come together for this conference, and they're very loud. They talk in a loud manner. They're just very loud, so if it's too loud for you, you can always cover your ears a little bit, but this is going to be a great moment. So if the celebrities are here for their 10-minute to say hello, can we get them to come out? Ladies and gentlemen, the USC Marching Band. Thank you so much. I really appreciate it. I mean, I can't tell you how much went behind the scenes and with Jeff and to get the team here. And they have so many events. So we had to sneak it in during the time that the celebrities were free. And to me, when I come out to LA, you know, coming from Michigan and the marching band there, I mean, these are the celebrities. I mean, they're an incredible talent. I appreciate you very much.
Thank you very much.
Absolutely.
Let me just say a quick word of thanks, too. I was in the USC marching band at one time, and I played trumpet, not like this gentleman here, but but it just harkens back to such great memories. Thank you so much. Mark never tells me what's going to happen, so this is a total surprise to me, and so you guys are awesome. Thank you.
Thank you.
Thank you.
Thank you, Dr. Heath, and thank you, Dr. Moyad. Before we move on, I do want to thank our sponsors, Bayer, MyEvent, Pfizer, Astellas, and Dendreon, for helping us put on this conference. It's thanks to them that we're able to make it free for all of you. Also, please, if you would like to donate, PCRI is a 501c3 nonprofit, and you can donate at pcri.org/donate, and that helps us keep this cause going and keeps our conferences free and all these videos on our YouTube channel. Now we're going to go into PSMA imaging for prostate cancer, and we're going to talk about Pluvicto, or lutetium, which is a big topic in prostate cancer right now. And we have an expert in this field discussing this topic. His name is Dr. Johannes Czernin, and he is the chief of the Amundsen Translational Theragnostics Division for UCLA. He's an incredible speaker because he breaks down what PSMA is, and he's also able to tell us updates and what's going on with Pluvicto. And Dr. Moyad and him had a great discussion on this. I'm sure you're going to find it informative. So without further ado, thank you, Dr. Johannes, for joining us at our 2023 conference.
Thank you very much. It's a great honor for me to do this. I think very often we can learn much more from the patients than the patients can learn from us, because you know the disease much better. I'm an imaging person, but I was trained in medicine. And now we're, of course, branching out from just imaging to also therapies. So I'm actually going to talk about both the diagnostic part and the therapeutic part, because I think many of you have read about Pluvicto and the treatment of prostate cancer that we can do with radioactive PSMA-targeted substances. These are my conflict of interest disclosures. So this is the overview of what I'm going to talk about. The first one is talk about a little bit what is PET-CT, what is best imaged with MRI, ultrasound, PET-CT in prostate cancer, bone scans. What is PSMA, which I think is important for you to know. And then I talk about the diagnostic story. How did this imaging assay, this tool come about, become so successful and so important in helping patients with prostate cancer? And then the PSMA therapeutic story. We have treated more than 250 patients with PSMA targeted, what is called radioligand therapy. Then, of course, I want to talk quite a bit about frequently asked questions, and I hope many questions will come up in the end. But what the process is, how is it done, what's the effectiveness, what's the safety, what are the side effects, and so on. And then talk about challenges. And there are, of course, challenges with the rollout of these new treatments, and I want to address some of these concerns and problems. So what is PET-CT? PET-CT consists of a CT scanner, CAT scanner, and a PET scanner in one machine. And you can acquire simultaneously the anatomy of the body, and you can look at metabolism or expression of some target, such as PSMA, which stands for prostate-specific membrane antigen. We inject a radioactive tracer. That is a very low radiation dose that we give to the patients, perfectly safe. And then we get these images that show a CAT scan, a PET scan, and we fuse the images so that you have a combination of the anatomy and what we call function sometimes, or molecular information. With PET imaging, you can look at various aspects of the disease. Here I show some examples of different PET tracers that have been injected into patients, and they will give you different information. You probably have heard about the Axumin scan. This is something that was approved before the PSMA scan by the FDA, and it allows you to image amino acid utilization of prostate cancer. How much amino acids does the prostate cancer eat, and where does the consumption occur, where in the body? Then you see the PSMA scan as the second one here. Many patients have had FDG PET-CT scans, that's glucose metabolism, so we can look at glucose metabolism. We also can look at lipid metabolism, that is important, how much fat does the cancer consume. And we can look at calcium metabolism, that's the bone scan. Each of these scans gives you different information, and the ones that are now really used in prostate cancer are this one, Axumin, and then PSMA, and then to a certain degree, of course, still the bone scan. What is MRI used for? MRI is really used mostly for detecting the site of the prostate cancer in the prostate. It will also give you some information of regional lymph nodes, and it can also be used to look at distant disease in a targeted way. But that's the most important indication of MRI, is really looking for diagnosis and localizing the prostate cancer. And the ultrasound is used to guide the biopsy. So you insert the transducer, and then you have a needle attached to it, and then you do the biopsy, and it is a targeted biopsy based on what you see on the ultrasound, so that you don't get randomly into the prostate. And now a little bit about this term theranostics. You have probably heard about theranostics. The term gives it away. It's a combination of therapeutic, thera, and diagnostic, ostic. So you have a therapeutic component and a diagnostic component. And the interesting part is you can label or mark an isotope with a diagnostic or a therapeutic isotope. And this is shown in this diagram here, where you have therapeutic isotopes labeling one molecule, but you can do the same with the diagnostic isotopes. You can get PET images, and you can treat the patient, and you can target it to some structure that is sitting on the prostate cancer cells. It's like a smart weapon that seeks out the cancer by looking at a certain structure that is expressed by the cancer. So this would be a diagram or example of what a prostate cancer cell looks like, and that has on top of it sitting PSMA, in this case, prostate-specific membrane antigen. And then you have a molecule that is labeled with a diagnostic isotope for PET imaging. And then you have the same molecule labeled with a therapeutic isotope, in this case lutetium-177. And then this compound finds the prostate cancer cell in the body after it is injected into a vein. And then it gives you this image. And what you see in red here is thresholded out prostate cancer metastases. So then you can see where the disease is, and you can treat with the therapeutic compound and sometimes get these spectacular results. This is not a fake image, this is a true image. This is the disease before the treatment. This is near complete absence of disease after treatment with the radioactive compound. So you have one molecule to see, the same molecule to treat, just by labeling with a different kind of an isotope. And this is how it is done in a very simplified way. It's a simple injection into a vein. And we talk later about what the side effects are, what the process is, and how this works. This is not new. This is actually, I took that from an article, and that was published in 1949 in Life magazine. This is a patient with thyroid cancer. And you see the patient before the treatment with radioactive iodine and after. Now, we do this all the time in the clinic. We can take an image of the thyroid and look with radioactive iodine, and we see the extent of the disease, and then we give a different iodine isotope, and we have the patient swallow that, and then it will treat it. And the outcomes are really often like this. You see the patient in very, very dire straits here, and then completely recovered years after the treatment. That was kind of the first theranostic approach, the first really targeted radiation approach that was used successfully in patients. I'm not going to talk too much about the biology of this because it's kind of interesting. This was found in the prostate-specific membrane antigen, PSMA, was discovered already in the 1980s. And the function is still not very well known. But what we do know is that it is associated with promoting tumor growth and tumor aggressiveness. So it is something that when you have a lot in the body that lights up on the scans, that it denotes that you have to do something about it because the tumor is more aggressive. The story actually with PSMA-targeted therapy and diagnostics started in Europe, I would say maybe 10 years ago or so, when a compound that actually was developed in the United States by a guy called Marty Pompa was rediscovered in Germany, was modified, and then given to patients to diagnose prostate cancer and to start treating prostate cancer with the substances that I showed you. In the US, things are different. We need to go through a very orderly approval process. We have to go to the FDA. We need to do all the prospective studies. That was not the case in Europe. They simply said, fundamentally, this is safe, so we can try it. And that set the stage later on for a huge wave of centers opening up in Europe, Asia, Australia, where people could already get the scan and get the therapy, the PSMA-targeted therapy, and people from all over the world would go there to get this treatment. This is shown one example how this was dealt with and promoted in Europe. This is from the University of Essen in Germany, and the physician is a person who actually came from Germany to teach us everything about PSMA several years ago. I want to show you now some of the studies that led to the FDA approval, because these are studies that UCSF, Tom Hope, and we did together, and I think that's maybe one of the more important things that I did in my professional life. So that I want to show you some of the data that kind of justify the success of PSMA-targeted imaging. The first study was done in patients with intermediate or high-risk prostate cancer who were scheduled to undergo surgery. and had every test before that. They had bone scans, they had a CAT scan, and were qualified as surgical candidates. And in these patients, we then did a PSMA scan. The idea was the patients then go to surgery to find out whether what we see on the scans is really correct by histology. So these patients had essentially everything. And then when they went to surgery, the surgeons found disease, additional disease, which we detected with a pretty good chance to detect it. We call it 40–50% chance to detect it with the scan before surgery. And that implies that if you do the scan before, you have a pretty large number of patients that shouldn't undergo surgery, but where the treatment should really be something different. Now, overall, about 25% of the patients had disease when we imaged them. In those patients, no disease was known before we did outside of the prostate was known before we did the scan. There are two compounds now that did a very similar study. The one, gallium PSMA-11, is used at UCSF and UCLA. It's an academic, non-commercial substance. The other one is commercially available. It's called DCFP-YL. And they give you very similar image information as shown here. Here you see where the arrow points to a tiny little lymph node that was detected, again a lymph node in a patient with intermediate risk prostate cancer. That's something that is really, really important to optimize patient management. You get exactly the same information from both scans. So if you ask, why don't I have a PYL scan? Why do I get a PSMA-11 scan? It gives you the same diagnostic information. We still miss microscopic disease. If it's too small, then we can't see it. And some of the prostate cancer lesions have a low expression. They don't have enough of these PSMA receptors on the cancer cells that I talked about. Then we can miss disease too. So that was one important study that was done, and you saw it was done in 277 patients. And I also want to mention these studies were only possible because patients paid for the scan. So there was no mechanism to get this paid for, no NIH funding, no other funding to do this. So we're very grateful for the patients who were willing to pay for these scans. This is an example of imaging before radiation treatment or surgery. This was a comparison between bone scans and CAT scans and PSMA scans. And the data in the nutshell were that you have higher diagnostic accuracy, see more, and it's more accurate with the PSMA scan. It's very well tolerated, and it has an enormous impact on patient management. So the recommendation now actually is to, when possible, to replace at least the bone scan with a PSMA PET-CT scan, because you get all the information on the PSMA PET-CT scan. The second important imaging application is when patients had definitive treatment, either surgery or radiation, and the PSA starts creeping up. PSA starts rising. It's called, as you know, biochemical recurrence. The cancer is somewhere. Hopefully at a very low level we can detect it. And what this graph here shows on the left side is how often can we detect the site of the recurrence, because then you can go after the site, either with targeted radiation or with surgery, or you start systemic treatment, or whatever the management of the uro-oncologist is that is considered most appropriate. So here on the left you see that when the serum PSA, the blood PSA, is less than 0.5, which is very low PSA level, as you know, we already detect about 40% of the sites of the recurrent. And as the PSA goes up to, let's say, above 2, detection rates go up to 80% or even higher when it's above 5.0 nanogram per milliliter. When PSA is 5, we detect almost all of the sites of recurrence. Again, this is important because you can address and treat what you see. On the right side, you see two examples of this in a patient with a PSA of 1.5. After definitive treatment, you see the sites of recurrence in lymph nodes. These are the little dark spots that you see there. And on the right side, a PSA of 2.3, where you see on the right groin, you see, or pelvis, you see the sites of recurrence. That has a tremendous impact on management. And we will not dwell on details here, but when you look at the text, we looked at the impact of the imaging on the management of prostate cancer patients. And this is done by doing a questionnaire, sending a questionnaire before the PET scan. What would you do without the PSMA scan? How would you manage the patient to the physicians? And then 2 questionnaires after the PSMA PET scan. How did your management change? And how did your treatment change? These were the questions that we asked. And so here the answer is written out, spelled out here. The impact on management change in management occurred in more than 50% of patients. So that's a really, really decisive impact on how prostate cancer is now managed when compared to before. So these are the men in black. So we went to the FDA, and we got FDA approval after, I will show you the tortuous pathway to this approval. But in December of 2020, we got PSMA approved by the FDA. In September of 2021, it was included in the National Comprehensive Cancer Network guidelines. It's now part of it. In November of 2021, it received Medicare coverage, as did the PSMA 11, so it's now insurance covered. Medicare and most private insurances, as you know, it's always a fight, but we will help with this as often as we can. And then it's included in the Society of Nuclear Medicine guidelines and so on. So this is now fully accepted, approved, reimbursed, and recommended. So this is the summary on the imaging portion of this part of the presentation. We can assess the extent of the disease after diagnosis and after treatments, which is called staging and restaging, with a high accuracy. And the data are really robust. This was really well done studies. There's no ifs and buts. It is what it is. The numbers are rock solid. We can identify the source of rising PSA. This gives the treating urologist, uro-oncologist, actionable targets. You can really do something about it, which is really important information. And we have an impact on management. Now, the key question that is still not answered is, do we have an impact on outcome? Do patients live longer? Do patients live better? And that's something where many studies are ongoing. We still have to wait for the results, and I will show you 2 examples of the studies that are ongoing here. This was a study done at UCLA, and just to explain this a little bit, this is done in patients who had a very low PSA, biochemical recurrence, and the spots that you see here in the pelvis would be the ones that are targeted by standard radiation in the site of, at the time of rising PSA, standard pelvic salvage radiation treatment. But everything that is outside of the pelvis would not be in the radiation field. So that would imply that the radiation is not going to be very successful because too many lesions are outside of the standard radiation field. And that occurs in about 20% of the patients. So there's a second aspect to this study, and that is that we are now collecting, we did a randomized trial where radiation treatment was either based on PSMA imaging or not, or conventional imaging, and we look at the outcome, which we probably have the data within 2 years to see whether this affects patient survival. So I think that's an important study. And the other one is this here, that we try to improve targeting for surgery, radio-guided surgery, where we inject the radioactive PSMA ligand before surgery, and then the surgeon go in and they use a probe to find lymph nodes that have a lot of uptake of this, and then can selectively take out these lymph nodes. And the idea being that if you do this, you will eradicate more of the disease that is in there than if you just go by your standard approaches without knowing whether there are metastases involved. So then there are frequent patients' concerns after imaging. One question is, am I radioactive? And there's a tiny bit of radioactivity, but it is orders of magnitude lower when you think compared, for instance, to external beam radiation. So there's really no worry about radiation if you come out of an imaging study. It's not dangerous. Can I be around children or pregnant women? Yes, you can. Can I eat anything I want before and after the scan? Yes, you can. Can there be false negative scans where there is disease but we don't find it? Yes. I mentioned that. They are small lesions, more likely when the blood PSA level is really low. These lesions that don't produce a lot of PSMA, or it's tiny little lymph nodes that just are below the resolution of our scanners. Can there be false positives? Something lights up, but it's not prostate cancer. Yes, that can happen too. It's really rare, but it can happen. We talked about insurance. Does insurance cover the scan? Yes, it should. We try to work with patients on referring physicians on pre-authorizations if there is a problem. But it's in all the guidelines. The evidence is there, so they should not deny payments for these scans. How many PSMA scans are performed per year in the United States now? It's approaching 200,000 per year. And the estimate is that it will reach probably a peak of around 500,000-600,000 once it's more available throughout the country. Now I want to talk a little bit about the therapy studies leading to the FDA approval. How effective is PSMA-targeted therapy? And this is a therapy that is provided and distributed by Novartis. And it has the brand name Pluvicto. Don't know whether that's the best name, but it's the name. So there were three major therapeutic trials. The one was from Australia. And what these graphs show, when you see the 57% number in the Australian trial, that means 57% of patients who were treated with this lutetium PSMA or Pluvicto had a drop in their PSA, blood PSA by 50%. That was a small study. We did a slightly larger study, prospective study, but also too small. At UCLA, we had close to 40% response, which we call PSA response, again, a drop of PSA in the blood by 50%. And then came this large trial on the right, which is called the VISION trial, which led to the approval. They found they looked at outcomes, they looked at survival, and they found that in patients with metastatic prostate cancer who had every treatment before, hormone and chemotherapy, the survival benefit was more than 4 months. But what is important, what you see here is that if patients respond to the treatment, then they will live about a year longer than the patients who do not respond. So it's always a question, you have about 50%, 40% responders. The responders have a significant benefit in terms of survival. And then there's the first trial that compared a taxane chemotherapy that is shown here. It's called the therapy trial. And in these patients who were either receiving a taxane chemotherapy or our PSMA-targeted radioactive treatment, the radioactive treatment was the winner in every aspect. And in terms of better tolerated, better PSA response, and longer progression-free survival. The quality of life also is important. So then, again, the FDA approved the PSMA-targeted treatment. You see that at the bottom here. And this is now also, in the meantime, part of the NCCN guidelines. It's Medicare reimbursed, and thereby it should be covered by all the different insurance companies. So currently, we're only allowed to use the treatment in really late-stage patients after chemotherapy. And there are numerous studies ongoing at any stage of the disease, even before surgery, as a kind of neoadjuvant setting where this radioactive treatment is given to find out whether it's actually better and more effective to give the treatment earlier. And I don't want to mention all these different trials that are underway, but there's a whole bunch of these trials coming, and it will probably take several years till we have all the outcome data here. This is what I want to show as the outcomes when the treatment is successful. Each of these pairs that you see has a pre and a post-treatment scan. The red denotes the cancer. On the numbers show the pre-treatment blood PSA levels. You can see that they are sometimes very high, like 900 something, and then disease almost completely disappeared. These are the so-called super responders. That's about 10% of the patients. That is by no means the standard. I just want to show you the best case scenario. And now I show you the worst case scenario. These are patients who are imaged again late during treatment, and you see how the disease progresses while patients are being treated. And we must be honest about this. We don't know why patients respond or do not respond to the treatment. We haven't figured that out yet. It's kind of the key portion of our research that we are doing to try to find out why some patients, or 50% of the patients, resist. This is kind of the extreme bad outcome. Often it's kind of a mix between disease stabilization and slow progression. So now, how is the treatment done, and how do we know if it's working? And then talk about safety, side effects, and frequently asked questions. So we do a screening procedure at UCLA. We do an initial consultation with the patients in, of course, close collaboration with the treating urologist. And the requirement are we need a PSMA scan within 3 months of the treatment, because we need to see whether the target is expressed. If you don't see anything on imaging, the treatment cannot work because there's no target. Patients need to have had chemotherapy, which is usually a taxane, cabazitaxel, or any other taxane treatment. There need to be at least one chemotherapy that the patient had. And there are certain lab thresholds, because one of the side effects is it affects the blood count. It can affect the blood count. We also need to know what is called the performance status. So patients still need to be mobile, need to get around, because if you get the treatment and you can't get to the restroom, then the radioactivity that is excreted through urine, that can become a kind of an issue and a problem. We also instruct the patients for some radiation safety aspects. But I want to show you in a moment, I think I'll show you a slide, that this radiation is really not getting far out of the body. It has a very short range. And we clean up the room, of course, where we do the treatment to have the next patient in a room that is not contaminated. What is this performance status? And I just say patients need to be performance 0, 1, or 2. That is, they have to be mobile, they need to be able to get around. I just wanted to show you what ECOG means here. This is our setup right now. So we give up to 6 cycles in intervals of 6 weeks. That's the standard protocol. We have a very, very primitive setup right now. And I'll show you where we are going with this. We have essentially 2 reclining chairs, and this is the real setup here. You see how the radioactive dose is sitting in this container that is connected to the IV line that the patient gets. And the patient doesn't stay more than 2 hours in our outpatient clinic and can go home, can self-drive, or can be driven home without any significant risk of any radiation contamination for family or friends. And the reason why this is so simple is because the radiation that we are giving is shown in orange here, has a half-life of almost 7 days, but as you say, it is blocked by aluminum foil. So it really is not something that reaches very far and is easily blocked, and patients are not a risk for the environment or for family members. What we do recommend is that while the radiation is not dangerous, but try to keep a kind of semi-COVID distance, like 3 feet, for 3 days. You can be around children, but keep 3 feet of distance. 3 feet is easy to memorize, keep 3 feet distance. The radiation doesn't get that far. You can eat anything you want before and after the treatment. You should take all the regular medication as advised by your physician, and the insurance should cover the treatment. And there are some tips that we give patients. Be careful with toilets, washing hands with soap and water, drink plenty of liquids because you will wash out the radioactivity. But it is really very, very safe. What are the most common side effects of the treatment? I think that's also important to know. And it's really the usual side effects. It's fatigue, it's a dry mouth because some of the radioactivity gets into the salivary glands. It's nausea. Change in bowel movements can be diarrhea or constipation. The blood count can go down, but it's really reversible. Taste changes can occur. Bone pain can flare up for a few days. And there can be, in very few instances, some kidney toxicity. But severe side effects in all the population studies were really extremely rare. A patient usually compared to chemotherapy that they had before, and they said it's no comparison. It's a walk in the park compared to that. So how will we know whether the treatment will work and when we stop the treatment? So this is my great artistic skill here, but you see how the PSA drops, and that's a good response. And in an ideal scenario, after 2 cycles, you should have a significant drop by 50% of your blood PSA. You can also do this here where it drops a little bit, and then we would continue treatment after 2 cycles and continue up to 6 cycles. And I want to mention that there are reports now that in Australia, one patient has received 16 cycles of this without any other health problems that occur through it. And then you have some where the disease kind of stabilizes and then ticks up, and others where it's really going steep up. And these are clearly patients that if that is the picture after 2 cycles, that the PSA goes up, where the treatment does not work and we should discontinue. And here's some examples what that can look like. You can have rapid non-response, PSA keeps rising, PSA rises dramatically, or you can have these extreme examples of complete response, PSA close to 0, even 0 after treatment. It's not always the same. Sometimes we wait for 3 cycles. Sometimes patients have great symptomatic improvements, less bone pain. Then we would, of course, suggest to continue the treatment. That's always done in concert and in discussion with the treating urologist, because that's kind of a team effort. The urologist will say, well, this doesn't work, let's move to something else. Why does it take so long? And you're not supposed to be able to read this, obviously, but I just want to highlight 2 things. The one is, this was 1987, and we got our approvals in 2020 or so. So in 1987, the target was discovered, PSMA, and it took us till 2020 to get this to patients. Why is this? The one is, it takes time to do the basic science to prove that it is of value and to do the clinical trial. The other issue is, of course, you need to go through the appropriate steps to convince the FDA that this is safe and effective. So that takes a very long time. And when you look at our work here, we started with getting data from Europe in 2011. Then in spring of 2016, we started our large clinical trials. And then again, it took us till 2020 to get to the FDA approval. This is actually a very fast approval process, because usually drugs from the base to clinic takes about 10 years. So we actually were quite happy that it worked that quickly. There are opportunities and challenges. The one is, every patient gets the same dose for the treatment, and that, of course, is something that is not ideal, but that's the way the FDA was approved. I think we could give more and higher activities that would be more effective to reduce the number of patients who do not respond. And how much target is expressed, we don't know exactly how these scans are best looked at to identify the patients who will likely benefit from the treatment. We don't know why patients don't respond. It could be mutations. It could be something that makes patient less sensitive to radiation. And it could be acquired abilities of the cancer to overcome or beat the treatment out. As in any other cancer, what is really important is to come up with rational combination therapies. It's not going to be a single agent treatment. We need more treatment centers. I think if you believe that we will have 40,000 therapeutic studies a year in the United States, then we need 70 treatment centers if each of these does 8 patients a day. So we are far away from having that. Of course, if we do 4 a day patients, we treat 4 patients a day, you need 140 treatment centers. So you see the number is really, really high. We need the workforce, And kind of ironic, when you look at this, you think 1,210 qualified workers is a very low number given the job market. But finding 1,200 people who know what they are doing in this very specific field is not easy. So that's an initiative that professional organizations are doing right now to try to find qualified technologists, nursing, radiation safety, front office, janitorial physicians. And then there is a demand-supply imbalance. The company is thus far not capable of robustly supply the drug, and patients are waiting. We have a large number of patients on the waiting list, and that's a real problem, because there's only one company, that's Novartis right now, that distributes this, and if anything in the supply chain goes wrong, then the patients will not get their drug. Within a year or two, I would predict there will be 2 or 3 or 4 companies providing the treatment, and then the supply and the availability will be much more stable than it used to be or than it is currently. This was a major challenge in spring, where Novartis published their inability to deliver Pluvicto, and we thought then it was resolved in June. Novartis resumes production. But then it happened recently again, and we published kind of a harsh criticism of industry here, because we feel that it's responsibility of the industry to make sure that there's a robust supply. There are actually 3 papers in the Journal of Nuclear Medicine addressing this, to raise awareness that this is a really big problem. So that's the summary here. PSMA PET-CT imaging can be done and used and should be reimbursed at any stage of the disease, except you cannot use it to diagnose prostate cancer. That is not covered by Medicare. That's a biopsy diagnosis. That's not something that we can do. Pre-authorization is needed as for any commercial insurances, not for Medicare patients. It is Medicare approved, it's included in the guidelines, and it is now even spelled out in the guideline that it is suggested to be better than CT and bone scan for initial staging. The therapy, after taxane-based chemotherapy, the studies are ongoing to move it forward, because I think sometimes we come in at a time where the disease has spread too far, and then we don't have the firepower to eradicate the disease. The significant supply problems I talked about, and the shortage of treatment sites is also a very important issue. So I showed you what it looked in the past, or still actually now, at UCLA. But in the future, we are building this here. This will have 8 infusion chairs. This is going to open this summer. And each of these infusion chairs is in a separate little room with its own restroom. Patients will stay about 2 hours with us and then be discharged and go home. And I think it would make a huge difference in how patients feel about the treatment. It's just a different level. This is the center here, another image. We will treat prostate cancer, will be the most frequently treated disease there. You also see the layout. It's about 3,000 square foot space. It's going to be very well received by patients, and patient care is in the integrated patient care is in the center of this activity. This is the people who have done all the work over the last 10 years to get this going and get this done. These are basic scientists, clinician scientists, clinicians coming from all different areas of expertise, including urology, radiology, radiation oncology, nuclear medicine, and they came from European sites to teach us. They were earlier than we were to teach us how to do this, and made sure that we are successful. So with this, I want to thank you for your attention to prostate cancer patients who participate in and thereby support research, the referring physicians who trust us, the Prostate Cancer Foundation, the national funding agencies, the UCLA team of Johnson Comprehensive Cancer Center, UCLA Health, and David Geffen School of Medicine, and Dr. Scholz for inviting me to speak here and have the opportunity to start communicating with you. Thank you very much.
Fantastic. So we'll do a little questions and answers here, and then it'll be lunchtime. So there's no pressure to stay on time when there's lunch coming up. All right. So the first thing I want to ask you is I want to leave prostate cancer for a minute, because PET-CT scan it's blossoming all around medicine. So is there another area you're really excited about with PET-CT? The reason I'm setting this up is I'm looking at some of the Alzheimer's trials, and now they're using the scans to look at plaques and to decide who would qualify for meds.
Yeah.
So is that an area you're excited about outside of prostate cancer? Or is there another area?
There are quite a few areas. First of all, let's stay in cancer for a moment.
Okay.
Treatment monitoring. So we use FDG PET-CT in pretty much every cancer patient now to find out whether the treatment works. I think that's a very important area, because often we didn't know whether it works, because just looking at CAT scans is often not that informative. But if your glucose metabolism goes down rapidly on the scan, then you know the treatment works. So that's important. They do adaptive treatments where they adapt based on the imaging findings in many cancers. Cardiovascular diseases are very important, and that goes hand in hand with the brain studies, because there's what you call cardiac amyloidosis, and you know amyloid is one of the products deposited in the brain when you have Alzheimer's, and that's also happening in the heart. So there are imaging probes that can look at amyloid in the brain and the heart. And with FDA approval of some drugs, whether controversial or not, to slow the progression of Alzheimer's, you need biomarkers to find out whether the treatment works. So I guess, again, it's the most important aspect is if you do a baseline scan and follow-up scan, you see whether the treatment works. And I think that's one of the key strengths of PET imaging. Also in prostate cancer, it's one of the key areas of importance.
That's interesting. So the other thing I did before you gave your lecture is I looked at some of your old videos when you gave talks at medical meetings. Yeah. And the reason I like them is because you were very honest. So you were very passionate. So here's a couple of quotations that you said at a medical meeting that gets me excited, so I can bring up some controversy. You were very passionate. You said, when it comes to PET-CT and these other areas, you said, quote, exposing patients to a lot of radiation in this manner is a ridiculous argument. So what you were trying to say is, I think, the perception is there's all this radiation, but that's not true. This is not. Can you expand on that for a second?
I think I tried to say that in the imaging portion, because the radiation that you get from a scan is really, really low. It's absolutely not dangerous. I have to watch my language again, but I remember the study that was published in Radiology where the message was, we create with CT imaging enormous numbers of cancers just by the radiation. That's absolutely bizarre and grotesque, and it's really total nonsense. It created so much anxiety on the side of patients that patients didn't want to have good diagnostic tests because they felt they will get radiation treatment. No, it's not radiation treatment. It's orders of magnitude lower. Even when you look at patients who had external beam radiation, you get really high radiation doses. Subsequent cancers are extremely rare, very rare. I mean, they happen, but it's really rare. So when you get the radiation that we give to imaging, it's homeopathic. In fact, many people believe that a little bit of this radiation is actually healthy.
No, okay, so then that was the one thing. And the other thing, if you want to comment on, you were very passionate at these meetings, and you said there's too much discussion that imaging is costing money in terms of we're a small fraction of medical cost to the system, and we need to change that perception too. Can you say something about that?
Yeah. So there was always, you in all the review articles you read the standard sentences, imaging is very expensive, but when you look at healthcare costs, it's really hospital expenditures, quaternary care, the imaging component, I think I calculated it once, it actually was 1% of Medicare expenses, and then the 1% was actually too low for the reviewers of this paper, so I've kind of faked it up to 1.5%. But I mean, you can't talk about expensive without looking at much more complicated models, which is called the decision tree sensitivity, whatever analysis. You really need to find out what the downstream consequences of incorrect diagnosis are, and then figure out what the real costs are. This is a science by itself, and just this is a defense mechanism from insurance companies, and so that they say it's expensive, so we don't want to pay.
No, that's good to know, because you still deal with that today, that what we just talked about. People think it's a lot of radiation exposure, their second cancer, so I'm glad you answered that. Now let me take you to a couple questions we talked about in general. Let me know what you think. So you're dealing with a lot of radiologists in the community, and are they having trouble? I know you guys are a center of excellence for these scans, but look, I live in Michigan, other people are in different communities. Are they having trouble doing accurate interpretations of these PSMA scans? Because that would be a concern of mine. It takes a certain amount of experience.
There's clearly a learning curve.
Yeah.
And then, I mean, I made my mistakes. There's a learning curve, there's no question. I do think that a few hundred scans should do it. If you do a few hundred, but whether you want to be the first 20 patients is a different question. But it's, radiologists are usually very good, very well trained, and I think they can figure it out. But the more training, the better. There's no question, and there's no real regulation of how much training you need to read PSMA PET scans.
But if you had a situation where someone's just starting to do scans, and there's no different from surgery, or it's no different from pathology. People get second opinions, right? Mm-hmm. They say, well, I want an expert. So we know you're one of the places in the world that has read the most scans. Is it unusual, or do you entertain or get excited about the possibility that people say, wait, I want you to also read my scan as a second opinion?
Yes, it happens. Happens quite often, and I have no problem doing this. And we get either then a CD-ROM mailed to my home address or to UCLA, and we are happy to do that. Now, of course, if it's thousands that come, it would be a little bit of a problem, but we do it. We do overreads. Yeah.
I mean, after this, it'll probably be thousands.
Yeah, I'm sure.
So, and then so I know it's not free for you to read my scan as a second opinion. Do you have an idea of what it might cost?
I think it's maybe $80 or something.
How much? 80?
Yeah,
Did you say 80 or 800?
No, 80. Maybe it's 100, but it's not high.
Really?
Yeah.
And okay, so
do you know the imaging business a little bit, how that works?
Well, so if I'm sending my scan to you as another opinion, you must have received a bunch of them. Are you seeing? I don't want to get you in trouble. Are you agreeing with the initial opinion, or are you seeing a lot of times going, wait a second, why are they seeing that?
No, there are cases where we see it differently. That doesn't mean we're necessarily right, but we see it differently. What bothers me more is that we do PET-CTs with a fully diagnostic CT and a fully diagnostic PET scan. There are still many places who don't use intravenous contrast for CT imaging, and that I find problematic because you try to find little lymph nodes and need to differentiate them from smaller structures. Then I think that's something that is probably, that's an issue for me, but not only with PSMA, it's with every PET-CT scan. I think that the diagnostic quality should be highest for the CT component and the PET component, and that is sometimes not the case.
So just to finish this portion, let's say I want you to read it at your house or at the medical center. There's a place on the website that says this is where you could do a second opinion, or
I don't know how good we are with websites, but there's clearly a contact that I will provide if the email comes to me and say mail it to whatever place. Yeah,
and
then it will be uploaded in the electronic record system.
And then you would give us that contact.
Yeah.
Okay. How about the PET scanner machine itself? Because you have a certain PET scanner. Does it make a significant difference in the quality
I don't think
of the PSMA PET?
I mean, when I look at the old, we started PET-CT in 2001, I believe, and we had a very primitive CAT scan component, and that, of course, you cannot do anymore because they were simply not the level that they are now. But whether you take, GE or Siemens or Toshiba, or whatever you take, they're pretty much the same.
They're same, okay.
Yeah, there are new devices that are spectacular, that can do very different things. It's called total body PET, where the whole body is in there, and they have a resolution that is just really, really better. The unfortunate part is the costs there. They are so expensive that it's currently not feasible. So they will be used mostly in government-run health systems where the government invests in programs.
And the other question I wanted to ask you in terms of, and then we'll jump back to the PSMA PET. So with this whole lutetium Pluvicto problem in terms of supply, there's some, but nowhere near to meet demand. There is I don't know if you call it a brother, sister, a cousin product that people are talking about and going to Germany for. And it's called actinium. And actinium is the next radioligand product that people are going to get excited about after Pluvicto. Wouldn't you agree? But I just want to know how you feel about this actinium, because there's clinical trials going on, City of Hope. There's people that travel outside the country to be treated with actinium now. They pay cash. What are your feelings about this next treatment that may or may not down the line get FDA approved?
So actinium is clearly more potent than lutetium. More potent? Yeah, but it's not available. And so that's not very helpful. The second thing, the toxicity is, you could see that I wanted to make the point when I showed images that stuff gets into the salivary glands. And with actinium, which is an alpha emitter rather than the beta emitter of lutetium, you get real damage often to the salivary glands. And as you know, xerostomia, dry mouth because you really affect the salivary glands, is not something that is pleasant for patients. And the patients often have to stop actinium treatment after, say, 2 cycles because they can't take it. So what companies are working on now is trying to bypass the salivary glands so that you don't get this.
Yeah.
And the other is ramp up the availability, which is probably currently you wouldn't be able to supply 1% of the need if it's about actinium. So people try to come up with technical solutions to make it more available. It's not there yet, but there are other alpha emitters coming. There's lead. Has a terrible name. Who wants to get injected with lead? Yeah. But it's absolutely not dangerous because the lead is in such low quantities that doesn't. But it's lead, and that's generator produced, and that's probably more likely to happen, I think, in the foreseeable future.
So these are patients that would, if they didn't respond, or if they had a response to Pluvicto or stopped responding, they could then possibly go. You're excited that they could possibly then get this as the next option?
Not yet, because in the US and even in Germany, in Germany there would be clinical trials. In Australia there will be clinical trials. We are working on preclinical work to find out what the safety, because you have to go through the motions. You have to do small animal studies to find out what the toxicity profile is and so on. So the good news is industry is buying in. So you have about 50 companies in this theranostic space. That to me is a good sign, because when industry buys in, they believe that this is really a big deal.
Yes.
And then I think it's going to happen. How long it will take is open. I don't know.
Yeah, I made a little sign here for the video. This actinium that people are excited about. So I'll move on from there, but I have to go to Vegas for a meeting from here. So if I'm at the roulette table or at the blackjack, am I betting that this is going to be successful in a couple of years? Am I betting that I think this is going to work in a couple of years or not? If you had to just be a betting individual.
Yeah, I'm not good at bet. Most of the time lose my bets. So.
Okay, so then I don't want you to bet.
It has cost me many good bottles of wine.
Okay, so then I don't want you to bet.
But I think it will take more than 2 years. It will happen, but it will take more than 2 years.
So here's a topic I don't see people talk about a lot, but it's near and dear to my heart when it comes to the PSMA scanning. Mm-hmm. All right? Before you had PSMA scan, if you went for other scans, Axumin scans, if you went for choline scans, the patient was told to, depending on the situation, stop significant exercise within 24 hours and/or fast. They couldn't eat on some of these other scans, like at choline. And you're saying there are no issues with fasting, eating. If you get this scan, you're not concerned that anything could interfere?
So eating, no. Because with FDG we do it because with glucose imaging, because you eat, you change insulin, right. You get sugar into your muscles. Exercising, the same thing. Exercise, I'm not sure because I don't know what exercise does to your amino acid levels.
Yeah.
Or lipid metabolism like choline, I don't know what it does. So exercise, I would just maybe not exercise the day before or something. But diet...
I've never heard anybody say that. Are you talking about for your scan? For your PSMA?
No, for any PSMA. You don't.
For any PSMA, you would tell them to exercise, okay.
No. I would say they should not.
They should not.
But because for PSMA, it doesn't matter, but for choline, which is metabolism, right. Axumin, metabolism, okay. FDG scans, metabolism, don't exercise. But diet really only for FDG scans, not for, you don't have to worry about an impact of diet on your choline uptake or choline patterns.
So do you use others, do you use the glucose, the FDG scans at all in prostate cancer? Are you still, in other words, a lot of questions that we got from the audience is, let's say I'm not seeing anything in your amazing scan. Should I go ask for a different type of scan like the glucose scan, the FDG PET? What do you think?
So in very advanced disease, when the PSMA scan can be negative, so people have linked that to the neuroendocrine phenotype, and then FDG can get negative. And then PSMA can get negative, so that the cancer is so de-differentiated that it doesn't produce PSMA anymore. Then FDG would be reasonable. Also, before treatment with Pluvicto, if you have lesions that have maybe low PSMA uptake, then FDG could be helpful, because if it's high, it shows you it's a different kind of disease. It makes it much less likely that the patient will respond to Pluvicto. So in Australia, for instance, every patient who undergoes treatment has both a PSMA scan and an FDG scan before.
So they get both scans?
Before treatment, yeah. Which we don't do for many reasons. One is insurance coverage. And the second reason is that if you see a lesion on CT,
right.
You see some mass or something that doesn't pick up PSMA, then you know the treatment will not work because the target isn't there. So I'm not sure that you really need the FDG scan. It would be nice to have it,
yeah.
But I'm not sure it's really needed.
What do you tell one of the greatest advertisements for I call it your scan, if you don't mind, because you were involved in it, so I say your scan, but
it's really not.
I know. Sometimes it's a compliment.
Yeah, no, I know.
So I'm saying, here's what I've noticed a lot. The advertisement was, we can pick up something as low as 0.2, or they give a low number and people get excited, right? As opposed to waiting for your PSA to get 1 or 2. With the older scans, then you would get a scan. Okay, so you can pick up at 0.2, but a lot of people go get your scan and they don't see anything at 0.2 or 0.3. Now what do you tell them?
So as I showed in the numbers, when it's between 0.2 and 0.5, it's probably around 40% only that we detect it. So the majority of patients, you will not see it. So it depends. Many radiation oncologists would then just treat without targeting anything because there's nothing there. Problem is on CT you will not see anything because these lymph nodes or the recurrent site is tiny, so you will not see it. Other people wait and say, well, let's do it again when you are 0.6 PSA, and then treat. Since we don't know outcomes, we don't know whether an intervention based on the imaging really makes a difference. We believe, but we have no data to prove it. I don't know.
So what's confusing a lot of doctors I've noticed is that, okay, 0.2, nothing on the scan. Let's just say this is someone who had surgery, right? Okay, 0.2, nothing on the scan. 0.6, nothing. 1, nothing. Then, why not get an MRI? Why not look for it with some other mechanism?
Many patients will get it anyway, but most of the time you don't see it. Most of the time you will not find anything on MRI either. Some patients get an Axumin scan.
They'll get a different type of PET CT. Okay.
Different PET CT. We compared that, and it's clearly inferior to PSMA imaging. Yeah, I mean, the numbers are 80% when it's 1.0, but it's not 100%. So what's the issue there? The issue is either it's very small or it expresses low amounts of this PSMA thing on the cells, then we will not see it. If it's a large lymph node, then we will probably just based on CTs, large, let's say 1 centimeter, that range, we will say it's probably the lymph node that we see. Can we prove it? No. Sometimes you can biopsy it, but
I mean, I think this is a big dilemma because, you know, PSA stands for, in some cases, prostate-specific anxiety.
Oh, yeah.
Right? So as it goes up, people are anxious. And so you've seen people go to get choline or go get Axumin scans if they're not getting what they want with this.
You know, I think the best way to deal with it is always honesty and say, well, you have an 80% chance that we find it, or you have a 60% chance that then many radiation oncologists will simply treat.
Okay. Does a bone scan do anything better than a PSMA scan? In other words, if I get a PSMA PET CT, do I even need a bone scan anymore? Or are they becoming obsolete?
So the NCCN guidelines now suggest that it is superior to do a PSMA PET CT scan over a bone scan. We tried to do a direct comparison. We didn't get enough patients to really do it. There's clearly no additional benefit of the bone scan in our experience. So if you have a PSMA PET scan, I don't think PET CT scan, you don't need a bone scan, not only because of the PSMA findings, but also because of the CT findings, because you see lesions very well, bone lesions on the CT scan. So, you know, I personally don't need a bone scan. It's part of the staging that led to certain treatment algorithms based on CT and bone scan. So we see more now. How do you deal with this as a urologist or uro-oncologist? What you do with the information? You don't know whether if you go after a specific lesion, it will be beneficial. How do you define oligometastatic disease when you suddenly have a bone scan with 3 lesions and PSMA scan with 8? How do you incorporate that? That's all unknown. Nevertheless, I believe the more you know, the better it is going to be, at least in the future, because you gain knowledge, experience, and eventually will know how to best manage it.
So if the PSA is rising, if it's high enough, you feel really good about PSMA. How about these other situations that are happening? Let's say you're on hormone therapy. Say your PSA is low. It's kind of playing around at a low level. Can you tell me, is some of the limitations of the PSMA scan that when you're responding to treatment, that it's not, or do you feel like you could still use it in some circumstances?
So we have a very small series of patients where we image before and after hormone therapy.
Okay.
And again, it's very difficult to do this because nobody pays for the scans, and there's not much, there doesn't seem to be much of an impact of the hormone treatment on what we see as PSMA expression on images. And I know there was this old study by Tom Hope that came out where it said it has an effect on PSMA expression. It can have a little bit of, it's not dramatic. So for instance, if you were to say I gave hormone treatment or I stopped hormone treatment to increase PSMA expression because that would make it more sensitive to the treatment, I don't think so.
Wow, okay.
But again, I can't prove it, so I shouldn't even, but I think so.
Well, because at the end, everything comes with a catch. And so, here's some of the catches that people throw at, I just want to do this for fun.
Keep coming.
Your scan.
Yeah.
Here's some of the criticism. Okay, here's some of the questions we get. Not only criticism, but everything comes with a catch. Just my first question is, how long is the waiting time? I need to get a scan next week at UCLA. How long is the waiting time right now to get a scan? Because remember, in the old days, that waiting time got pretty long before.
Very long. Now the waiting time is approximately, I mean, the rate limiting step is really the insurance authorization. For Medicare patients, it's less than a week.
Less than a week.
And insurance authorization can take longer, and it's very aggravating for everybody, referring physician, patients, and us also, because it's like the phone tree thing, and you get the obnoxious music. And, yeah, so that's not helpful, but it should be more than 2 weeks.
And then if I get my scan approved, I should be able to get in 2 weeks, right? So that's exciting. And then how long does it take you to read it on average?
We read either the same day or the next day. But when the patients come in before, I would say 1 o'clock, it's the same day. And then we read it, and then the report is either on the system the same evening or the next day.
Okay, so
that's the latest.
That's great. And then how long does it take me to just go through the procedure itself in the scanner?
So the way we do it is patient comes in, is going to be injected with the isotope. There's an uptake period of about an hour. Then the patient goes on the scanner. We do a whole body scan. Then we ask the patient to void, to go to the restroom, and then we do just the pelvis.
Yeah.
And that whole imaging, including getting off the scanner and on, is probably 45 minutes. The scanner. So waiting time plus scanner, and then everybody's late. Calculate 2 hours or some 2 hours probably total spending in the clinic.
2 hours total? Because you remember, there's still around bone scans. I mean,
that's 4 hours.
That's 4 hours.
But you have to wait because it takes much longer to accumulate in the bone. Yeah.
But you guys are implying, which makes sense, that you probably don't, many people don't even need bone scans anymore. This does everything. What about, everyone's using MRI just for initial diagnosis and biopsy, but a lot of people are arguing that PET-CT should be used in complicated cases possibly to diagnose. Do you think that it's going to be used earlier and earlier to diagnose significant tumors like MRI is used today?
So there's of course a lot of research ongoing, and we have studies at UCLA also to find out whether we can see clinically significant prostate cancer in patients where one is not so sure.
Yeah.
And in the ones where you're pretty convinced that there is cancer, but the MRI doesn't see it. So I don't know the answer, how good it will be. You get sometimes very focal uptake in prostate cancer, and then it's hard to find it with biopsy because the anatomic fusion with what you need to do your biopsy, the CT fusion with the MRI or the ultrasound and this PSMA signal is not trivial. So, you might not get to the right point. I think it can be helpful.
Because I know these centers are studying the effects of using both.
Yeah. Fusing it, yeah.
Yeah, fusing it. So you see promise in that.
Well, there's a PET-MR scanner coming also at UCLA. It would be interesting to see how much that can help.
So let's talk about some more, I call them Achilles heels. The word false positive and false negative is not a fun 2 words to hear.
True.
What are you worried more about with these scans? False positives or false negatives or both, and why?
No, of course you worry about both. I would say that so first of all, the term prostate-specific membrane antigen is a misnomer.
That's right. Because
PSMA is expressed in several other tissues and also in the blood vessels that sprout into other tumors. So we have detected colorectal cancer with PSMA imaging because it lights up and it cannot be prostate cancer. Then it's going to be biopsied and you find out. The false positives that we see can be very worrisome because they can be anywhere in the body, and benign bone lesions can have low uptake. I'm very worried about false positives, more than false negatives, because false negatives, I know what our performance is. False negatives, I know 40% sensitivity in patients who go to surgery means we miss more than half of the small lymph nodes still. So I know what it is. False positive is very hard because you can't go after each with biopsy to find out whether it's real. Often it's clinically not such a problem because you have more disease. You have like 10 lesions, and it doesn't matter whether one is true positive or false positive unless it's in a very awkward location. So the other thing that I look at is try to look at the clinical information quite a bit. So the history is important. If your PSA doubling time is very fast, the PSA progression is very fast, then chances are that it's much higher that it's true positive. It's something simmering at a low level, kind of I get more concerned. The other thing is the CT. You have to look carefully at the CT. They reduce the number of false positives. Radiologists have a pretty good gestalt idea of what malignant versus benign, good versus bad looks like on the CAT scans.
So when the PSA is moving, like the velocity, it's going at a nice pace, you feel more confident that what you're seeing is real?
I would say that in most cases I feel confident. There are some cases, especially when the PSA uptake the PSMA uptake or ligand binding is low, you see a little bit of, you have a lymph node with a little bit of uptake in an unusual location.
Okay.
Or you have a bone lesion, you have a little bit of a bone uptake. We know already, we learned that if you have a solitary mild uptake in a rib, it's usually false positive. So I mean, you learn by doing it, and you have to stay critical. You have to look up. You also have to. You see something in a very odd location, you have to look into the literature and see, has something been reported on, an uptake in some other disease.
Well, that's why you're in trouble for admitting that you do second readings, because that's my worry, right? That someone that's a novice at this is seeing something and they're not sure if it's false positive, false negative. And I'll give you a classic example that if you looked in the literature, there was a discussion of PSMA and all these isolated rib lesions. You remember all this data? And so that freaks people out because they think they've got metastatic disease, and it turned out a number of those were false positives, right? Am I got that correct?
If it's a solitary rib lesion, most of them are false positives. Solitary
rib lesion, most of them ended up being false positive.
Yeah. And that comes from retrospective studies, but it's there's also different PSMA compounds that are kind of coming up in Europe.
Yeah.
One of them is known to give you tons of false positive rib lesions. So if you know that, then you can deal with it. It aggravates uro-oncologists in Europe to a great degree because they say, what do I tell my patients now? What do I do with it? Yeah.
Another term that a lot of people write about in the questions, and because a lot of people will look at their own report and then they'll look at the impression, and then you'll see these words used a lot. It's called SUV. Can you just kind of explain that when someone's seeing this value that says SUV, I know it sounds like an automobile, but it's not, right? So it's called standardized uptake value. It's not a car, and can you explain? It's higher. Makes you feel more confident, lower. Can you just kind of give a brief overview of why this is used so much when you read these scans?
It gives you a kind of an indication of the intensity of PSMA expression. So if you have a lot of PSMA, usually the uptake of the isotope of the tracer will be higher. So if you have a number that is, let's say, above 20, or double the uptake of the liver as a reference organ, then you will see the uptake is intense. Or you can normalize it to salivary gland uptake. So we have ways to look at it, but it actually denotes the amount of radioactivity that ends up in a lesion of the injected dose, how much of that goes into a lesion. The more PSMA expression you have, and I would say the more likely it would be that a PSMA targeted treatment can be successful.
Effective.
Yeah.
So is there a cutoff value that someone should look for in a report, SUV of what number did you throw out, did you say?
You can say 10, you can say double the uptake in the liver, you can say, we would qualify it, we would say, kind of give in the impression low, medium, or high.
Okay.
And then there's also heterogeneity. Some of the lesions in the single patients can have low uptake, and others in the same patient very high uptake. That's not a good thing for treatment because you will have lesions that will not respond very well.
I'm always looking for criticisms of PSMA that I haven't thought about, even though I know it's completely changed medicine. Here's one that came from a urologist that's well known and been at this meeting. I won't mention the name, but I don't know if this is still true or not. So it says, some studies have estimated 20 to 30% false positives, but they believe heavily irradiated, non-viable prostate cancer could remain PSMA positive. Is that true anymore or not? In other words, if I've had radiation to an area, can prostate cancer that's no longer viable or dead or not living tissue, can that throw some PSMA out there?
If it's dead and it's really essentially scar tissue, fibrous tissue, no. because the PSMA needs living prostate cancer cells. But I agree, there are false positives, and in the prostate bed there can be false positives. There can be sprouting in of small vessels. So one has to be careful. In lymph nodes, I would be very surprised if they're in typical location, if they're false positive. They usually are real.
Okay, those usually are real overall. And then what about, can you say one more, I'm over, I apologize. We want to end by 12:30, but different PET CT, different tracers are excreted, or the body gets rid of them in different places, right? So with PET, with the PSMA that you use, the product gets excreted through where?
Well, the liver and the kidney to the bladder.
And the bladder.
So that's why we send the patients to the restroom and do an extra pelvic view.
Okay.
So after they void, then you empty the bladder and then you...
But the bladder lights up.
Yes.
And the prostate's near the bladder. So when the bladder lights up, what if there's a tumor that's near the bladder? Can you pick that up, or does it get pushed out by the brightness of the product in the bladder itself?
So again, you know, we have the CT scan and the PET scan, so we know where the bladder is and where the prostate is, so we can see that. But the other trick is really the voiding. So you empty the bladder, then you get a cleaner look. It's also that if it's real, that's another true positive sign versus false positive. If the uptake keeps going up, so when the pelvic views later on, it gets hotter, then it's real. If it goes down, then it's more likely to be benign.
Okay. And then there are some surgeons I found out in the country that are getting PSMAs, and when it doesn't light up before surgery, they won't do an extensive lymph node dissection anymore. They're confident that there's nothing in the lymph nodes, so they may sample one lymph node. Have you heard about this? I mean, I've received a couple of these calls that they have such confidence in the PSMA if they got it before surgery that they won't do an extensive lymph node dissection just to sample the lymph nodes.
I think the data that I showed should raise caution here, because if the sensitivity is only 40%, for what can be detected during surgery, I would think that more than 50% will be still there.
Still possibly there. So that's good to know. So we're not that advanced yet to that point overall. All right. Is there a question I should have asked you that I didn't, that you really wanted to answer, that was going to make UCLA and PSMA shine even more? Like, you don't need any more attention than you guys are getting, you guys and gals. But
I think we're so great. You just made one mistake. You had a USC marching band.
I know, but I appreciate your candidness. I appreciate that overall. Are you in touch with at all people in Europe and in Heidelberg and where all they're doing? And because people from California and other places are flying over there to be treated.
What I didn't say is that Novartis actually stopped delivery of Pluvicto for the next 4 to 6 months. So I'm talking to patients all the time. And there are several places that I know the people in Germany, all of them pretty much.
And they can still give the product?
Yeah, and it's per cycle it's probably no more. It's very expensive, but it's much less expensive than here. It's like $10,000, $12,000. Here it would be, if you pay out of pocket, like $40,000, $50,000, $60,000.
Yeah.
So, but you can't get it here. That's the problem.
Exactly. So I just wonder who you're talking to in Europe where they can still do these things. Is it University of Heidelberg?
It's Essen, it's Heidelberg, it's Munich, it's pretty much all over the place.
And so you'll help patients if they run into trouble, just at least knowing who these people are and how to contact them?
I do it all the time.
And you've made a lot of promises here.
I do it all the time.
This is great.
I do it all the time.
That's fantastic.
You know, I didn't have a cell phone until I was 60. Now I'm kind of victimized. So no, we do it all the time.
Okay, so I'm going to have to let you go, but I got a couple side things for you that have nothing to do with today. I think we've covered a lot. And by the way, are you a runner? Did you run marathons?
Yeah.
Do you know how I got that?
Why?
Because I watched, again, I call this investigative work. Some people call it stalking.
Oh.
But what I did was I went, and you kept referencing about, a marathon, the joy you feel when you finish a marathon. I thought the only person that talks that way is a runner.
Yeah, but I didn't do many marathons. It was very slow. But I was a soccer player, and I still play. I till 6 weeks ago, till I pulled my hamstring. I played soccer. Now my career's over.
Well, no, that's okay, because you need plenty of time to do more of the second opinion readings that you're going to be getting. Okay, so we have a couple of gifts, but first, I want to tell you what you and I share. We share a very strong bond, and I haven't even met you till today. I've seen you at meetings, exchanged some pleasantries, but you went to the University of Vienna for your MD. Mm-hmm. I know 2 world-famous celebrities to me that went there. Let me see if you can recognize their picture. What?
Dr. Marberger? No.
No, I'll show you. Can you bring up that picture? I want to see if you can guess who these 2 celebrities are that also went to the same university. One to get his MD, one an undergrad in the 60s. And can we bring up my first slide? There it is.
Oh.
You can look down here too. We got it down here.
Oh, no, it's going here.
Any idea whatsoever? If you get this, I'll buy you dinner tonight. And then you'll read my PSMA scan.
I don't, is she an actress?
She an actress? Oh my gosh. You just made my mom's day. That's my mom and dad. So
oh, really?
My parents went to the University of Vienna. My dad was the first Iranian to graduate from the University of Vienna Medical School, and my mom was an undergrad, and my mom said that my dad used to follow her around campus, so she finally gave in and they went out.
That's understandable.
Understandable? So that's my parents, and so so my mom is 86. My father, who was my superhero doctor, passed away a few years ago, but I thought it would be a nice moment because there's like a bond at the University of Vienna. It's unbelievable. My chairman goes there every year, and so I told my mom that someone from the University of Vienna is going to be here. He's world famous, and she said, I want to say something to him. And in German, so can we play this? Mom, this is my mom, just in 20 seconds. Because she spent most of her life in Vienna and her whole family's still there.
It's nice.
Sehr geehrter Herr Dr. Professor Czernin, wir danken Ihnen, dass Sie an dieser Konferenz teilnehmen und wir gratulieren zu Ihrem großen Erfolg.
I understood.
So, do you want me to explain, or do you want to explain what my mom said besides that I'm a great son?
No, that's, she said you're a great son.
Basically she's saying that it's an honor to have you here, and congratulations on everything that you've accomplished, because she's another proud graduate of the University of Vienna.
But she was born in Vienna? Or?
She was born in Vienna. Yeah. She's her entire family is still there. She's the only one.
I still recognize the Viennese accent.
Yeah, that's what she said. That's what she said. You would recognize it.
Yeah,
so, And so I said, Mom, just say any 3 sentences. And I swear she kept me on the phone for 4 hours going, I got to make sure that he understands this.
Send her my best regards.
I will.
Thank you very much.
This will absolutely make her day.
So nice,
it's part of my way of saying thank you so much, and thank you for being a part of this, and congratulations on all this success. It is amazing.
Thank you.
So with that, we have to give 2 gifts, again, with the help of my mom. Mozart Kugeln. This is the most famous chocolate from Vienna you can imagine. We used to eat it as kids. And then I thought one great cup for you would be, I use this mug periodically. It says it's the periodic table. It's a nerd's cup. So it's
perfect for me.
Thank you very much. I really appreciate it.
Thank you, Dr. Czernin, and thank you, Dr. Moyad. Okay, so now we're going to transition. We have a sponsored talk by Janssen Pharmaceuticals, and they're going to be talking about hormone therapy and prostate cancer. They're going to give us some details about hormone therapy itself, but also the side effects and what to expect. Presenting this talk is the medical director of the prostate cancer program at UCLA. His name is Dr. Matthew Rettig. He's a medical oncologist, and he's been a good friend of the PCRI for quite some time. He does a really great job of contextualizing prostate cancer, but also talking about quality of life and whether or not this is the right decision for you. So thank you, Dr. Rettig, for being here. We really appreciate it. Without further ado, here's this talk.
Thank you so much. Thanks for that introduction. So yes, my name is Matt Rettig. I'm a medical oncologist that focuses in genitourinary malignancies, especially prostate cancer. I work both at UCLA as well as the affiliated VA Medical Center. where we see a lot of patients with prostate cancer, the most common cancer amongst veterans far and away. We'll get started. So we're talking about prostate cancer. This is more of an educational overview, and the title of the talk is Understanding the Challenges, Empowering Yourself. So here are the learning objectives. First, we'll provide an overview of prostate cancer, and then I'll go over the role of androgens, male hormones, and how they function in the context of prostate cancer, and then explain disease progression. So we'll start off with the state of prostate cancer. So these are statistics from 2019, and the relative frequency of these cancers is the same, but the incidence of prostate cancer has been going up. We're expecting in 2023 about 275,000, 280,000 cases. And in 2023, we expect it to be the first year that the incidence of prostate cancer will be greater than that of breast cancer. So previous slide was incidence. This is mortality. So lung cancer is the #1 killer of men and women. Prostate cancer is the second leading cause of cancer-related mortality, and it's the #1 cancer in terms of mortality in non-smokers. And the numbers are increasing over time. Again, these are 2019 statistics. And essentially since 2018, the number of deaths attributable to prostate cancer has increased by about 1,000 per year. So that in 2022, although we don't have the final numbers in, we expect 34,500 deaths attributable to prostate cancer. And here are the risk factors. Age is a major risk factor. In fact, prostate cancer incidence increases with age more rapidly than any other malignancy. Interestingly, we can identify prostate cancer in men who are quite young, in their 30s and 40s, and in autopsy studies of men that have died from another cause. When one examines the prostate, we see about 20 to 30% of patients, even in their 30s or 40s, having evidence of prostate cancer. Most of these cancers that can be detected on autopsy are not clinically significant. Another important risk factor is race. African Americans have the highest incidence, about double that of Caucasians, and Hispanics and Asians have a lower risk than Caucasians. Interestingly, geography is important. So irrespective of race, men in North America have a very high incidence of prostate cancer. So if you take age-matched Blacks from Africa and Blacks from the United States, we see that the incidence is much higher amongst the American Blacks. Interestingly, when men immigrate to the United States, their offspring then have a higher and higher incidence of prostate cancer, consistent with the statistics for men that have been in, whose families have been in the United States for multiple generations, indicating environmental factors playing an important role in the incidence of prostate cancer. A family history is also important. There can be patients who have inherited genetic cancer syndromes where there's a specific gene that is mutated and predisposes to prostate cancer. There are also, and more commonly, clusters of cancers, including prostate cancer, amongst families that are not attributable to a specific gene, but perhaps to multiple genes or shared environmental exposure that can predispose to prostate cancer. And then you can see other risk factors, including diet, as we mentioned, obesity. There's question whether or not smoking really has plays a role in risk for prostate cancer, and the same thing holds for some of these other risk factors that are listed here, like vasectomy. That's really not been clearly demonstrated as a risk factor for prostate cancer. So most patients in the United States are diagnosed by an elevated PSA without symptoms. Patients, of course, can develop symptoms, either local symptoms related to the prostate, such as urinary symptoms, occasionally blood in the semen, erectile dysfunction. And then if the disease is more advanced, metastases can cause symptoms related to the site of involvement. So if it's in the bone, it causes bone pain, or generalized symptoms such as weakness, fatigue, loss of appetite, and weight loss. In terms of screening and diagnosis, so PSA is a screening tool. There have been various recommendations by the U.S. Preventive Task Force. In 2012, the U.S. Preventive Task Force actually recommended against PSA screening based upon the results of studies demonstrating the benefit of screening as well as the benefit of treating localized prostate cancer. The U.S. Preventive Task Force in 2018 partially reversed course and said that men between ages 50 and 69 should consider screening, and that should be a shared decision to be made with their doctor. They still stand by the recommendation against screening in men 70 or older. I personally think it's a individual decision that takes into account multiple factors such as patient risk factors, life expectancy, etc. And of course, the diagnosis is made by a biopsy. This is a slide that just shows how men can deal with prostate cancer, and there's a spectrum of responses. Patient can have a proactive approach, could take a more practical approach without any emotion. And then some men feel confused, especially at the outset when they don't have much information and don't necessarily ask the right questions or know what questions to ask. And then some patients really feel hopeless and that there's no choice. I should point out that irrespective of the stage at diagnosis, the disease is really eminently treatable, and it is associated with many, many years of life expectancy. And most men who are diagnosed with prostate cancer will die from another cause other than prostate cancer. And that's true even of patients who have aggressive features in their prostate cancer biopsy or have a high PSA. So let's turn to the role of androgens in prostate cancer. So androgens is the term that collectively refers to male hormones, most prominent one being testosterone. Okay, so what you see here are the different clinical states and stages of prostate cancer. On the left is localized prostate cancer, where the vast majority of men are diagnosed. On the far right is metastatic castration-resistant prostate cancer. So castration-resistant may not be a very palatable term, but it's an accurate term indicating that suppression of male hormones through medical castration with drugs like Lupron has stopped in its efficacy, and the patient's cancer is worsening, and therefore they have castration-resistant prostate cancer. And of course, when they have metastasis, it's metastatic castration-resistant prostate cancer. And that really is the lethal form of the disease that accounts for the mortality associated with prostate cancer. To the left of mCRPC are the two states that are precursors to it: metastatic castration-sensitive prostate cancer, and that's a patient, would describe a patient who has metastatic disease and is first going on hormone therapy and is therefore castration-sensitive. Non-metastatic CRPC in the purple circle is a patient typically who's been on hormone therapy for a PSA recurrence after surgery or radiation, go on Lupron and is on it for many years, and then ultimately the castration-resistant state develops as manifested by a rise in PSA, but there's no evidence of metastasis on conventional imaging. So that patient would have non-metastatic castration-resistant prostate cancer. Importantly, throughout the course of this disease, including in the metastatic castration-resistant prostate cancer space, the male hormone environment is still critical for the survival, proliferation, and growth of prostate cancers. So even though it's castration resistant, the tumor still uses the hormonal milieu and activates the male hormone or androgen receptor, but it does so in a manner that is no longer dependent upon the testicular source of male hormones. So how do we determine if there's a disease progression? Of course, we have blood tests, the PSA being the most obvious one, and the testosterone should always be co-monitored with the PSA, because there are patients who are on hormone therapy and who have what's called testosterone breakthroughs, where the testosterone does not remain low and is no longer in the castrate range. So that should always be a check, that the testosterone, to confirm that the patient is still castrate. Of course, we also have imaging to determine whether or not the patient has developed metastasis or existing metastasis have worsened. So pre-existing metastatic sites can have grown or new metastatic lesions develop. And the conventional imaging that is classically used are radionuclide bone scans, so-called bone scans, as well as CAT scans of the chest, abdomen, and pelvic to look at the soft tissues like the lymph nodes, liver, lungs. MRI can be used, although it's not used so much for imaging of metastatic disease, but rather it's an effective tool for imaging the prostate, especially in patients who are undergoing initial evaluation and staging for prostate cancer. So when it comes to localized prostate cancer, the most common state of the disease at the time of diagnosis, and there are multiple approaches. For patients who have low-grade, unaggressive forms of prostate cancer, active surveillance is a really good option because most men will not succumb to that illness, will not succumb to prostate cancer. Of course, there are therapies that are implemented with curative intent, and that would be either surgery, radical prostatectomy, or radiation therapy, which is often combined with hormone therapy in patients who have more aggressive biology, have high-risk disease, or something that we call unfavorable intermediate risk disease, where concurrent hormone therapy with radiation has been shown to improve outcomes. So androgens, as I said, are male hormones that are predominantly produced by the testicles. So about 90–95% of circulating male hormones in an adult male are derived from the testis. There are about 5 to 10% that are produced by the adrenal glands, and prostate cancer cells, unlike normal prostate tissue, can actually produce testosterone as a way of feeding itself. If you think of a race car, if you think of the male hormone receptor as the or androgen receptor as the engine, then androgens are the fuel that really need to get the engine going. So when we treat prostate cancer, we can either take away the fuel, such as with medical castration like Lupron, or we can block the ability of the fuel to actually activate the engine. And those are drugs that like the lutamides, the bicalutamines, the darolutamides, the apalutamines that effectively block the function or action of androgens. So, as I said, the hormone therapy or androgen deprivation therapy or medical castration is really the mainstay, the backbone of the medical treatment of prostate cancer, and that has been known since the early 40s when Huggins and Hodges published their seminal work showing that castration, surgical castration, or medical castration with estrogens was a way of treating prostate cancer in men and dogs. Charles Huggins went on to win the Nobel Prize in 1966 for his work. And then another Nobel Prize was given out related to prostate cancer in 1977 to Andrew Schally, who discovered the basically the LHRH analogs. Those are the Lupron-like drugs. And he did that at the Miami VA and is still working there and is in his mid-90s. So as I said, hormone therapy or androgen deprivation therapy works by either blocking the production or action of male hormones. The Lupron would be blocking production by impairing the ability of the testis to produce testosterone, and drugs like the lutamides, bicalutamide, enzalutamide, apalutamide, etc., block the action of androgens. So now let's turn to the third topic, which is disease progression. So when patients are placed on androgen deprivation therapy, castration, the overwhelming majority respond, typically by a rapid decline in the PSA, as well as radiographic responses. Ultimately, however, if a patient is on hormone therapy for long enough, all patients will develop castration resistance. And how long it takes to develop castration resistance depends on a number of factors, including what stage of the cancer the patient is at, the volume of cancer. So if the patient has more metastases than, or as compared to fewer metastases, and other biologic factors, including genetic factors of the tumor that can help or confer sensitivity or resistance to androgen deprivation therapy. So we talked about this castration resistance, and we also talked about non-metastatic castration-resistant prostate cancer as a patient who's no longer responding to castration and whose PSA is going up, but there is no evidence of metastatic disease on conventional imaging, and that's non-metastatic castration-resistant prostate cancer. It's a state of the disease that we feel that is shrinking in size because of the ability of novel imaging modalities, molecular imaging like PSMA PET scans, to detect very small burden of disease that is not ordinarily detected with conventional imaging. Importantly, with non-metastatic castration-resistant prostate cancer, there's a wide variability in the time that a patient to the time that a patient will develop a metastasis. And the two features that are most predictive of time to metastasis are related to the PSA. So the PSA doubling time, with a PSA doubling time of less than 10 months, predicting for earlier onset of metastasis, or the actual PSA level, a PSA of greater than 10, also predicting for earlier onset of metastasis. And about half of the patients who have non-metastatic CRPC will develop a bone metastasis at 2 years, and a small percentage will even succumb to the disease. So we know that men, of course, can progress to metastatic disease, and that can happen even in the absence of hormone therapy. And that's, of course, that's what cancers do. They grow in an autonomous manner and will ultimately develop metastases. And metastases can be present at diagnosis, which is shown on the left, and that is called de novo or new metastatic castration-sensitive prostate cancer. Alternatively, metastatic disease can develop in the context of a recurrence after surgery or radiation. So typically a patient will have surgery, then develop a recurrence. And if the recurrence, the PSA is not treated, the patient will eventually develop metastatic disease. And that would be called recurrent metastatic castration-sensitive prostate cancer. So when we have metastatic castration-sensitive prostate cancer, basically that's an indication that the patient has metastatic disease and the patient is first going on hormone therapy. So even though the patient hasn't necessarily received hormone therapy, we call it castration-sensitive, meaning that the tumor will respond or is responding to castration because basically all patients do. In theory, we can also call it castration-naive metastatic prostate cancer, but these are terms that refer to the same entity, that is a metastatic tumor, which patients are first going on hormone therapy. And as I said, a patient can have de novo metastatic castration-sensitive prostate cancer, meaning that the diagnosis of prostate cancer is occurring when the patient actually has metastatic disease, or they can have recurrent metastatic castration-sensitive prostate cancer, whereby the metastatic disease is occurring in the context of a recurrence after surgery and or radiation. Interestingly, de novo metastatic prostate cancer has a less favorable prognosis than recurrent disease, which sounds counterintuitive because we always think of recurrences as having a worse prognosis, but in the context of prostate cancer, that is not the case. It's the other way around. So whenever we consider treatment for prostate cancer, irrespective of age, irrespective of stage, we have to consider multiple factors. So what is the expected life span for the patient? So is the patient 105 or is the patient 55? And that's going to inform treatment decisions. Of course, what are the other medical illnesses that the patient has? That's important because it can help guide therapy. And there are some illnesses that could be, in theory, exacerbated by treatment of prostate cancer. Alternatively, some of the drugs that we use for prostate cancer can interact with drugs for other diseases. And we always want to have a careful discussion about the potential benefits and downsides of treatment, so that is side effects. Potential benefit is, in my view, can be thought of in one of two ways. Does a treatment extend life expectancy, or does it improve quality of life? So the treatment options for metastatic castration-sensitive prostate cancer and non-metastatic castration-resistant prostate cancer overlap. Androgen deprivation therapy, such as Lupron, is really the backbone of therapy for these disease states. We also have the what we call anti-androgens. These are the drugs that are the lutamides that block the action of male hormones. Importantly, with metastatic castration-sensitive prostate cancer, we've learned over the last 8 years that androgen deprivation therapy by itself is no longer considered sufficient or optimal to achieve the greatest survival benefit. We now know that if we add a second hormonal agent, one of the lutamides or chemotherapy, or even 3 drugs to serve as the backbone of treatment, we markedly improve survival, much greater than if we reserve those same drugs for the castration-resistant space, the metastatic CRPC space, where the drugs can have an improvement in overall survival, but those same drugs, when brought earlier in the disease course, such as metastatic castration-sensitive prostate cancer, have a much greater impact on life expectancy. So I think what we know is that patients can have 3 different areas where they may struggle in understanding their prostate cancer. These are there can be confusion about the states of prostate cancer, which we've touched upon, namely, is it castration resistant or castration sensitive? Is it metastatic or non-metastatic? It's also possible to have confusion over where is a patient headed in terms of their future treatment. How long will the current treatment work? How long is it expected to work? What do we do if the treatment stops working? These are all important questions that a patient should address with his physician, so that there's a greater understanding. When there's greater understanding, that reduces stress and anxiety over their disease. I think, of course, we need to understand what it means to progress to metastasis, and whether or not metastasis is developed at diagnosis or as a recurrence, and whether or not the metastatic disease is castration sensitive or castration resistant. So my recommendation to you is really ask questions to your physician, to your urologist, your oncologist. You can do your own research, but don't make any definitive conclusions. You can be misled by what you read on the internet. There's a lot that goes into making a decision about prostate cancer. A lot of different studies. Sometimes studies can have opposing results on the same topic. So it's important to have a discussion with your well-informed physician. It's also important to focus on quality of life and what you can do in terms of diet and weight loss to optimize your ability to tolerate treatment, as well as to extend your life expectancy. So diet and exercise can do both, and improve your tolerance of treatment, as well as extend life expectancy. And of course, you're going to ask your physician if your treatment's working. We touched on this. What's going on? What will happen if my cancer progresses, and has my cancer progressed to other sites of disease? So I'm going to stop there. These are patient resources that you can use. Of course, you can use the PCRI as an important resource, and then the American Cancer Society, the National Cancer Institute, and others. So I'll stop there and say thank you very much for listening. And I hope this talk has helped you in some way, so that you can gain more control over your cancer and learn as much as you need to make the right decisions for yourselves.
Thank you, Dr. Rettig. I really appreciate that talk. If you have more questions about prostate cancer or hormone therapy and whether or not that's right for you, you can visit our website, pcri.org/helpline, and talk to our advocates. They can help answer some of your questions. Also, thank you to Janssen. We really appreciate your sponsorship in helping us present this today. All right, a couple things I want to remind you about. You can donate to PCRI.org. We are a 501c3 nonprofit. All of our services are for free, and we're reaching hundreds of thousands of people around the world. But there's millions of men dealing with prostate cancer, and we want to reach more. So if you want to partner with us, whether that's on a monthly basis or an individual donation, we really appreciate it. You can do that at PCRI.org/donate. I also want to remind you, if you have questions regarding this conference, you can leave them in the chat box on our YouTube page or email us at info@pcri.org as well. Our next presentation is by Dr. Carl Rossi. He's been a dear friend to PCRI and spoken for us for many years now. He's the medical director of the California Proton Center. A couple key things to know about him is he's been doing proton therapy for over 30 years and has done thousands of procedures. He is an expert in this field, and he's going to discuss the ins and outs of proton therapy and what side effects you can, kind of expect in that situation. Dr. Moyad is going to ask your questions that have previously been submitted, and if you have questions during the talk, our helpline is on with us now to answer. I hope you find this presentation informative.
Thanks. So yeah, you've known me, we've known each other for years, and you've watched my hair turn grayer and grayer as the time has gone by, but that's just life, right? But thank you all for the invitation, first of all, and appreciate the opportunity to be here again. It's also very, very nice to actually get to see people in person without having to either hide behind Zoom or a mask or both, which I think we're all over and done with. I like to remind people when I do a talk about radiation therapy, like, what are we doing? It's mysterious enough. People are scared of radiation, right? You go to the dentist and they put a lead drape on you, and we have all these warnings about it. How does radiation kill things, whether they're good or whether they're bad? It does so by breaking DNA, and that's what you see in this slide. That is the target for all radiation therapy. It doesn't matter whether it's a proton or an X-ray or a gamma ray coming off a brachytherapy source. That is our target. And everything we do with our different technologies is to try to create as many breaks in that DNA strand as possible. Why? You break the DNA, the cell can't divide. It dies when it attempts to grow. And we're very fortunate in that by and large, malignant cells, not all of them, but most of them, are less able to repair that type of injury than their normal counterparts. So you're somewhat more likely to kill the bad stuff than the good stuff. In certain cancers, the difference is great. In many of them, it's actually very modest, and that can make it more of a challenge to try to control them. So, the history of radiation therapy actually goes back to shortly after the discovery of radiation. 1895 is when Röntgen discovers X-rays, Becquerel discovers natural radioactivity. Within a year of that, people were, using this as a weapon to treat primarily skin tumors and other things, because they had seen that if you bombard somebody's skin with X-ray, this funky thing would happen. The skin would get red and fall apart. So people started doing that well before the turn of the 20th century. Unfortunately, there's a lot to learn, right? There was a lot of good things to learn, and there were a lot of bad things to learn. And one of the bad things that we learned is that radiation is a toxin. No kidding. We think that's intuitively obvious to us now, but it wasn't even through the early days of the 20th century. And the monument you see there in the background of that slide is a monument in North Germany to what are called the radium martyrs, the men and women who in the early and not so early days of radiation therapy died because of exposure to the equipment that they were using. A lot of physicians, a lot of physicists. So you've always got to keep in mind that radiation is a powerful tool for good, and it's also something which you cannot ignore because of its potential for harm. We have some basic tenets that we use in radiation therapy. It's our holy grail, whatever you want to call it. The first is that there's no such thing as radiation resistance. There are levels of it, but if we give a high enough dose, we can kill any living cell. As I mentioned a minute ago, malignant cells are somewhat less able to repair that damage, and that's how we're usually able to kill cancers without killing the person that they reside in. And there's the toxicity of radiotherapy is beyond dispute, but what is somewhat controversial is there a threshold? Is there a level below which there is no harm? And that has been debated for a long time. It will probably be debated for a long time, but we have a principle in radiation therapy. The acronym is called ALARA, A-L-A-R-A, which means as low as reasonably achievable. In other words, you want to give normal tissue as low a dose as you possibly can, because that's the only way we really know that we can avoid side effects. The one guarantee to prevent a radiation side effect is if I don't hit a tissue, I'm not going to harm it. And that's, we'll be hearing a lot about that in the next 25, 30 minutes. So if you look at how we've advanced radiotherapy, Kicking in mind what I just said a minute ago about, how it works and there's pros and cons. We've done all of these things technologically to try to become more specific as to where we put the dose. And all these modern technologies really have some pretty, relatively remote antecedents. Whether you're doing IMRT, whether you're doing protons, whether you're doing implants, they're all ways to try to use the physics of the modality to become more specific. And why do we do that? Because we understand the physics a lot better than we understand what we'd like to understand, and that is the fundamental radiation biology. People were using radiotherapy as a weapon for over 50 years before it was discovered exactly how it works. That picture I showed you early on about the DNA molecule, that comes from the 1950s, 1960s. So half a century of delivery before understanding fundamentally what we were doing. And now we know not all cells respond the same way in a tumor to radiation, and there may be some cells that are radiation resistant because they have better repair mechanisms, and some patients cannot repair damage as well. That's also being elucidated. For the time being, we're stuck with physics. So all of these different modalities are physics-based. That's the lever that we pull because it's the one that we can pull. And if you look at modern X-ray therapy, IMRT, very, very good stuff. What you can do is you can concentrate the radiation doses, of course, the prostate patient, you can concentrate the radiation dose, the highest doses, in the target, whatever that target might be. The downside to doing this with X-rays, potentially, is that the beams don't stop. To get that high dose here in the center, this is a volumetric arc plan, VMAP, very good X-ray therapy. To get that dose here, you're giving a bath of radiation, lower dose, but still not insignificant, to everything else. Is that clinically a problem? Most of the time it isn't. We treat lots and lots of people every year, and we cause very few severe injuries. But there are issues with this, and even if you take it up a level, in a perfect world, why should I treat this person's intestines and bladder if the problem's in the prostate? Or if I'm treating a breast cancer patient, why should I treat her heart if I don't need to? That's a compromise you have to make with X-rays because of their physical nature. And this is how, you'll hear how protons are different in that regard. And the reason, first of all, what is a proton? The subatomic particle. It comes out of the atomic nucleus. In fact, it's the most common particle in the universe. The fact that it has a mass and an electric charge determines its properties. When you shoot it into anything, whether it's a person, into a water tank, doesn't matter. The person who first discovered this difference, this rather august-looking gentleman here, William Bragg, 1903, he is working in Adelaide in South Australia, and he is shooting helium ions into a water tank. And he's measuring the radiation dose deposited as a function of depth. And what he finds is that when the particles are going fast, there's really very little ionization, little radiation. It's when they get slowed down in these last few millimeters of their travel, you get this big spike of dose. And then once you get to this point, the particle stops. The dose drops to zero. This is now called the Bragg peak, named in his honor. William Bragg, 1915 Nobel Prize recipient in physics for other work he did, your typical underachiever. He pretty much invented the field of X-ray crystallography. But this is what our proton radiotherapy is all about. It's based on this physical phenomena. Remember, pulling the physics lever again. You can stop these particles at a point in space and not give dose beyond them and give a lower dose on the way in. The Australians are completing their first, finally, Proton Center in Adelaide, which is named the Bragg Center. It's supposed to open in either 2024 or 2025. They've named it after him in his honor, which I think is pretty cool. But, when you look at how we do radiation therapy as a radiotherapy community, very few people have access to protons so far because of the expense, because of the complexity, et cetera, et cetera. So most patients, especially most prostate patients receiving external beam radiation, they're treated with IMRT, intensity modulated X-ray therapy. That's become our standard because it's really good treatment. It lets you do things you couldn't do in the past. When I was a resident, we would learn how to draw squares and rectangles on a piece of X-ray film. That's what we would treat. Did it work? Yeah. Did you treat a lot of extra tissue? Heck yeah. IMRT, computer control, revolutionized that. We're not going to turn the clock back on that, but I think it's important to realize that this technology was introduced, again, purely because the physics of IMRT looked better than the physics of its predecessors. Because I hear a lot, and I've been hearing this for several decades now, well, you haven't done a randomized trial of protons versus IMRT, and I'll say, you're absolutely right, we haven't. By the way, where was the randomized trial of IMRT versus 3D conformal? Good luck finding it. It was never done. It was adapted as the standard because of that improvement in physics. And what's holding proton therapy back is, to some extent, the complexity, which is getting to be less of an issue, and also just the cost of delivering the treatment, which is also becoming less of an issue. So Bragg discovers the Bragg peak in 1903, and you go fast forward to 1946, and you have this gentleman who, if you've heard me talk before, you know him, somebody I deeply admire, Robert R. Wilson, who was the physicist, not a physician, the physicist who wrote a paper in July of 1946 saying, in effect, you know, if you could stop those particles where you want them to stop, that's a good way to spare normal tissue. His background, born in 1914, he was born in a town called Frontier, Wyoming. That's actually the name of the place. He got his PhD at Berkeley with Ernest Lawrence, who was a Nobel Prize-winning inventor of the cyclotron. He was the youngest division head at Los Alamos during the Second World War. Now, he was in his early 40s. In fact, his division was responsible for separating U-235 from U-238. So much of the uranium that was used in Little Boy came from the labs that he was running. And after he left, at the end of the war, went back into academia, in the mid-70s, he became the founder of the Enrico Fermi National Laboratory, which is the U.S. premier fundamental high-energy physics lab out there in Illinois. He is also an architect. He designed the headquarters building. He built these multi-ton sculptures on site. He ensured that there was a herd of buffalo, because it's a prairie site. I'm not making that up out there. And he and his wife are actually buried there. Just a fascinating, fascinating man who I had the pleasure of meeting several times when he would come to Loma Linda. Great guy. So proton therapy, he writes his paper, 1946. Well, that's great. Couldn't do it. Was first done in the mid-1950s. That's this upper left-hand picture. This is a picture from the Lawrence Berkeley lab where they have protons coming out of this nozzle, and they hope this is a head and neck cancer patient. You can see how comfortable they look and how well immobilized they are. That was what best they could do then. It wasn't until the late 1980s that a medical proton center was built. And that's the Loma Linda facility. And this picture here on the right is from April 1988 at the groundbreaking. I was just about finishing up medical school when they took that shot. And the way Loma Linda was designed and the way that most of the new facilities have been designed is as so. You have one accelerator that serves multiple treatment rooms. So you're not treating concurrently, you're treating sequentially. You're treating a patient in here while you're setting people up here and here. This is a schematic of our facility. We have 5 rooms. We have all sorts of other ancillary stuff, including anesthesia for the kids that we treat. But that is the way that most proton centers were built until about 7 or 8 years ago. And what's happened since then, like everything else in science, is that they've gotten smaller. And you can now take this 5-room facility and you can make it the size of a tennis basketball court. And it gets even smaller than that. In November of last year, Stanford announced that they're going to build a 1-room proton center that fits in a standard radiation therapy vault. You don't need a bigger building. You don't need this other ancillary equipment. So once that comes to fruition, that opens up lots and lots of possibilities. Smaller hospitals can get it, et cetera, et cetera. The way that we deliver the treatment at all the newer facilities is we use electromagnetically scanned beams. Think of it as a 3D printer, putting in dose and layers through the target. That lets you get very creative. It lets you give differential doses. I'll be showing some stuff about that in a second. It lets you treat really large, really irregular shapes. This is an advancement over the way that we did things back into when proton therapy was first being used clinically. So if you look at our current status of proton therapy in the United States, we have over 40 operating facilities, which is up from 1 when I started in this. They're virtually all using scanned beams if they can. The majority of them now have the same type of imaging that we use for X-ray therapy. We take 3-dimensional pictures of the patients each day to line them up. And the majority of the new facilities are small. They're 1 room, they're 2 rooms, which means that you can put them in more locations. And as I mentioned a minute ago, Stanford is going to be the next site in California to actually operate a proton center, unless UCSF gets off their duff and finally beats them to the punch. That's a map of where they are. They're not evenly distributed. The vast majority are East Coast and Midwest. In fact, if you look at this map, most NCI comprehensive cancer centers either have protons or they're getting them. So you've got protons at Mass General and protons at Memorial Sloan Kettering and Johns Hopkins and University of Pennsylvania, Mayo Clinic, et cetera, et cetera, et cetera. So it continues to grow largely because the machines have become cheaper and smaller and easier to install. So we'll talk now about prostate cancer in particular. This is a bit of a joke to myself. A new and experimental treatment. I hear this all the time. I've been doing this for over 31 years in real patients, and I'm still told by people who should know better, usually physicians, oh, it's new, it's experimental, there's no data, nothing's ever been published on it, et cetera, et cetera. Well, I was digging around at work on Thursday, and I came up with this paper, which I was aware of. This is the first paper in the medical literature about treating prostate cancer out of Mass General, and it was published in 1979. So not exactly new, experimental, never been done, nothing, there isn't any data on it. We've been doing it for a long time, and there's a lot of data on it. And as you'll see, it's one of the many, not the only way, thank God, one of the many good ways to treat prostate cancer. How do you plan your patients? Pretty much the same way you do it with X-ray therapy. Everything is dependent upon making a three-dimensional model of what you want to treat, and also dependent upon making sure the patient is in the same position each day. And that's not trivial. I showed you those beams. I showed you that Bragg peak coming to a stop. That's 2 to 3 millimeters. It's not easing to a stop. So if I've got a patient on the robotic table, I've got to make sure that those layers of dose are being painted, not in their hip, but in their prostate, not in the heart, but in the breast, et cetera. And it all comes down to planning and doing things to make sure that delivery is accurate. So in prostate, the real key, multimodality imaging. Not just doing CT scans like we used to do in the past. Thankfully, no. Doing MRI, PSMA PET. These things have revolutionized what we do. They all show you something different. The MRI in of itself shows you detail you don't get on the CAT scan. And it can show you things like, well, hey, here's an area I want to give a higher dose to because there's more disease there. Oh, by the way, here's a neurovascular bundle I don't want to treat or I want to spare. That's data you get from the MR. The PET, of course, can show you similar things and also other areas you may want to hit. These are all synergistic. We're fortunate at the Proton Center that I'm at, where we have in one room, MRI, CT PET, and regular planning CT. They're all in a horseshoe, so we can use them to our heart's content. As I'm sure many of you are aware, the F18 PSMA PET has been around now in some respects for several years, but really as a generally available tool for just over a year. And we started doing that at the Proton Center in last, I think it was October of 21, as soon as Medicare started approving it. And it's fantastic. It lets you see things you wouldn't see otherwise, and if you can see it, you can target it. And that's exactly what we do. Again, an example that I think almost everybody here is familiar with, patient who has disease in the prostate, also has a positive pelvic lymph node. So guess what? You can pile higher dose in that area because you know that area is involved. Now, if you're doing your typical plan, especially the way we did it a couple years ago, you start with the CT. This is back when we were using balloons a lot before we had hydrogel. And CT just kind of gives you a grayscale image. It doesn't tell you much beyond that. But same patient, that's the same person. Here's a typical multiparametric MRI. And you can see here in the right side of the prostate, there is a discernible nodule. That's extra disease. Guess what? Let's pile extra dose in. If we can see it, we can target it, and we can hit it. And that's exactly what we do in the planning. This is looking at it using another signal processing technique. You see the same thing that confirm that's malignancy. And then when you do your treatment plan, it's a little bit subtle, but you can see the hottest spot is right there where that disease was, not just turning up the dose to the entire prostate, trying to be specific as to where you punch the hardest. That's looking at the same patient, cut down the middle, showing how we're able to stop the dose and avoid the bladder, avoid the majority of the rectum. Okay, let's talk about some data. Does this stuff really work? I mean, again, there are lots and lots of papers. There are over 700 papers that I'm aware of doing literature searches in the literature about using protons to treat prostate cancer. And don't worry, we're not going to talk about all, but except maybe about 2 or 3 of them. That's it. So one of the ones I was pulling out when I was doing some research for this talk earlier this week is a really good, really large data set from MD Anderson, University of Texas. They've had protons since I think about 2005, 2006. And this is looking at almost 3,000 patients that they have treated there. And they're different risk groups and all the things that you'd normally expect. And they've been followed now for a long time. The median follow-up is 7 years. Some of these patients are twice that far out from their treatment. And they've used the typical definitions of failure, PSA going up more than 2 nanograms per ml, the Phoenix definition. And to cut to the quick, here's what they found. Like everybody else sees, in the low-risk patients, the ones that we hardly ever treat anymore, the cure rates are incredibly high because the disease is so incredibly minimal. Now, again, these are patients that you probably never see now, but I saw a lot of them up to about 2010, 2012. But even for slightly more advanced disease, the 5 and especially the 10-year rates are good, right? You're over 90% free of disease. And as you move up this ladder, of course, these numbers come down, but they're still relatively reasonable. So you've got good long-term data in this study and many others saying that this is one of, protons are one of the many ways in which you can control prostate cancer. University of Florida did a similar analysis where they were comparing patients that they treated with protons at their proton facility to patients who were treated with IMRT, also at University of Florida. Again, reasonably long follow-up. The groups both had hormonal therapy, generally about the same in either group, but a little bit more at the IMRT. First thing to point out, there was no difference in the older patients in the outcome over age 75. They didn't see any difference at all, which is something that's also very repeatable. But when you look at the low-risk patients, again, that group we don't treat much anymore, there was about a 5% difference in disease-free survival in that between those two groups favoring protons. They saw a slightly smaller difference in the intermediate risk patients, and the high-risk patients, they didn't find any difference whatsoever. And the suggestion was that because they were giving a higher dose in the proton patients, that's perhaps why they were getting a better outcome. And when you talk about higher dose, you worry about toxicity. But if you limit the amount of normal tissue that you treat, you can limit the toxicity. And the stuff that we worry about in terms of side effects are what are called grade 3 or 4 or 5 events, the showstoppers. And they were extremely low in either group, but they were somewhat lower in the proton patients, probably because you treated less of the bladder and less of the rectum. Northwestern has done a big database analysis, also looking at their proton patients matched to radiation, to X-ray therapy. And probably the biggest points from this were, first of all, they did see a survival difference. Not is the disease present or not, has it come back or not, but is the patient alive? And they saw that in favoring the proton patients. Why? Because of second cancers. There were fewer second cancers in the proton patients, likely because there was less normal tissue being treated. And there's another paper, I'll be touching on this in a little bit, about the same thing. And these were primarily cancers in the pelvis, like the bladder, and also leukemias. The more normal tissue you expose to even moderate doses, the more likely you are to cause those problems. So if you can limit that, you can reduce that risk to the individual. And even though I have doctors tell me, well, it's adults, it doesn't matter. Like, well, 70-year-olds are going to live 15, 20 years. It matters to them. 75-year-olds are going to live 10, 15 years. It can matter to them as well. So it's not something that you just shove under the rug because a person's no longer 18 or 20 years old. This was another large review that we did. It was called the PCG Proton Collaborative Group. Again, just doing a big comparison where we're treating patients with advanced prostate cancer with protons versus similar patients treated with IMRT. And what we found is that using protons to treat these patients, because we were treating the pelvis, they tolerated it better. Hardly a surprise. You're not treating all this intestine like you have to with IMRT to treat the pelvic lymph nodes. Now, second cancers, it's a big deal. Protons are felt to be the treatment of choice in kids. We hardly ever get any pushback from an insurer about treating a 10-year-old, 12-year-old, even about to age 21. Oh, no problem. But what about adults? Oh, that's all different. I've had to fight on 22 and 23-year-olds. This paper came out of almost 3 years ago out of Stanford, where they did a big analysis, I mean, looking at lots and lots of charts, and there's all the detail in how they did it. In essence, what they did is they looked at the 10 most common adult cancers, and they looked at patients who either got 3D conformal X-ray therapy, which was the standard of the 90s, or IMRT, today's standard, or proton treatment. And they looked at the rates of second cancer between all those different forms of radiation therapy to see if there was a difference. And they found a couple things, of course, that were pretty interesting, right? The first thing they found was that between 3D conformal X-ray therapy and IMRT, there was no difference in second cancer rate, which surprised a few of us. We thought IMRT might be actually a little bit worse. But perhaps the most important thing is that the rate of second cancers in the proton patients was less than 1/3 of similar patients treated with either 3D conformal or IMRT. And this wasn't just a statistical fluke, because you see it across all the age groups. You saw it in 9 of the 10 adult malignancies that were looked at. The only one we didn't see a difference was in lung, probably because it's such an abysmal prognosis anyway. And even if you exclude the prostate patients, you still see it. The breast cancer patients, you still see it. They came up with this other analysis where they said, you see this early. It's not something that happens 20 years out. You start to see this significantly as soon as 5 years after completing radiation therapy. So there's not a lot of comfort in telling a 70-year-old, don't worry, it'll take 20 years to get your second cancer if it's something they may see in 5 years. And this was the scatter plot they did with, with all these diagnoses except for lung. There was a much lower rate of second cancers in the proton patients versus those treated with X-rays. Well, I showed you that picture earlier with the MRI where you could see the disease. And this has become a very hotly investigated topic now in prostate radiation therapy. Why don't we hit those areas harder, right? That's the concept. What can you do to pile more dose in there? And there are lots of ways to do it. We do it with protons, people do it with brachytherapy, people do it with X-rays. And there are a couple studies that have suggested that if you do this, you're going to get a better result in terms of cure. This first one that got probably the most press in the radiation oncology world is this thing called the FLAME trial. And it was randomizing gentlemen to either radiation therapy to a certain dose alone versus radiation therapy, same dose to the entire prostate, plus a boost within the prostate gland, a significant boost. And this was reported out about 2.5 years ago. And what they found was that there was a statistically significant advantage, that's the red line, in the patients who got that higher dose within the prostate, both in terms of reducing recurrence in the prostate and reducing the risk of this disease showing up elsewhere. If you destroy the cancer in the gland, you do a much better job of reducing metastasis than if you can't. So as a consequence of this type of data, we're all doing what we can to try to boost the radiation dose within the prostate gland. And they came up with some theoretical graphs saying if you could get the dose up to around 95, 97 gray, you might be able to reduce those local failures to close to 0. And that's what we're looking at now. We're giving doses in that dose range to see if we can really sterilize the vast majority of tumors in these patients. So their conclusion, as I've just alluded to, was that higher doses were better. That's the take-home message. We have all the statistical stuff saying it's better. It's better. It makes sense. The higher the dose you're able to give, the more likely you are to destroy that cancer. Oligometastatic prostate cancer. Nice big word, huh? It just means, well, it means different things to different people. The definition of it kind of bounces around depending upon whose paper you read. But in general, it's felt that if you have 5 or fewer sites of disease outside the prostate, whether those are lymph nodes or bone, that's considered oligometastatic or minimally metastatic, not widespread. And back when I was a resident and up till not too many years ago, we were all taught if you've got one site of metastasis, you're going to have 100. That's just inevitable. That's going to show up here, there, and everywhere. But maybe that's not the case. This is not a new idea. Again, if you go look at the history of trying to treat these patients aggressively, it goes back to before World War II. There was a report in the literature of a patient with renal cancer, solitary lung met, had both removed surgically, lived over 2 decades, and died of natural causes, never had a recurrence. Well, now that our technology allows us to find these sites of disease early And also now that we have some pretty good systemic therapies, maybe it makes sense to treat these patients aggressively. This is an example of a patient I finished treating last week. He had a solitary metastasis to a left rib. We were able to paint the dose in the rib and spare, the adjacent lung. You can do this again with a bunch of different radiation modalities. The point is that treating these patients aggressively seems to be beneficial in many ways to them. And there have been a couple of trials that really opened up people's eyes. This first one was called Saber Comet. As you may imagine, part of having a good trial is having a good name, good acronym for it. You want to have something which kind of catches the eye, catches the ear. This was looking at patients with all sorts of different histologies, whether it was prostate, breast, colon, didn't matter. And it looked at some patients who either got best standard treatment or the same standard treatment plus those sites were ablated with radiation. They wanted to see if there was a benefit. And of course, again, they found that there was. You increased the median survival. So the patients were more likely to live longer if you treated them aggressively. You gave them a significantly higher 5-year survival. I mean, these differences are not trivial. And you also decrease the rate at which they progress. So at the very least, what you get out of this, if you treat these patients aggressively, is you slow things down, right? You're slowing down the progression. And in the case of prostate cancer, as I'll show you in the next couple slides, that means for many of these patients, you're able to give them a holiday from everybody's favorite systemic treatment, ADT, so they have some better quality of life. And the prostate trial I'm alluding to is this one. It's called the Extend trial. Very similar to Saber Comet, except that they were looking at just prostate. Everybody got 6 months of hormone therapy. Half the gentlemen at 2 months of hormone therapy got radiation to the sites of oligometastatic disease. The other half didn't. There weren't that many patients enrolled. This data is still maturing, but it's very clear if you look at the results that have been published to date that they're highly favorable to those individuals who are treated aggressively. You're able to keep them off hormonal therapy for longer after that 6 months has expired. You're able to reduce the rate of progression in some of these patients that we haven't even gotten to the median rate of progression-free survival yet. And that was their conclusion, is that if you did aggressive stereotactic radiotherapy, again, whatever technique you have, you're doing these patients a favor. It's a win-win. You're keeping them off ADT, you're reducing the rate at which they progress. So, can we do this with protons? Of course. I showed you a picture 4 or 5 slides back where it can do it. You can do it with X-rays. The cancer cells could care less. They don't know what they're being hit by. That ionization, that DNA damage is the same. So we tend to get in protons the patients who have had high doses of prior radiation in that area, and we're trying to spare normal tissue because we can do a better job of it. Or we get patients that have disease that's in really tricky sites to treat, like around the spinal cord. But it doesn't matter what modality you have. Most of the world is not a proton therapy. The point of this is you hit these things hard because you're going to benefit the individual. You don't just tell them, sorry, Mr. Smith, you've got metastatic disease, tough luck, stay on hormone therapy, and leave it at that. I get asked this a lot about partial gland treatment, because there are potentially some advantages to it. Let's treat part of the prostate, right? And you spare normal tissue, you spare the neurovascular bundle, you preserve erectile function much better, you're not going to have as much of the rectum and bladder treated, et cetera, et cetera. Why do you want to treat the whole gland if there's only disease on one side? I mean, that all sounds great, but there's some risk to it. And the biggest risks are that we often underestimate the bulk of disease just based on our imaging, even with our fancy imaging and even with random biopsies and MR-guided biopsy. If you look at gentlemen who have surgery, and you look at the percentage that have multifocal disease, it's pretty darn high, which is why the standard approach is still to either, you operate, you take out the whole gland, or if you radiate, you tend to treat the whole gland. There are a lot of ways to do partial gland treatment. You just pretty much pick the way you want to do it. If you're going to do it, you can do cryo, HIFU, nanoporation, radiation, et cetera, et cetera. It doesn't matter how you're doing it, the goal is still the same, just to try to ablate that portion of it. I can tell you that my personal clinical experience with this, which is entirely anecdotal and based on a grand total of 2 patients, is that it doesn't work. At least it hasn't worked the way I've done it. What I've seen is that the patients I treated are kind of like the guys that come to me who've had other modalities to treat partial prostate. They fail right at the edge of where you treat it. So if they had cryo, they fail at the edge of the cryo cavity. If they have proton radiation, they fail just past my high dose area. Now, that's anecdotal, and they're, you take it for what it's worth, which may not be all that much. Remember, I don't see the ones that don't fail, right? I only see the ones that have problem. But because of what I've seen in my personal experience, I'm just not a big fan of it right now, because I think that the risk of recurrence and letting disease sit there and potentially progress, leaving that patient at risk for metastasis, is a little bit too high. We'll do some quick examples of plans when we're doing our treatment, using our intensity modulated proton beams. This again is prostate with an intraprostatic boost. And now you can see, of course, we're using the hydrogel, which is markedly reduced rectal bleeding. In fact, it's down to around less than 5% of our patients versus 25%. Same patient, again, cut down the middle, but you've got the dose in the prostate, and you're sparing the doses to normal tissue. This is a gentleman that's currently under treatment. I'm treating his pelvic lymphatics. Oops, I'll go back to that if I can. There we go, good, wrong button. That's the pelvic lymph nodes are up here. He's got 2 bone mets we're also treating at the same time, one here, so we're able to separate the dose to all those areas and get very clever with our dose painting. Looking at him down the side, we're treating his lymph nodes, we're not treating his intestines, and we're doing a good job of boosting the dose in his prostate to the areas that have the greatest amount of disease. This is a solitary oligometastatic site patient, also just finished treatment, had a pelvic lymph node, getting treated up here, high dose there, and not giving anything up here. Postoperative patient, also a person under treatment right now. We still use the balloon in them because it's hard to put the gel in, but the goal is to treat the prostate bed, boost it, get rid of the disease that's there, hopefully render that person disease-free. And again, you can see him on a side picture. Future developments, I'm going to just touch on this really briefly because I think that it's kind of fun to talk about, but at the same time, the point of this meeting is more talk about prostate cancer. The Bragg peak is our biggest strength in proton therapy. It's also our biggest challenge because we have to know where to put it, right? We've got this beautiful tool that comes to a stop, but if you don't stop it in the right place, you're not doing that person a favor. And how do you know you're stopping it in the right place? Well, we've got all these different ways to do that, but they're all based upon physical assumptions. So we'd like to have ways that we can measure this, and we're coming up with that. I'm going to go through these pretty quickly because I don't think I want to dig into the weeds. But for example, one of the things that we're experimenting with now, and this is going in throughout the proton community, is doing things to change our delivery. Maybe deliver in an arc, not deliver in a static field. Perhaps we can look at ways to verify the radiation dose we're giving to the patient in real time, using techniques called prompt gamma and some other stuff. We're looking at better computing systems to take the radiation biology, the linear energy transfer into account. And we're looking also at real-time image guidance improvements like you have in X-ray therapy. The MRI guidance of X-ray therapy has gone from being something under development to something which is now relatively commonly available. People are doing the same thing in the proton world. And I think I'm going to stop at that point because I've got slides on this, but they're more, again, the interest is, it's not the same. It just shows that, like everything else, we are improving what we're doing, which is the job of medicine, right? The goal of all this is to get to the point where none of us are ever sitting in this room again talking about this stuff. That's what you want. I don't want to get it. That's where we're trying to go with this. But proton therapy, because of the fact that it's now more widely available, and because the technology is getting less expensive, like everything else in medicine and other technologies, we're able to develop it and improve it, and we're doing the same improvements and trying to do the same advances that come straight out of the X-ray therapy world, whether it's delivery, imaging, et cetera, so that we can be more specific in what we do and hopefully be more beneficial to the people that we need to treat. All right, thank you very much. Appreciate your attention and your time.
Dr. Rossi, fabulous. I haven't seen you in a while.
Same.
He did this meeting, was it 2018, 19?
I think it was 2019 when we were over at Marina Del Rey.
We did 1 year, we moved over to Marina Del Rey to the Marriott. And that was a great event too.
Yeah.
So I actually remember your lecture. And
glad somebody did.
I do. I know, it's good because I want to ask you a couple of things from that lecture that I couldn't ask you about 4 or 5 years ago. I'm sure you remember what I'm talking about. I want to ask you a few things, though, but it has nothing to do with prostate cancer to begin with. So I looked at your bio, and here's what it said. It said, Dr. Carl Rossi, when he's not caring for patients or conducting research, he enjoys running, which I know, because you and I are avid runners. Cycling, which I know. I don't cycle as much, but that's okay. Traveling, I know, because you travel a lot. And then here's the one that made me double take. It said, and flying.
Yeah.
And I thought, what's that mean, commercially? And then I thought, I wonder how he got here today and how you get around. So you mean you fly airplanes?
Yeah, I've been doing that for 35 years.
Okay. Wow. And you flew in this weather?
Yeah.
Okay, and you have a big insurance policy.
You've been talking to my mother?
So I'm impressed. I didn't realize that.
No,
and the other thing it said that I never looked at is it said you treat prostate cancer and it said lymphoma.
Yep.
Can you just quickly cover that? I just never knew the lymphoma part.
Yeah. So lymphomas are tumors of the lymphatic system. I mean, the one that most people are familiar with is Hodgkin's disease, which was actually a success story in cancer treatment. That was a universally fatal disease up to the late 1940s when the radiotherapy techniques were first developed to treat it. And what's changed over the last 30, 40 years, again, we learned the hard way, is that there were a lot of people cured of Hodgkin's in the 40s and 50s and 60s with radiation. Unfortunately, 20, 30 years later, 15 years later, they started dying of heart disease, second cancers, pulmonary fibrosis, et cetera. So in oncology and in treatment of lymphomas, the treatment has now gone to try to get the best of both worlds, where you will do chemotherapy to attempt to eradicate the majority of the disease, and that usually works really well on the microscopic stuff. It doesn't work so well when you had a 10 or 12 centimeter mass in somebody's chest, because the drugs never get there in the appropriate concentration. So we will use radiation to consolidate the chemotherapy response. And the reason that you do that I like to do that with protons in kids or adults, is sparing healthy tissue. You want to minimize the chance of causing a problem, because you're going to cure virtually all these patients. So, do you want to cure them and make them need a heart transplant 10 years later? I had a radiologist attending at Loma Linda that was also a pilot, and she had been treated for Hodgkin's disease about 25, 30 years earlier. And she passed away not from a malignancy from that, but she passed away from what's called pulmonary fibrosis. In essence, her lungs just became scarred and there was no way to stop it. And it was every bit as terrible as any cancer you'd ever see. So that's why we treat lymphoma with protons. At Loma Linda, I did a lot of pediatric lymphoma. Here in San Diego, I do primarily adults because we have somebody else who does the pediatrics.
Okay. It also said on the website, more than 13,000 prostate cancer patients have been treated with protons over the last 31 years, more than any other place in the world.
No, I mean, I got stuck doing this fortuitously. I just happened to do my residency in radiation oncology at Loma Linda when they were building the Proton Center. And we treated our first prostate patient. His first day of treatment with one of my guys was October 8th, 1991. The second guy we ever treated was the physicist who designed our machine, by the way. Anyway. Really? Yeah, oh yeah, who lived to 101, 102, and passed away from other things. But, I mean, I just happened to be there when it all started, and my attending, Dr. James Slater, the picture I showed you, about 6 months into this, we were getting busy, said, well, we're kind of busy. Do you want to stick around for a couple of years and maybe help out? And that was 1992-ish, and a couple of years became 20 plus, 25.
So, yeah. Look, I don't have a skin in the game, so that's the fun part about my job.
Yeah.
So then why am I going to other places that are popping up that are proton centers when this place has treated so many people with the same individual? So I always find it interesting how when it comes to surgeons, everyone says, well, you have to have the surgeon that does the most surgeries. And now we're evolving in prostate cancer to say, well, you want to go to the person who does the most second reads on pathology, like Epstein, right?
Yeah.
So now we're accustomed. But my argument is, why are we giving the other people a free pass? Like I told Czernin, I want the #1 person who's reading PSMA scans. I don't want #2. I don't want the silver medal. So with all these proton centers coming up, I appreciate that, but there's a learning curve.
Yep.
So, boy, this is not putting you on the spot since it's going on YouTube. But why, tell me the state of those and why I would actually consider them. And do you, in your mind, rank the centers that have experience, or do you ever help with that besides your own?
So, needless to say, you have to have more than one person or one group that can do this, or I'd never leave the building and probably never sleep, right? It's just from a practical standpoint, other people have to be able to do the work. And what's happened over the last, starting early 2000s actually, is that you've had these other centers open, many of whom, like when I was still at Loma Linda, we had the MD Anderson doctors spend several months with us. This is how we treat prostate cancer. And we had folks from Mayo, and we had folks from Mass General that spent time there. But over the last decade and a half, there are now so many centers at what I would consider to be centers of excellence, MGH, Mayo, et cetera, that have their own institutional experience and their own training programs that I think that they are entirely competent to do the same thing I've been doing. And when you look at the data that's published, that's why I showed data from other institutions. Those numbers are as good as, that Anderson data is as good as anything else I've seen that I've been able to generate.
Yeah, but how many years should a center be up and running before I feel like I want to be the next guinea pig?
Easy question.
I know you can't give me. I'm just saying, broadly speaking. Yeah, I don't want to be the first patient.
Yeah, I would like to see. Sure. So it's going to depend upon how they set their program up. So if you're, MD Anderson, for example, when they started, we had several of their attendings spend time with us, and we were proctoring their cases like you do with a new surgical procedure. I think that if a facility has done, I'd say 200 cases in a year's time, that they're going to be pretty proficient at it.
You're feeling better about that with 200? Okay.
Yeah.
No, I appreciate you giving me a number.
Yeah.
So now what's the deal with, there's a take on the internet with, because the internet's always right.
Of course.
So there's a take on the internet with insurance coverage and protons. Where are we with that? Is that still controversial, or can you just clear up the controversy?
Sure. Yeah, so I'd say it is slowly improving over like maybe a half decade at a time. So if you look at the history of proton therapy going back, all the way back, even back to the 50s, 60s, it was originally paid for by many insurers because these were patients of last resort. They had no other choice. In 1991, actually in February of 1991, so before we treated our first prostate patient at Loma Linda, Medicare, actually CMS, which is Medicare's parent agency, made a decision based upon that, in part, that work that was done at Mass General, to start covering proton therapy of cancer, not just prostate, but everything. And they've maintained that to this day. And the difference in the cost to Medicare is the difference in the cost of the treatment delivery. There's no difference on the professional side. If I treat with protons or x-rays, it's the same professional fee. But protons, because of the technology complexity, cost more, and they've been supporting that. They've made it quite clear in meetings I've had with them in the last couple of years that at some point, when that technology no longer needs the support, that difference is going to go away. But that's been a consistent position that Medicare has had. Private insurance is all over the darn map, and that's where you have more issues. Now, kids, everybody treats, it's an 18-year-old, go ahead, go for it. But I've had to fight for 22-year-olds because they're an adult now. Like, well, what happened on their 22nd birthday? They became miraculously radiation resistant. The biggest difference, and where we're seeing the insurers change, is not surprisingly, it's in the cost of delivery to the insurance carrier. If you can get the treatment to the point where insurer X is writing the same check, they don't care at that point. And we have contracts with a couple of insurers in California where that's exact for prostate, where that's exactly what it is. They pay the same cost, whether it's same case rate for IMRT or protons. And that's what they want. Because you talk to people about, unfortunately, and this is a really rude wake-up call when you're, kind of a starry-eyed oncologist. You go talk to insurance medical directors about, hey, look, I'm reducing second cancers, blah, I'm reducing other things, great. And they look at you and say, well, that's important, but we really don't care if it's beyond a year. And this is a conversation I had in particular with Lee Newcomer from United Health several years ago. I said, what do you mean a year? Well, we have turnover. We lose 50% of our patients in 5 years, so it's not on our books. Great. So the biggest reason that protons are becoming more widely accepted by the insurers, it's not because of data. We like to think it is. It isn't. It's two reasons. Number one is the cost of the treatment is lower. And the other is that there have been a significant number of patients that have taken their insurer to court and won for various malignancies that were not treated with protons, and that has gotten their attention. Okay. So it's a long-term project, and I don't think I'll see the end of it.
The part B of my previous question was, if you're ever comparing notes with other proton centers, are you seeing cure rates and toxicity differences between yours and others? And again, this is, I know, a delicate situation, but I got to think there's some compare and contrast going on. Because I'll tell you what made me think of this question. Before I came here, I was driving from up north Michigan, and I was coming down there, and there's a massive sign that said, "We have protons now." And I'm going, man, okay, this thing's everywhere. So I wonder how competent this is, you know? So, and I wonder what their toxicity rates are. So that's your question, cure and toxicity. Sure.
So we actually have a collaborative group called PCG, Proton Collaborative Group, that virtually all proton centers, including McLaren, is a member of. Okay. And we do publish. We have a number of registry, like there's a registry for prostate patients and stuff, and we look at this in a prospective fashion to see if we're detecting any differences in toxicity between facilities. For the modern centers that have been treating with, especially with scanning beams, I haven't seen it. But I can tell you that back in the earlier days, like when it was just Loma Linda and Mass General, we had a randomized trial that we did, and even though 70% of the patients were treated at Loma Linda and only 30% at MGH, the toxicity at MGH was substantially higher, not because there were a bunch of doofuses, but because they didn't have the ability to treat with a beam that went through the hips. They had to treat through the perineum, so they were treating more rectum. That, and they also screwed up their calculation in their proton dose. They used a method that gave them about a 5% higher dose than they thought they were giving, and that all came out in the wash. But if I look around now at the center, what are the center? I mean, a lot of centers of excellence. You've got UPenn now has 3 proton facilities. No problem with all 3 patients being treated. I don't see any differences. Haven't seen any at Mayo, although I've had a discussion with Mayo Scottsdale where they've said that in their post-operative patients, they've seen some toxicities that I haven't seen, and I can't explain it. But across the board, it looks very, very, very similar. And if you look at the PCG data, where we're looking at thousands of these patients, we're not seeing any red flags that this place is bad or there's some unusual toxicity.
So if we switch that topic for a second, what's all the rage lately, and we had in the meeting not too long ago, is this SBRT. And I'm sorry, it is attractive. If you're going to tell me I can be treated in 5 treatments and then I'm done versus coming back over and over again, and the toxicity may be the same, and I'm done in 5 days. And look, this is taken off in other cancers. So my question is, are you doing anything similar in the proton world, like a proton therapy, SBRT? Because that's big time competition, baby. Oh yeah, well, do we use proton SBRT in cancer? First of all, in cancer, the answer is absolutely. In fact, that's one of the ways that we treat liver mets. And all of those oligometastatic sites that I treat are 3 to 5 fraction SBRT. Now, you want to know about primary intact prostate. I want to know about primary prostate cancer. So can you give me 5 days and be done?
I can.
10 days,
let me tell you what will happen in my experience though if I do that, because I've done it. I've done it way back in 2019, if anybody remembers that far back. I had 41 gentlemen that were favorable, some unfavorable intermediate risk, that I treated with 5 fraction proton SBRT, 8 gray times 5, same as you do with X-rays, and that was done over in the space of a week. And I've been following them. And here's the good news and here's the not so good news. The good news is their biochemical freedom from relapse is every bit as good as what I see if I do this when I used to do it over 9 weeks and now I do it over 5.5. No difference. The not so good news was that 20 to 25% of them had persistent urinary bother that lasted for the better part of a year, and that required Medrol dose packs and other things to knock it down, and I don't see that when I go more slowly. Now, if you look at the SBRT literature with X-rays, you're going to find some places say that happens, some say it doesn't. So it's a little bit up in the air. The current national recommendations, the current NCCN guidelines for radiation say you can do this in 1 week, you can do it in 8 weeks. Our preferred regimen, based on the long-term data that we have, is 4 to 6 weeks. So I haven't been doing, because of what I saw with the urination, the toxicity, I'm not routinely offering it because I just didn't feel like, oh, I saved you, 4 weeks and I gave you 6 months of misery. That's a bad trade-off in a quarter of those patients.
So a friend of mine who went to see you was surprised how long it took when you just have to come in every day. What's the average treatment time when you come in for proton therapy, and how much of the day are you taking up?
I tell the gentleman, plan on being in the building an hour a day on the treatment days, which is 5 days a week. That hour, you're going to probably spend about 45 minutes doing what you always do in medical office, and that's twiddling your thumbs and hopefully finding a more recent magazine to read or getting on our wireless network and having some fun. You spend about 10 to 15 minutes of the hour in the treatment area. And of that 10 to 15 minutes, you're going to spend between 30 to 60 seconds being treated. Everything else is positioning. So everyone we treat, whether it's whatever part of the body, they're in some type of customized immobilization device, and they're on a robotic table, which has 6 degrees of freedom. So the majority of the time they're in the room, we've got them in the treatment area. There's imaging equipment built into the frame of the gantry, and we're doing volumetric imaging, just like you do in X-ray therapy, to adjust their position so that the daily position matches the planned position. So yeah, it's a lot of waiting around, and the actual treatment is very brief, but then after that, you get out and do whatever you want.
What do you tell patients about hormone therapy in terms of, in general, like a sweeping generalization of who you favor and who you don't favor to receive hormone therapy when they get protons?
So it's the same rules in protons with hormone therapy as you have in X-ray therapy. There's no difference. So who do we tend to use this on? Unfavorable, intermediate risk, high, and very high risk. And of course, it's the same duration. So
once you hit that unfavorable, intermediate, and high,
same thing. No different. As far as what I tell them, I think the medical oncologists and the radiation oncologists do a much better job of telling people what's actually going to happen when they're on ADT versus the urologist. That's just my impression. But it's telling people, look, you're going to feel it. By and large, you're doing this because it's going to give you a better result down the road. But you're going to be suffering for a while, and you just have to, there are ways to mitigate that. You have to accept it. Or, I'd say a third of the gentlemen that I have this discussion with who meet all the criteria for hormone therapy, whether it's short-term or long-term, they say, I understand why you're recommending it, I don't want to do it. And my response to them is, all right, it's an adult decision. It's something we've talked about after you've had a chance to make an informed decision. If that's your the way that you want to be, I understand, you're giving up this in terms of control, but it's your decision, and I still treat.
Now I want to go, what I want to spend the last portion on before I get to this. The last portion is going to be on oligometastatic disease. Okay. Because this is a pretty hot area. And I've seen doctors go to you and you've hit a couple spots, and the whole game of treating oligometastatic disease is amazing if we ultimately find that it works, right? But it seems to be working.
Yeah.
Okay, so I'm going to table that and talk about my favorite subject, which is the catches of radiation therapy. And I just want to go through some rules, and you just tell me what you say. So a lot of patients come in, and I asked you this when you were here many years ago. By the way, you probably don't remember the joke I told you when you first came in. It's 5-6 years ago. You laughed really hard. So I told him the joke that I said a neutron walks in a bar and says to the bartender, neutron, not a proton. This is for the geeks in the audience. I said, the neutron said, how much for a beer? And the bartender said, for you, no charge. See, you can tell you're older. You laughed. You thought that was funny when you were younger. Anyway, so a lot of patients in California, they like to take supplements, just like in Michigan.
Oh, yeah.
Right? This is a big deal.
Yeah.
And you know what? I'm sorry to say, but I am not happy with the way radiation oncology oncologists have handled the idea. They need an answer. And I know they come to me for this answer, but they need an answer from you all. Okay, if I'm taking a handful of supplements, and I'm coming to get proton therapy of any kind, even oligometastatic disease, one of the camps say, all right, what you're doing is you're preventing free radicals from being generated by the radiation, so you are limiting the effect of radiation. Another camp says it makes no difference. Radiation is so much more energy. Why are you worrying about it? I don't give a damn. And then there are some I bumped into that says, take all that stuff because it's going to help the radiation. What do you say to all the people? Like, I'm a fan of supplements, but what do you say to the supplement takers during the radiation course?
I tell them, and part of this is based on a discussion I've had with you on more than one occasion, where you've told me, and I tend to believe it, that we create so many free radicals that it probably doesn't make a difference. What I tell them though is, look, we have data from a head and neck cancer radiotherapy study, not prostate, the other end of the body, where patients were being given effectively a prescription strength antioxidant, because the idea was this could prevent them from getting other cancers in the upper air digestive tract, And in those patients, it looked like the radiation was slightly less effective at controlling their primary tumor. Whole different situation than what you're able to take, what you get at the health food store. That said, if you want to be, as conservative as you possibly can, stop taking the supplements during the treatment. You can resume the day you're done, because the free radicals that we create when we radiate, that's what breaks the DNA, by the way. It's an indirect effect. They last for about 10 to the minus 4 seconds after the beam shuts off every day. So, but that's what I tell them. It probably doesn't make a difference, but if you want to be, ultra conservative, then just eliminate anything which is a free radical scavenger during treatment.
Oh, that's helpful. And then what about diet-wise? Is it okay to get a lot of fiber in my diet when I'm going through radiation? Because what they say during some imaging and some of the radiation processes is if you create too much intestinal or rectal gas, you can make you can make the prostate move more than is usual. But I'm just saying, do you even worry about the diet side of it in terms of interfering?
Very little. If we have somebody, first of all, we're looking at these patients every day in 3 dimensions right before we treat them. So we get a volumetric picture of where they're at, and that includes looking at bowel gas. So we have the occasional patient where we'll look at the image and say, boy, they got a lot of gas. And then we'll tell them, yeah, you should probably get less gas. You'll be more comfortable. But we're able to adjust the patient's position in near real time to take into account anything that may have moved because they had, more stool, less stool, et cetera.
Okay, so if someone just decides they want to go plant-based during the radiation procedure and they get all sorts of fiber, you don't lose any sleep?
I generally don't.
Okay.
Yeah.
What about repurposed drugs? It's one of my favorite categories I'm going to end up talking about with Dr. Scholz in the next session. The repurposed drugs is the concept that very simple drugs that exist over the counter, a prescription that many of you may be taking, may have a secondary benefit in fighting cancer, and we didn't realize it until time went on and we did more research. The one that I see the most about with radiation, and I've seen in a lot of the radiation papers, the suggestion is cholesterol-lowering medication may increase the radiosensitivity or the ability to kill the tumor during radiation, but no one's ever tested it. This has all been retrospective data. So is it possible that if I take my cholesterol-lowering drug while you treat me with protons, I may get a better outcome, or what's your stance on that?
I think it's possible, but it's pretty tenuous. Is the way I would reply to that question. Just like metformin's another drug I think is beneficial, right? Even that one's there's some clear benefits, but not because it's synergistic with radiation. It's beneficial for other reasons.
Yes.
So it gets back to what I was saying earlier about how we understand our physics of this really well, but the biology of it's still a big black box. And ideally, what you'd like to have is drug treatments that would enhance the biologic effects of radiotherapy in one way or shape or form repeatably. And that still doesn't exist.
But you have no problem. I mean, you have no problem with them taking those meds.
No, and a very significant percentage of patients are taking them anyway, because of other medical issues.
Okay, so what you said in the last conference, which this was the one that stunned me about side effects, because I had never heard of radiation. I don't know if you'll remember, but I said, well, what happens after radiation or during radiation? What are some of the issues you deal with? And you talked about urgency and things like that. And I said, well, do you recommend anything? And at the time, I think you used the words Azomax, which is benazoparidine. You actually brought that up. I don't know if you remember, because you're the only person who's ever brought it up since.
Yeah.
So can you explain that, and if you still are an advocate of buying that over-the-counter product or getting it as a prescription? It's a urinary analgesic, basically, but are you still a fan of taking that during radiation?
I am, but it's not the first thing I reach for anymore. So, first of all, having urinary frequency and urgency during treatment is very common. That's the one. In fact, it's usually the only side effect I hear about from the patients. They don't get diarrhea, their blood counts don't crash, they're not getting nauseated, et cetera, but they're peeing more. So you tell them, first of all, what kind of liquids are you drinking? Because that can make a difference. Oh, I've been drinking my smoothies every day, made of 20 different types of fruit juice that all have citric acid in. Well, maybe you should cut that out for now. That can help.
So that's your number one go-to.
Number one. Number two, NSAIDs. The vast majority of these gentlemen, if you start telling them, I want you to take an Aleve twice a day, consistently with some food, you're going to knock this down. It's going to keep it under control. Not I tried it and it didn't work, meaning I tried it once and nothing happened. So if they're having urgency, I'll have them do Aleve or Advil. I probably have had in the last 6 months only 1 or 2 patients that I've ended up giving Pyridium to, because for most of them, the NSAIDs and controlling the type of liquids that they drink makes the difference.
No, that's important. So ibuprofen, so naproxen, Aleve, Motrin. Yeah. They take it when they have the urgency?
Yeah.
But what if they have the urgency for a long time? Are you worried that might increase their bleeding risk, or are you just?
Well, with the exception of the guys I treated with this stereotactic technique, that usually doesn't persist for very long. But the other thing I've done, you always start from simple and go to more complex. If the over-the-counter NSAIDs aren't doing it, then you got a couple of choices. One is to switch to prescription NSAID like Celebrex, which may reduce the stomach upset. But I've also had a lot of success by giving patients a Medrol dose pack.
So can you explain what a Medrol dose pack is?
Sure.
It's basically.
It sounds pretty cool, doesn't it? It's a steroid dose pack. It's used a lot for a lot of conditions, and we love using steroids in medicine because they seem to work on almost everything. So in essence, what you do is you have a prescription, and you go to the pharmacy, and they give you this package that says take 4 of these day 1 or 6 of these day 1, then you step it down a day, 1 pill each day. The intent is it's a pulse of steroids, which are anti-inflammatory medications. And that can, in my experience, can do wonders in terms of reducing the urinary symptoms. What you often have to do during treatment, if someone's having trouble, you want to break that cycle. Because if you don't, they're going to be miserable. But if you can do something just to get it under control, then after that's under control, you can back off. And now maybe taking ibuprofen, once or twice a day can help you.
So that's the short term. That's the bothersome stuff, the urgency. That's the short term. During the process, a little bit after the process, right?
Yeah.
Okay. Long term.
Yeah.
Oh man, oh man.
Yeah.
Man, oh man. I'm serious. Like 2-3 years after protons or something, still have a little bit of rectal bleeding. And so this leads to my bigger question, which is I still have not figured this out. If someone has chronic problems from radiation, God forbid, where do they go, first of all?
Sure.
Because, it's not, we have some reconstructive urologists with not many, but where do you go? Where do they go? And second of all, when they experience some of these kind of symptoms, and sometimes they're mild, but they're persistent in their pain. And what do you talk about with them?
So the first thing, of course, I try to do is get a good detailed picture of what they're experiencing and try to figure out if there are any other extraneous factors that are making it worse. But you're absolutely right. A lot of gentlemen after radiotherapy, they're going to have issues with frequency and urgency that can come on 3 to 5 years later. So in terms of how to treat that, again, I like to work from simple to more complex. And what I have found has been very beneficial, both for the rectal bleeding, which, by the way, is much less common now with the hydrogel, and also for the urinary issues, is hyperbaric therapy. Oh, yeah.
Thank you.
Oh, yeah.
I met him in the green room. We didn't talk about his answers.
This is not a softball. You didn't toss me a softball there.
No, I didn't talk. In my mind, it's a basketball, but I didn't know how you were going to answer it. But I can't tell the audience enough.
Yeah.
Look, hyperbaric oxygen therapy, or HBOT, I've written about a lot. And there's so many men who don't understand it's an option when they have those long-term side effects.
So many doctors who don't understand it's an option.
They don't.
That's the problem.
I have talked to so many people who've undergone protons, they've undergone every type of therapy, and then they suddenly walk into their local hospital and they say, yeah, you're approved. We'll cover all of your hyperbaric oxygen therapy treatments. And you have to sit in a chamber and watch TV every day and come back. But so many of these men come back and say, my bleeding, what I always hear is my bleeding's a little bit less, or it's gone. Because they get inflammation there that's helped. So you've seen that too.
Oh, all the time. We're lucky at UC San Diego in that, probably because it's a big diving medicine program, we've got a very strong hyperbaric medicine program. And the urologists also are used to working with the hyperbaric therapy doctors, because for a lot of insurers to improve hyperbaric therapy for, say, cystitis, you have to have a documented diagnosis. So they have to go get a cystoscopy, look inside there. Oh yeah, look, you've got, surprise, surprise, cystitis. and they send them to the chambers, and you typically after 35, 40 dives, people really feel better.
Yeah.
It's simple.
So you go in for a lot of treatments. It could take an hour or two. It's a high pressure chamber, but now they have them where you can sit with 10 other people. Yeah. They're large, and you just relax, and the idea is that it enhances the wound healing process. Yeah. We know it's not making things worse, so it's either making it better or the same.
Yeah.
And that's not a bad deal when you're dealing with a chronic radiation problem, right? Yeah. So we've tried to get the word out on that. I didn't even know that you were going to say that. Okay, then what about someone that has IBS, or they have other bowel issues? Okay. They have ulcerative colitis. They just have a ton of bowel issues, but they need to get radiation therapy. How do you deal with that?
So the conditions that Mark is mentioning are ones where at least with X-ray therapy, you try to shy away from them because they are very poorly tolerated. So in fact, if you look at some of the, like ASTRO, our professional society's recommendations for proton therapy, one of those is in patients who have ulcerative colitis or Crohn's disease, because the easiest way to not hurt them is you stop the beam before it gets there. So if it's Crohn's and it's in the small bowel, I can treat that any day because I can stop the beam before it ever hits the small bowel. Ulcerative colitis can be a little trickier because it depends upon where it is in the large bowel. So what I do with those gentlemen is tell them, first thing you need to know is it active? And if so, where is it active? So you got to talk to their GI doctor, and they have to have a colonoscopy. And if somebody comes in and says, I've got active UC in the rectum, then it's all right, this is a really good reason to make sure we get the biggest spacer that we possibly can into that, to move the rectum out of the way. You still tell them it's a higher risk because of the underlying ulcerative colitis, but whatever you can do to reduce the radiation dose is to their benefit.
You're still a fan of hydrogel?
I am.
So can you explain to the audience what this is? Because I still notice that a lot of people in the audience and around the country and globally will go to their doctor and then they'll just get radiation, and there wasn't a discussion of what should I get it or not, right?
Okay, yeah.
So can you talk about this gel that's injected that goes between the prostate and the rectum that's supposed to reduce toxicity?
Doesn't that sound delightful?
I mean,
no.
Remember, it was just a theory a few years back.
Well, it was a theory that was tested in a randomized trial.
Yeah.
Though. That's the point that a lot of radiation oncologists don't seem to want to acknowledge.
But let me just interrupt you. I just read a paper, a major journal, about using another type of hydrogel with hyaluronic acid. So obviously, I'm saying this is picking up, right? Now everybody wants a piece of this action. So you're a fan of it, and tell me who gets it and who doesn't get it.
Okay, so first of all, what is it?
Yeah.
So this is a water-soluble gel that you place through the skin, not through the rectum, but you go in the skin between the front of the rectum and the back of the scrotum. And under local anesthesia, you inject this gel, which goes into what becomes a space between the back of the prostate and the front of the rectum. The way that we're normally put together is those two structures are right next to each other. They're a millimeter apart. So if you're trying to give a high radiation dose to the prostate, especially if you want to get fancy and boost areas, you're limited by the dose the rectum will tolerate. This material generally it varies with the person, like you'd expect, but in general, you create about a 1.3 to 1.5 centimeter gap between the prostate and the rectum. In the proton world, that's a 70% decrease in radiation dose to that anterior rectal wall. So what I have seen clinically, and what was reported in the randomized trial when they did this with X-rays, was that back in the day when I used to treat everybody with a rectal balloon, I would tell them, patients, 20 to 25% of you are going to be calling me 9 months to a year after you finish saying you see blood in your bowel movements. And I'll tell you, it's going to go away, keep your bowel movements soft, et cetera, but it's annoying. That number is now about 3% because you've reduced the radiation dose that much. So who gets that? I have to have a good reason not to do it. It's usually a person who refuses it. The other patients where we don't do it is if it looks like on imaging they've got disease in that area, because there are concerns that if you put something in there and you're moving those two structures apart, you could be moving the cancer cells posteriorly and moving them into the lower dose radiation area. So I try to do this on everyone we're doing definitive prostate treatment. We've done it on a number of post-operative patients, especially those who have been radiated previously, where we're able to get the gel in there and again push the rectum and the prostate apart. And I've done this in patients who had prior prostate radiation and were going to retreat.
And so you used it because of data, but now several years later, you're saying you believe the data. You're happy. You're happy with it. So you'll continue. Continue to use it.
My phone doesn't ring. I mean, seriously, this was so common.
That's good to know.
Yeah.
So my last questions are: do you ever give protons after protons? Meaning, you ever re-radiate someone?
Do we ever re-irradiate? Well, yeah, we do. In fact, this is another area where there's
and I'm telling you, let me tell you why I threw you a softball question.
Okay.
I was really nice to you on this one.
Well, thanks.
I'm still concerned about the flying thing.
Oh, no.
But the reason I said this is because I've always argued that you guys don't have a good sales pitch. In urology, you can say, hey, you know, if I take the prostate out, you can always get radiation, but if I radiate you up front, you can't get surgery, right? And I know there's some exceptions, but there's a lot of truth to that. But I'm saying you've never had a counter argument, and part of the counter argument is there are people that can be radiated after radiation.
Well,
so the floor is yours.
I do have I mean, you're right. This comes up all the time, and I do have a counter argument. So what I tell the patients is that if you have a recurrence after radiation therapy, after primary radiation, you've got about half a dozen different ways to address that. It's not, and reirradiation is one of them.
Okay.
What I tend to favor, because from what I've seen, I think it's the safest way to do it, is focal cryosurgery. Focal cryosurgery. Freeze the area where the recurrence is, because it's more controllable than doing reirradiation. The concern with reirradiation, and this gets to our unknowns, is that even though that normal tissue may not have been clinically damaged the first time you treated it, you create some microscopic injury that may or may not be repaired. And we're now just learning more about how much of that actually is repaired as time goes by. So historically, if you reirradiate, the concern has been you're going to place patients at a high risk for complications, like a fistula of the rectum. So personal experience, I've reirradiated patients at Loma Linda. I've reirradiated patients in San Diego. At Loma Linda, I retreated 16 gentlemen who were all patients I had initially treated with protons, and they had a recurrence, and we treated them. This was with, long before we had balloons, passive scatter beams, big margins, et cetera. The good news was that in 15 to 16, their PSAs went, they dropped like post-op. And they stayed there. One of them was the second guy we ever treated, that gentleman who designed our accelerator. He did fine the rest of his life. The not so good news in that group was that because I was retreating a pretty hefty chunk of the rectum, and because I wasn't pulling my punch, if I gave Mr. Smith 70 gray the first time and it didn't work, giving him another 30 doesn't make any sense. We went after it. That 25% of them wound up with what we would call a grade 4 complication. They needed temporary colostomy. Not so good. But when I presented that data at a national meeting, I had people telling me, that's really not bad because there are other options like surgery are no better. Well, great. Yeah. It's gotten to be much better now because of better delivery and excluding, if you can, the rectum away. But retreatment, reirradiation is still not my first choice because I think from what I've seen, at least with protons, from what I've seen, I think that cryo is a safer technique. I also like, for the reirradiation patients, I think that HDR, high dose rate afterloading, is an excellent way to do it because you have more control over where the dose goes. So I've had patients come up and meet with Dr. Chang here at UCLA to get retreated as well.
So that's good to know. Will you explain to me what happens? Let's say my prostate's a little large and I get proton therapy, I get radiation. What happens to the size of the prostate? Will you please enlighten us? Because a lot of people don't realize what happens to the actual prostate. Let's say I've got a large prostate.
It triples in size.
It doesn't. No, it triples in size.
It's not triple in size.
It
shrinks.
So this is not common knowledge.
No, I know, but
right? So if you have a slightly enlarged prostate, like most men do as we get older, right? It's weird. Everything shrinks as we get older, but the prostate gets bigger. So that's kind of a bad God joke or something. I don't know. But but what happens? You radiate it, then what happens to the size of the prostate?
So on average, you lose about 30 to 40% of the prostate volume after radiotherapy over a span of 1 to 2 years. Because we're giving these doses, and you're a little more likely to kill the cancer cells, but these are ablative doses. You're destroying the glandular tissue, And as those cells attempt to grow and divide, they die.
Yeah.
So what that means is that in about roughly 70 to 75% of the gentlemen who have gone through radiation, if you ask them to fill out a IPSS score,
yes,
it's better.
Yes.
But in the other 25%, it could be worse because as the gland has shrunk, now there's more pressure on the urethra.
Yeah.
If they also receive hormonal therapy as a component of their care, the volume loss is substantially greater because you get a volume loss from the hormone treatment as well as from the radiation.
Yeah.
So you're more likely than not, if you go through radiotherapy, to have an improvement in urinary symptoms down the road.
Yeah, long term.
Yeah, long term.
No, I'm glad you explained that. They never explained that in school. So it's important for the patient to understand. Suddenly they get their prostate measured again, and it's a third less in terms of volume, and it's not a bad thing.
No.
It's a good thing. All right, last question. We call it a day. Oligometastatic prostate cancer. So we talked about treating the primary area, but let's say I got a couple spots here. People are going in and getting those couple spots zapped.
Yep.
And the reason they're doing that is because they're in the hopes that they don't have to go through a lot of drug treatments, that just zapping those 1 or 2 spots will control the tumor or get rid of it enough that they'll never have to go on any sort of hormone therapy. And you've treated a number of these patients, including doctors, and had good results. But tell us where you are with oligometastatic prostate cancer. How many spots do you treat? I mean, do you look for 3 or 4? Do they have to be in the same neighborhood? And how many treatments? Just end it with that.
Sure. So it's, as you imagine, you got individualized because having 5 spots, scattered throughout the body may be different than 5 spots in the pelvis. And if 5 spots showed up in a month and their PSA is going up in leaps and bounds, that's a different situation than the PSA rising slowly. So I am a strong proponent of oligometastatic treatment because I think the data supports it, as I showed you some of that earlier. I look at 5 or less, and my tendency when I treat these is to treat the areas in 3 to 5 fractions.
So how many?
3 to 5 total. So like that one slide I showed of the rib, that's a 3-fraction treatment, 3 days of treatment. And I tell the gentleman going into this, look, we're doing this, the hope is exactly as you said, we're going to cure you. We're going to cure you. And you will get that in a frustrating minority of patients. Maybe 20% if you're lucky. That's what you see. The most likely benefit is just what they mentioned and what they found in the Extend trial. We didn't cure you, but you know what? We've given you a nice holiday from ADT, and you feel better, and we apparently are slowing down the next wave of metastasis, so clinically you're fine. So that's a win-win too.
So what do you consider a response if you hit something? Like, for example, a friend of mine you did that to. He had 1 spot, and he was 0.1 something, and now he's 0.04. That's a more than a 50%. Do you consider that? That's a response, more than 50% PSA drop.
Yeah, I'm even happy if the PSA is just stable.
Yeah,
because again, you're doing this because you're trying to keep them off of medication. So if your PSA is at 1, it's staying at 1, and makes you wonder sometimes maybe. And I get curious, and I'll re-image just in case there's a clonogen that's not making PSA. But if your PSA is stable, and in the past your PSA always went up when you had progression, we'll leave you alone.
Fabulous. We went over, and I apologize, but you made a lot of effort in flying here. Right? You didn't do commercial flights, so we wanted to keep you longer. It's important. So we have to make sure you go back with some heartfelt gifts. And the first one is a new coffee mug for you, right?
All right.
And I don't know many radiation oncologists that have a mug like this. It says, think like a proton and stay positive. There you go. Right? And I
that is really sweet.
My first thought is he's got 100 of them.
I don't. No, I don't.
Where's the imagination of these people who give you gifts?
No,
Anyway, so it was a very positive talk. You're a very positive guy. But then I thought, let's go a step further because you've always been dedicated to the PCRI, getting good information out. So let's find something that might be even more near and dear to his heart. And when you take it out, can you explain to the audience what this means?
Okay.
It's not a puppy.
Man.
Can you believe that?
I don't believe that. So what this is, of course it's clear so you can't see it. This is a glass, that wine glass, which says Claremont McKenna College, which is the college where I went to as an undergrad. And Had just a fantastic time there, and I was lucky enough to be able to compete in Division III track and field and cross country my entire time there, and still help out there as an assistant.
Do you have any glasses from your college, your alma mater?
No, I have some coffee cups. I don't have one of these.
You don't have?
That is new.
It's a classic alumni glass. It's really hard to get stuff from them. I don't know.
The coffee cups I'm not supposed to have. I think that they kind of found their way out of the dining hall. Just don't tell anyone.
No, that's okay. So there you go. There you have it.
Thank you.
Thank you, Dr. Rossi, and thank you, Dr. Moyad. That was very informative. I just want to take a quick minute to thank Bayer, Pfizer, Dendreon, Astellas, Janssen, and My Event for helping us put on this event. Thanks to them, it's 100% free for all of you. Also, please remember, take this link of this conference and share it in prostate cancer forums, on Facebook, on your social media, and help get the word out. We want to give this free education to as many people as possible. We want them to know their options. We want them to think about their quality of life and be aware of the side effects so that they can make informed decisions and have shared decision making in those medical offices with their physicians. Our next session is one of my favorites. It's with our executive director, Dr. Mark Scholz, and with our beloved moderator, Dr. Mark Moyad. The great thing about them is it's Mark and Mark. It's the different perspectives on prostate cancer. Dr. Mark Scholz is a medical oncologist in private practice, and Dr. Mark Moyad is in the urologic division of the University of Michigan in academia. It's so interesting hearing their differing perspectives on what they agree with and what they don't agree with. But the reason we present this to you is we want you to have all the information from different perspectives. The questions that they're answering have been previously submitted for this conference, but if you have questions during the session, our helpline is still on, and you can go ahead and ask your questions in the chat function on our YouTube channel or email us at info@pcri.org. Without further ado, here's Dr. Mark Scholz and here's Dr. Mark Moyad.
All right. Before we start, here's my gift to you. Dr. Scholz wears the most bizarre ties I've ever seen. And so I bought one, but I thought, my gift to him should be a clip-on, because he's always in a hurry. So here's my clip-on tie. So feel free to put on a clip-on if you need to.
That's going to be nice.
The staff helped me get it.
Not bad.
Yeah, it's beautiful.
Yeah.
And like when I was in Catholic school, I had to clip it on.
Well, make it a boutonniere here.
So there we go. All right, so here's how we normally do this. We go really, really fast, then hang out for a little bit afterward. But what we first do is Dr. Scholz goes through his thoughts of the talks, pros and cons. I might throw in some stuff, and then we just go through all the questions from the audience and other points, and then we get through probably 70, 80 things within an hour. I'm ready when you are. Go.
Yeah, so our first talk was about advanced prostate cancer, but I was so impressed by the strong message of advocacy that I'd never really heard articulated so well, that in this era of rapidly changing technology, that you're going to confront situations where you know more about your situation than your doctor does. And that's pretty disappointing, but it's a reality. And the good news is it's a result of amazing advances in technology, just incredible advances. So you're going to run into that, and one of our board members, Steve Schwartz, has a video which you see, I think it's had close to 100,000 visits already. And his mantra, he's a contractor, is question your experts. Question your experts. So you want to surround yourself with experts. As Dr. Heath told us, we want to have a team that surround us, and we want to then utilize that team and question your experts. I think that was what I got out of Dr. Heath's talk. And thank you so much, Dr. Moyad. Even we were wondering if it was just like a thing with Dr. Heath. I mean, both of them coming from Michigan and whatnot, but I was pleasantly surprised. I was actually stunned. I thought it was one of the best talks that we've had on advanced prostate cancer. Her strength, I thought, was their ability to see it from a patient point of view. Yeah. And a lot of our experts are very academic. They have a lot of slides with a lot of graphs on them, and it's impressive and it's interesting, but getting right down to the grassroots of you all being advocates, questioning your experts, and taking responsibility. So I love that about her talk. I don't know if you had any further comments on that.
Well, I hadn't seen her in a while. She's like me. She's social when she's here, but she's very quiet and to herself when she's not, and likes her private time. So I hadn't talked to her in a little while. But the first thing she said to me before she went on stage was she said she's overwhelmed when she walks to the parking lot of oncologists and urologists and all these people running up to her going, well, what's the latest with genetic testing? Because she said the field's become so overwhelming that unless the patients participate, which is exactly what you're saying, unless they really engage, they could be missing out because just their doctors trying to keep up is overwhelming. And I just have to tell you, I do feel sorry for the physicians because, you know, in a lot of situations, academics or not, they're being told by certain people that they need to see more people in a day, more and more. And so they're developing their computer side manner, not their bedside manner. And they're moving from room to room and they're being pushed by a slightly higher power to see more volume, more volume. And so something has to give. And what gives is more self-education time. I think it's going to continue to suffer based on the system that we're in. But if you understand why the system is the way it is, then I see more people get involved in their own education. So we do something very smart here for 15 years. We just don't pick speakers. They've been heavily vetted, whether I've seen her probably 18 different times. Most of the speakers that have ever come here, they don't realize that many of them were unknowns in the patient world until they came here. But these were people we saw time and time again deliver flawless, wonderful talks, and they were very educated, they were very passionate, and I can count on one hand in 15 years a really bad speaker that we probably would never invite back. But we've seen them time and time again do their thing in front of doctors. And then it's funny, just so you know, for Dr. Scholz and I, 15 years ago, we would beg people to come to this meeting to speak. Now everybody gives us their CV. They all want to speak here. So the whole game has changed. That's the answer to Heath's thing.
Yeah. One thing, so accolades to her, really impressive.
Yes, amazing.
But she did talk a little bit about genetics, and there was one little practical tidbit I thought was interesting, is the genetics companies, apparently, these are the people that will take your blood or do a mouth swab and tell you if you're going to be eligible for some of these medications or if you're at higher risk for some more aggressive cancers. And apparently they're being funded generously by Medicare because these companies will actually come to your home and draw your blood. If you talk to your doctor and say, I want an Invitae blood test or a Garden 360 blood test or a Foundation one, these are the companies. Maybe I'm not as reticent as Dr. Heath is about giving commercial names. Then your doctor, all they have to do is write an order and they'll come out, draw your blood and run the genetic test. I don't blanket tell early stage patients to do genetic tests, although I'm certainly not against it. There is some evidence that maybe people with BRCA mutations are a little more likely to progress if they have early stage disease. But it's not a game changer in my mind. It is for some physicians. But for the advanced patients, it's really irresponsible not to have genetic testing if you're advanced. So it's very easy to do. And just ask your doctor, and whether he draws the blood while you're in the office visiting him there, or send someone out to your house to get your blood, it's real easy to get.
A lot of us live in a world where family histories are sketchy. Oh, grandpa had this, I think he died of that, and so when in doubt, you know, it's interesting how many people go get their germline, they call it, analysis, and they end up having one of these mutations. It's striking. So one of the most frustrating things I deal with is someone will say, you know, I don't think I had prostate cancer in the family. I mean, grandpa had this and this and that, but I'm not sure what they died of. And lo and behold, they get tested and there's the mutation. Yep. I mean, it's really tough to go back on records. I mean, my grandfather's extended family, I'm not sure what happened to them. And I did a lot of investigating. And so when in doubt, I think it's an incredibly amazing option that I wish more people would explore, right?
Yep. All right, so let me...
What about, do you want to say anything about the other speakers?
Yeah, so, well, let's do Dr. Rossi, since we just heard from him. The subject of focal therapy came up in his talk. He humbly kind of bowed out. He said, I've treated 2 patients. I wasn't thrilled with the results. But I think focal therapy has a bright future, honestly. And he mentioned that he did salvage cryotherapy in one of his patients. That's a type of focal therapy, actually. And he put a list. There was a slide that showed all the different types of focal therapy that are available. And the advantages are real. If you can find a skilled focal therapist, and if your anatomy sets up for focal therapy, not everyone's going to be a candidate, but if the anatomy is favorable, then there's going to be a much lower risk of erectile dysfunction. In this modern era, with things like SpaceOAR and crackerjack radiation therapy, the bad things that we used to hear about happening frequently, rectal burns, bladder burns, are very rare, but there's still a problem with erectile dysfunction. And people that have focal therapy have a much lower risk of erectile dysfunction. So people that see that as a priority, that have favorable anatomy, shop around, talk to different experts, because it's a little bit like the Wild West. It's still not a regulated area. Focal therapy, I think, is here to stay, and I think it's going to become more popular.
I have no comment on that, so I think, do you want to, is there anything, I was happy that Dr. Rossi, who always does a good job, there's no question in the area of protons, everyone would agree he's #1. Everybody around the world knows who he is. I was glad we talked about side effects. That made me happy, so that's my only comment on that. Do you want to talk about Czernin?
Yes. So PSMA PET scans are, I think, the biggest breakthrough since the discovery of PSA. The industry hasn't really begun to digest the ramifications of this tremendous breakthrough, but if you think about it, it's fairly straightforward. We've been using how high is the PSA, or what's the Gleason score, how many core biopsies are positive, to try and project whether or not the disease is spread outside the prostate. Is there anything else that matters besides whether or not the disease spread outside the prostate? The answer is no. There's really nothing else that matters. Did it spread or not? Is it a cancer, or is it a pretend cancer? Is it a paper tiger? Well, we know from our experience with Gleason 3+3, there's a lot of prostate cancers that don't ever spread. What many people don't know is there's a lot of Gleason 7s, 8s, and 9s that never spread. That is shocking to people, but of course they all get treated. No one's waiting around to see if they spread, because we know that there is a risk of spread. And so everyone historically has been treated. But now with PSMA PET scans, when someone's diagnosed with a higher Gleason score, we know that they've had that disease for a number of years, and if the PSMA PET scan is not showing any metastatic disease, we have a much more accurate indication as to whether that disease is likely to spread based on whether it has already spread. So this information is not being factored into all the historical algorithms. And how can this change the way we manage prostate cancer? Well, one way it may change the way people think is how much hormone therapy is given to a high-risk patient. Hormone treatment for 18 to 24 months has been the standard for a long time for Gleason 8 disease, because there was maybe a 20–25% chance that the disease had already spread. Now we have scans that show a much lower likelihood of spread. Can we modify the duration of hormone therapy? So these are some of the analyses that are in process, but we don't have studies yet. But I think that aspect of PSMA PET scans is going to change the way we think about intermediate and high-risk disease. Another thing that was mentioned briefly, I think you brought the question up, is can we do a PSMA PET scan instead of a biopsy in someone that has an abnormal MRI or a high PSA? The use of focal or targeted biopsies, I think, has made the downside dangers of biopsy much less, and I'm not as intimidated by the thought of someone going through a couple of biopsies instead of a dozen biopsies, which is the standard random approach that's still popular. But people that have plenty of financial resources and say, you mean I can just take a scan and not have any biopsy? I think people should be aware of that possibility. These PSMA PET scans are quite accurate for picking up prostate cancer inside the prostate as well as outside. If a PSMA PET scan isn't showing any disease inside the prostate, why would we do a biopsy on that person? We may continue to monitor them, but it's kind of cool that maybe in certain cases we can avoid a biopsy altogether. So those are just some of the things that came out in my thinking during the PSMA talk.
I was happy he mentioned places that you could travel to if you're if there's that level of desperation. PCRI has built a very strong foundation on if you can't get it here but can get it somewhere else, that's your prerogative, and we can possibly tell you where to go get that. So I think it's easy to talk about what might not have worked, but I think people forget that for how many years, 5, 6, 7 years, people were getting PSMA scans before they were FDA approved right down the street, because people were coming to this meeting and we were saying you can get them right down the street right now. Yeah, you're in a so-called clinical trial, but this is just an information gathering study. So for years before approval. Second thing with the lutetium, people were going to Germany, people were going to Australia. So what made me happy about his talk, because sometimes academically we get stuck in a box, is that he did mention there were all these other places he tells patients that they could possibly go if there's a desperate situation. That made me happy about his talk. Ready now? We only got about 700 questions. And you can tell I have no life. I read every single one of them in my room. So I tried to group them, and a lot of them, well, before I go into where a lot of them went, here was a couple on testosterone therapy if someone's had prostate cancer. So if someone's been treated for prostate cancer, in a couple of these questions, it's a year or two later, PSA is low or undetectable, their testosterone's low, but they heard testosterone can accelerate the growth of an existing tumor. Do people go on testosterone replacement therapy after they've been treated for prostate cancer, or is that just too dangerous?
Well, that's an excellent question, because there's experts who will come down on all sides of that question. My personal view is that because of the intermittent hormone therapy trials that were done 15, 20 years ago, where they allowed people to stop taking hormone therapy and their natural testosterone would return, so we have actually pretty good data showing that that's not dangerous as long as they're monitored. So why would we be afraid of giving testosterone in someone who stops Lupron, but their testosterone never returns spontaneously? We're just replicating what happens when you stop Lupron and their testicles make the testosterone. It's the same testosterone. So the giving testosterone we could probably do a whole talk, a whole conference on testosterone. It's fascinating stuff. Mark and I had dinner on Thursday night, and we were both getting all excited about talking about muscle loss in aging. And Mark's an expert on that, and I think we need to hear from him a little bit about that before today is out. Yep. Testosterone is probably one of the biggest things to help rebuild muscle, which is a very important thing in aging gracefully. So the simple answer is that in our practice, because we've given a lot of Lupron and we have a lot of aging patients, people with low testosterone levels, I'm sure that between Dr. Lamb, my partner, and myself, we've got over 100 patients that are taking testosterone in different forms. We monitor them closely. Again, we could talk about the modus operandi for hours, but I think that the simple answer is that under supervision, giving testosterone to prostate cancer patients or people that have previously had prostate cancer is something on the table for consideration. Do you want to jump into the sarcopenia thing?
Well, I wanted to do a part B to that, because there were a couple of questions. There were people on hormone therapy, androgen deprivation therapy. One mentioned 3 years, one mentioned 5, and now they're off. And they're wondering when they're going to get their testosterone back.
Right. Yeah.
So you just please explain, the longer you're on hormone therapy, what happens?
Right. So, and there's a medicine called Orgovyx, which is the pill that Dr. Heath mentioned as a substitute for Lupron shots, that has more predictable testosterone recovery when you stop. Lupron shots, Eligard, Trelstar shots, Degalurex, otherwise known as Firmagon, all these medicines tend to have lingering low testosterone levels even after you stop the treatment. And that becomes a bigger and bigger problem as we get older. So 50-year-old men may have robust recovery of testosterone after he stops Lupron. 75-year-old may never recover testosterone. So that's there's just a lack of awareness of how much you can have lingering effects after these shots. And I wanted to mention, I know I'm getting off the topic a little bit, but I wanted to mention that the Orgovyx pills are much less likely to do that. And so that's one of the attractions of considering that therapy rather than Lupron. If you're on a period of the hormone therapy for a period of time, and you're going to get off, and you're expecting to recover your normal testosterone, you're much more likely to recover it on the Orgovyx.
I mean, it surprised me how many people don't know that the pills came out. I mean, they quietly came out, it seems. I mean, of course, the advertisements are in the medical journals, but it quietly came out, and I can't tell you how many people I've talked to on the phone, and they'll say, wait, what is that? They'll say it's a pill option for hormone therapy. There's sort of an awareness problem. I mean, whether you get into the weeds of which one's better or not, the bigger issue is there's just a lack of awareness that you can go home with these pills, and you take a loading dose, and then you take just a single dose every day, and then you can do that instead of coming in for a shot if that's what you prefer. But the fact that it's added as another option, that has to come up in a conversation. Because some people love that sense of self-control, and some people love that they want to start and stop when they want to start and stop. Other people say, no, I'd rather go in to see Scholz, and he sticks a needle in a certain place and gives me that shot. And but the point is, people just don't know about all the options, the different months of options, the pills, and so more options, better options. The only thing I've heard is that the cost. Can you comment on that? That some people have run into some cost issues on it.
Yeah, and that was something that Dr. Heath brought up too, is the medications that have come out are truly groundbreaking, but they're spectacularly expensive. And so the push-pull between insurance companies and patients and doctors is I think all three of the doctors today talked about what a headache that is battling with insurance companies. But we are asking these insurance companies to make gigantic financial outlays. So the Orgovyx, I think, is something in the order of $2,000 or $3,000 a month. The second generation hormone medicines like Xtandi, Erlita, Nubeqa are somewhere in the range of $10,000 to $15,000 a month for the pills. It's insanely expensive, and surprisingly, insurance often will pay for these things. It's really mind-boggling. So in that context, I think it's good to know that one of the 4 second-generation hormone medicines, abiraterone, also known as Zytiga, has become generic. And this is why I think our system does work. All these medicines, Xtandi, Nubeqa, these $10,000, $15,000 medicines, or Orgovyx, a $3,000 medicine, will become generic at some point and become very accessible. Zytiga has become generic. It's as efficacious as the other medications that I mentioned, Nubeqa, Erlita, and Xtandi. But you can pick it up at Costco for like $80 a month. And it used to be $10,000 a month. So we got to give credit to the fact that Zytiga development was something around $1 billion worth of investment. The pharmaceutical company that brought us Zytiga, which was one of the most groundbreaking breakthroughs. It came out around, I think, 2010. And it emptied out my infusion area. Historically, we had lots of people taking chemotherapy. Since Zytiga has been out, we've basically, we're probably using 5% of the amount of chemotherapy that we used 10 years ago. Because this stuff is so efficacious, people go into remissions, they stay in remission a long time. $80 a month, what a bargain. So yeah, there's a lot of complexities here, and what kind of insurance will cover it and which won't. Orgovyx is, Lupron shots are almost universally covered by Medicare, for example, and private insurances. Orgovyx, maybe yes, maybe no. Has some advantages, perhaps. Are they $3,000 better than Lupron shots? Well, if your insurance covers it, perhaps so, especially if you're hoping to get predictable testosterone recovery when you stop therapy.
Yeah, it's quick drop, quick recovery. Some people say, well, you want that extra suppression time. That's what the trial showed. But to me, again, it's here are the options, here are the pros and cons. Adults aren't children, they're big boys and girls. They should pick what suits their lifestyle and what they want after they've been given the information. The problem is keeping up with all these hormone-changing drugs has been daunting, and very few people get all the information. So anyway.
I don't know if I even answered your question. I got off on my soapbox there.
No, I mean, you answered the question. I mean, sometimes when you answer a question, it makes me think of the questions that I'm also getting here. So you talked about Zytiga, abiraterone being really expensive and then cheaper. Abiraterone or Zytiga comes with prednisone. Can you please, because this comes up constantly, can you please explain why it is absolutely necessary in general to take your prednisone with that drug, because otherwise you could run into problems? And can you walk people through that?
Sure. I mean, Zytiga has occasional problems with increased blood pressure. In fact, all these second-generation hormone therapies can increase your blood pressure, fluid retention. Occasionally it'll irritate the liver. This is detectable with blood tests. And it can also deplete you of the normal cortisone that you get from your adrenal glands every day. And so that's why they ask you to take a little bit of prednisone, which is a type of cortisone, to compensate. Turns out that the prednisone is usually not a big deal. If someone is absolutely horrified by the thought of taking cortisone, there's some other potassium-sparing diuretics that could be substituted. I'm blocking on the name of it right now. We generally don't bother because people tolerate the prednisone very well. One other little trick in cost savings is, so $80 a month seems like a small figure to me for the type of results we get with Zytiga, but you can actually cut the costs even further because taking Zytiga with food doubles its potency. So many of our patients, instead of taking 1,000 milligrams every morning on an empty stomach, will take 500 milligrams in the morning with breakfast, take their 5 milligram prednisone pill right along with it, and that works just as well.
Yeah, and the company really liked that study a lot when it came out, that you would be taking less medication.
That's right, and get the same results.
We remember when that study came out. So the good news is with a high-fat diet, you get more bang for your buck on less pills. The bad news is if you end up taking more than less, and then also take the meal, you can be exposed to a lot of drug, right? So you got to make sure you take less in that situation.
Right, you don't want to take 1,000 milligrams.
Right, exactly. So that the dark side of that is you can be overexposed to the drug, so you want to make sure you cut down on drug. But yeah, that was an amazing finding in terms of that. The one thing, I have a bunch of biopsy questions. I'm sorry. The reason I'm laughing is anytime we talk biopsy, it's just like, here we go, look out. It's now Scholz is going to hold court. So I don't mind. So the questions were, again, the transperineal versus transrectal biopsies. And then the second one that we will get until the day we go into the dirt, all of us, is that do biopsies spread cancer? We got a bunch of those. So it's a two-part question. Tell us.
Yeah, I think that's an easy one.
Okay.
We'll take that first. The answer is no.
Okay.
1 million men are getting biopsied every year. If we were spreading cancer around, we'd have known that a long time ago. But yes, it is true. 1 million men go through random biopsy every year in the United States. It's a billion-dollar business. And you're giving me an opportunity to talk about it, and I'll get on my soapbox. That's really sad. There was a nice a definitive article in the New England Journal of Medicine in December of 2022 that done in Scandinavia in something like 12 or 14,000 people, where they looked at how much random biopsy in addition to targeted biopsy improves your chances for finding bad cancers. The thinking with random biopsies is, well, let's just be careful. We'll stick needles everywhere in the prostate so that if something isn't showing up on the MRI, at least we'll find it. And the beauty of that study, because validated what I've been saying now for about 8 years, is that they didn't find any disease that needed treatment with the random biopsy, as long as it was a good quality MRI and the targeted biopsy was done properly. And so that was New England Journal of Medicine, the most prestigious journal, large study, something like 12,000 patients, and no advantage for random biopsy anymore. So the trick, of course, is finding competent centers that do good MRIs, since we're banking on the quality of the MRI, and not all MRI centers are created equal. And then the doctor that does the targeted biopsy has to be experienced, because the needle has to go into the target for you to really sample what's going on. But I think again, I think I got off topic a little bit there, Mark. My apologies.
No,
but
You covered it, but it's the transperineal.
Yeah, the transperineal, I'm sorry.
Yeah. No.
So where are we with transperineal? So the biggest side effect of biopsies is not spreading the disease. The biggest side effect is infection. When typically we're poking the needle through the rectum, that's a dirty spot of the body. So infections in otherwise healthy people, we're talking about serious infections where people go to the hospital and get intravenous antibiotics. And with random biopsies, they're reporting about a 2% incidence of serious septic complications after these biopsies. So if we got 1 million people every year that are having these random biopsies, and 1% of 1 million is 10,000, what are we looking at? 20,000 people a year that get serious septic complications, if I'm doing my math right. So the transperineal concept is that instead of sticking the needle through the rectal wall, you stick it through the perineum, which is the skin between your rectum and your scrotum. And you're not going through the rectum, and you're going to have a lower risk of infections. And that's definitely true. Interestingly, the infection risk isn't quite zero. It's still somewhat less than 1%, but it's better. The problem with transperineal biopsies, you're going through more tissue, it's more uncomfortable. Some doctors are even putting people to sleep to do this, general anesthesia, which is not good in our age group, doesn't help memory. Other doctors are skillfully using local anesthesia, which would be reasonable, but it is more difficult and takes more skill to hit spots on a transperineal biopsy because the prostate's this far away from the skin rather than this far away through the rectum. So that's one way to cut down on the risk of infections. Another nice study came out showing that if you're doing a targeted biopsy without a random biopsy, in other words, instead of jabbing the needle 12 times through the rectal wall, no surprise we're getting infections. But if you just do 2 to 4 biopsies targeted through the rectum, your risk of infection drops down to less than 1%. So I haven't been pushing for transperineal biopsies. A little more cumbersome, a little more uncomfortable, a little bit further away, a little more difficult to target. There are good doctors that are doing them. I'm advocating continue with the transrectal biopsies, but only targeted, not random.
We had a number of questions, but a number of people have called in through the years and talked about someone's been biopsying something that there must be a cancer there, they can't find it. And then you've sent people for what's called in-bore. Can you explain to people that they have that option? And I became a believer after seeing a couple of these cases where they couldn't find anything, and the person that is so frustrated, which I understand, and then they were sent locally for what's called an in-bore biopsy, and they hit it. They found it. So can you?
So I sort of alluded to that there's a skill doing targeted biopsies, and there's different ways to do them. Outpatient targeted biopsies are usually done with fusion technology, where they take the MRI images and stick it into an ultrasound and then use the ultrasound overlay to find this purported spot. But it seems like it should be more accurate, and I think it is more accurate for them to actually have the biopsy done in an MRI where they're looking at the spot and they can see the needle go into the spot. So in-bore, the bore is the hole in the MRI, so you're going to inside the MRI. That's what an in-bore biopsy means. And I think that is likely to be the most accurate way. It's cumbersome because it's kind of slow, but if you're having difficulty getting a clear answer, or especially with what we call anterior lesions, where the spots toward the front of the gland, further away from the rectum, an in-bore biopsy while you're in the MRI is going to be the most accurate targeted biopsy.
I think that covers the biopsy area. I think I don't want to needle you anymore with that subject. Sorry, it's late in the day. I appreciate that. One fan of that pun. But you didn't use the word harpoon, thank you. This guy always likes to use the word harpoon when it comes to biopsy. You know, interestingly enough, and this makes me happy, the most questions we received we should deal with, they all fell into one pool. And that is the side effects of hormone therapy. And that makes me very happy because I love hormone therapy and I don't mind the side effects, are words never spoken by a single individual in their lives. And so we have to quit pretending like this is some walk in the park. You are throwing someone into male menopause within weeks. There's no peri-menopause, there's no then menopause 5 years later. It's not like menopause is fun on any side, but whammo, you're going right into menopause, and like Heath said, from A to Z, there's all these potential issues that can come up acutely, right up in the first few months, or chronically over the next few years. So why don't we talk about a couple of those, all right? The first one I want to talk about, and I'll even think about this, well, I don't have to do it alphabetically, but the one that we received a lot on are hot flashes. And so I don't know, you know, why don't we comment on hot flashes a little bit in terms of, because what you do is actually a little different. I don't know if you've accepted that, because I think a lot of people were stuck in a box with the manual, wouldn't necessarily treat them that way. They would want to treat with a very other traditional type of medicine. But why don't you talk about hot flashes, and besides keeping the room cool, besides wearing loose-fitting clothing, what else can I do about these things? Because just so you know, in my world, hot flashes make up what's called vasomotor symptoms. It's not just the hot flashes, it's the idea that when you flash in the middle of the night, it wakes you up, it disturbs your sleep. And then, so it adds even another component, the interruption of sleep, into the game of hormone therapy side effects. So what do you do about hot flashes?
First, I ask people how much they're bothered by them, and some people say, yeah, I notice them, but they don't trouble me that much. And we just live with them under those circumstances, but they can disturb sleep, and that's a very significant thing. In terms of things that really produce results, the top two things that really produce results are estrogen patches and progesterone. And that probably dramatically reduces hot flashes in about 80% of men. Now, estrogen orally is very dangerous for men. It can cause blood clots. But transdermal patches are safe and effective. So the main concern is you have to watch for breast enlargement. And if that starts to happen, either stop it or visit your friendly radiation therapist for a couple zaps to the breast area. So estrogen patches, progesterone I've gotten away from because it's a precursor to testosterone, and usually that's an anathema when you're on hormone therapy. So we haven't been using progesterone very much anymore. And then less effective, but occasionally effective medicines like gabapentin or Effexor can be quite useful in certain individuals.
What I'm seeing in a lot of the literature too is that when you ask someone on hormone therapy, hot flashes bother you, a lot of people say they don't bother me that much. And then with more investigation, they bother you a lot, but you just don't want to admit that they bother you that much. So you have your hormonal and non-hormonal, so you offer all those options. I think what's going to happen is, and I've always told people, I've learned more from breast cancer than about just side effects of hormone therapy than any cancer, because they've dealt with them for so long. And some of the most promising things that end up working for menopause will work its way into prostate cancer. So right now there's several drugs in phase 3 trial that are showing significant non-hormonal drugs for women, really significant drops in hot flashes and other types of vasomotor symptoms. And they've got nice long names. One just finished a trial, is going for FDA approval. I think they're going to work its way over and change the game here in the next few years, or the next year or two, in prostate cancer. So it's always nice to watch what's happening in breast cancer with hot flashes, because it's not like we see a ton of breakthroughs in this area, right?
Yeah, I think Veru is coming up with a product too. It's a small startup company, but I don't remember the name of their product.
The Astellas one is fezolinetant or something like that, and it's already passed through phase 3. And I bumped into someone at a meeting who I knew, and they said that they were going to move into prostate, and they don't see any reason why. Again, it's a non-hormonal thing. It actually affects. There's a part of the brain that it's a temperature sensor, the hypothalamus, and it affects it there. And so I have great hope for it. On the lighter side of things, interestingly enough, because I had to write some papers on how to handle certain things in urology and sort of clinical papers, and I keep reminding people the data there is in acupuncture. Acupuncture, if you can find someone that's competent there that doesn't charge you too much, acupuncture for hot flashes, even once a week or once every 2 weeks, has picked up enough steam. And so some people will say it doesn't have enough data, but the truth is in men in prostate cancer, there's been enough small pilot trials now that you start to see it getting recommended. At least we know it doesn't make the situation worse, but can improve the situation, and you don't need to get the treatment that often anymore for maintenance. And maybe it's also a good barometer, because if that's not helping after several treatments, then maybe you can go for more of the hard stuff if you want it. So I like how acupuncture's found a little home there in terms of hormone therapy, and people like to talk about placebo and this and that, but you know, there's been enough there to consider it a potential option. So that covers that, unless there's anything else you want on.
No, I'm glad you mentioned acupuncture. I think that's real. The studies are pretty convincing.
The problem with some of the over-the-counters on hot flashes, everyone who knows me, I think supplements are an incredible field. I don't think they get good objectivity. And the problem is I live in a world where almost everyone I started with 35 years ago has either moved to some industry, they sell their own product line. So there's very few people that don't have involvement with companies. So I like to say that I don't, and I'm free of that. But at the same time, I believe supplements need to get more respect, but they also need more objectivity. There's a lot of hot flash remedies over the counter. On the female side, black cohosh, red clover, all these different things. The problem is they really haven't been tested on the prostate side. So it's more of a Wild West on the prostate side. That's why I get more excited about acupuncture. We just don't have those. You know, does it cause liver toxicity? Does it interact with your medication? You know, God forbid. So I've never jumped on that bandwagon on the over-the-counters on the men's side. All right, let's talk about bone loss, because this makes me really, again, people want me to talk about vitamin D, but I think the deficiency is in DEXA. Can we please talk about osteoporosis screening, and why I personally believe, even if you have to pay cash, that anybody on hormone therapy should get one potentially, who's about to start hormone therapy, get a baseline, and then if they're going long term, to get another one maybe a year later, or if they're even going to come off after 6-9 months, get another one a year later. It is one of the most underutilized tools that I think is used in prostate, that is not used in prostate cancer. What say you?
I agree. We tend to treat people empirically with anti-bone loss medications. We published a small pilot trial, at least in abstract form, using medicines like Boniva, Actonel, Prolia, Fosamax, showing that people who went on anti-osteoporosis medicine at the same time they started Lupron didn't lose bone. And it seems kind of funny that the industry wants you to lose a certain amount of bone, in other words, become osteoporotic, and then start a medicine to try and fix it, where I would think we want to prevent it from happening in the first place. So I certainly am happy with getting a bone density scan, but our usual policy, if someone's going to be on hormone therapy for a year or more, is to start some sort of treatment. Certainly make sure they take a little calcium at bedtime, make sure their vitamin D levels are normal, and supplement them if they're low. And we haven't gotten around to the sarcopenia thing, but the weight training protocols that help you keep your muscles also help build bone as well, perhaps better than almost anything else. So the typical preventative policy that should be implemented in every man with low testosterone is a combination of these things. And yes, we do check bone density tests, but we don't wait around for problems to start treatment.
Vitamin D and calcium, very important to get. I think, you know, there's no group that has come out and said we all should be generally screened for vitamin D deficiency. I agree with that. Vitamin D test is a good test. It's not a great test. But where it's a really good test are in people who are starting hormone therapy. Because if someone's coming in super low, there's a problem. There's a real problem. There's also something else, because I had to do this vitamin D podcast recently, this guest thing. And I was telling people that a lot of physicians don't realize, I don't think, because it's not advertised. And you can go look at this next time you see your prescription for any bone drugs. A lot of people equate vitamin D with bone health, and that's fine. But a lot of people are walking around today doing just fine with vitamin D because it's now found in everything. You know, they've doubled it up in multivitamins. People are supplementing more and more. They're putting it in plant-based milks. But one thing that gets missed all the time in the prescribing information for all the bone drugs is that when you go on a bone drug, there's a higher risk of it dropping your calcium precipitously and causing a problem. It doesn't happen to a lot of people. It's called hypocalcemia. And one of the ways you combat hypocalcemia is carrying a decent amount of vitamin D and taking calcium. So another reason you have to consider calcium and vitamin D when you're on hormone therapy is, yeah, the bone part is important, but it also prevents a potential side effect from one of the most commonly prescribed drugs for bone health in men and women. And that's another reason to be excited about vitamin D and calcium, not just the fact that you should just normalize intake. Now, people say, well, what's a normal intake? You can always do well. There's a lot of different societies with opinions, but almost all of them will be of the opinion that men and women have to get between 1,000 and 1,200 milligrams a day. And if you get it from diet, that much better. Because the truth of the matter is that there's so much calcium around today that if you start adding pills to that and you get too much calcium, you can say hello to two things that are not so nice. One's called constipation, and the other thing is called kidney stones. So I was drinking my plant-based milk before I came to California, and I was looking at it, and one of them was a macadamia nut milk that had 300 milligrams per 8 ounces. Another one had, an almond milk had 400 to 450 milligrams of calcium per 1 cup.
Wow.
So we are being inundated by calcium. I think a lot of people are surprised that they don't need some supplements if they just do a quick diary and see how much they're getting day in and day out. And then there's also the side effect option that can occur in that case. But there, like I said, vitamin D and calcium have a necessary place that doesn't get recognized, and that's to reduce the toxicity or side effect of the bone health drugs. And I wish that would get more play. So there's that. The other thing I want to say about bone health is that in my world, whenever you hear the words that this is the key, like the word superfood, that's a word that makes me nuts, right? Because to me, I had 3 cucumbers at the meeting. It's the most boring food in the world, and I love it. To me, that's a superfood. You know, it's very low calorie. I get a little bit of fiber, a decent amount of potassium, virtually no sodium. That, to me, that's a superfood, but it costs very little to buy a cucumber. It's kind of dull to look at. To me, that's my superfood. So people are always looking for the cat's meow. Like, what's the one thing that can drive this here? So the problem with calcium and vitamin D is it's become so equated with bone health, it makes you think, like, what else can I do for my bone health? There's no question that through the years of looking at research of people that take care of themselves, that they eat healthier, they have a higher quality diet, they have a higher chance of improved bone health, even though they're not necessarily getting more calcium and vitamin D. So what's going on here? We're learning that other compounds found in healthy foods probably offset bone loss. Another one of those is potassium. So in urology, for example, there's a drug used in a supplement called potassium citrate for people who have high risk for kidney stones. And Cleveland Clinic and other people have gone back and looked at people that take this medicine, or they get a lot of it, for example, from food, and they're seeing a lower rate of bone loss, suggesting that potassium that's found in so many healthy foods, we're not saying take the pill, may have an impact on bone health. But the point of this message is whenever you hear that this is the key, this is the 1 or 2 items from food that can make or break your health, it generally means there's a lot of other players that aren't getting attention that we haven't learned about. And there's a saying I've said for corporate gigs and other gigs I've done in the past that if you can remember anything else in diet, just remember that the healthiest foods, first of all, in the grocery store get no health advertisements. So you need to first seek out foods that have no health ads. Those are the healthiest foods, like whole unprocessed food, right? So you have to go to that area and look for it because it's not going to say makes you heart healthy, improves your bone health. Those are the more, in my opinion, desperate companies that are looking to get that added edge. But what I always tell people is, you know you're eating healthy food when you remember the saying that healthy nutrients love to travel in herds together without ads. Healthy nutrients love to travel together in herds without ads. What's that mean? That means when someone, for example, picks up something like an avocado or an artichoke, because I'm a huge fan, it says in my bio I love artichokes, which is true at Michigan. I love artichokes. I'm just fascinated by them. I find it interesting that they are extremely low calorie. They're one of the highest sources of fiber. They have virtually no sodium. They're loaded with potassium. You're not seeing added excess sugar in there. You're just seeing magnesium, you're seeing all the healthy nutrients you can imagine found in that one low-calorie place. Don't you find it interesting how they're all hanging out together? You know, whether you look at an avocado that's high in a monounsaturated fat called oleic acid, which is similar to what you see in olive oil, and you get a large amount of fiber, you get a large amount of potassium, you get a large amount of magnesium, but you're not seeing excess sugar, you're not seeing excess sodium, you know, you're not seeing these artificial ingredients. So all these healthy things are hanging out together. It's not just that the avocado is a great source of healthy fat, it's a great source of a lot of healthy nutrients. And now we're starting to discover other things. So we're doing a series for PCRI. They came out and flew to our kitchen, and we're doing a series starting in 2 weeks where we probably do 6 to 10 modules on eating better and how to look at things differently to get excited about them. And our first module, if you don't mind me telling you, that's going to be released, and the first one that I wanted to do is, for most of my career, people were walking around, and you may have heard of this, that tomatoes might fight prostate cancer because of lycopene. So people lost their frickin' minds after that study came out. You go to your local grocery store, you couldn't even buy a tomato. That must have been the secret. If you just go buy a tomato, it kills prostate cancer, and that's it. It's the lycopene. But the original studies from Harvard and other places that showed that lycopene can help was actually a study of diverse fruits and vegetables, whole fruits and vegetables. It wasn't necessarily all about the tomato. So people get excited about the tomato, so finally I decided this is silly. I want people to get excited about something like asparagus. Asparagus is low calorie. How many people know that the USDA studied asparagus recently and found lycopene in asparagus? What? But lycopene is, I thought, the red pigment that makes the tomato red, for example. You find it in guava. Yes, that's true. But this nutrient can also be found in a variety of other healthy foods, and just because they're not red doesn't mean they don't have them. And yes, it might be a small amount, but again, it's the diversity of healthy food you're being exposed to. But this idea that one type of food is going to solve it is where people get themselves in trouble. So our first series is on where to find lycopene in the simplest places and without having to take a ton of pills to go find it. But really, when you're saying you're seeking out lycopene, you're just saying you're seeking out healthy, whole, unprocessed foods. That's all you're saying. There's a bigger picture there. So that's my soapbox for the day.
No, I got another one for you.
Okay.
So this whole vitamin D thing, you can see that, that our guys that are without testosterone and losing calcium rapidly probably should be on some vitamin D. But I have there's two fetishes that I want to address publicly here. One is that if a little bit of vitamin D is good, more is better. Mm-hmm. And the other one I want to take up after that is 8 glasses of water a day. All right, so let's go to the vitamin D one first. I know you've studied this a lot and looked into it at great depth. I have patients that are, shooting to get the normal range of vitamin D is like 30 to 100. And I have patients taking 10,000 units a day, and they're trying to get their vitamin D up to 80 to 90, as if it has some magical benefit. And I'm not sure what that benefit would be. And I know you've
the benefit has been sold. And, I'm 30, almost 40 years into my first paper, and one thing, I've learned a lot of things like you have in a long career. It's like people will say, well, why don't you do consulting anymore? Why don't you have a clinic and do this? It's because now it's a time for public health. I traveled 4 million miles teaching. It's time to, really get education there out on a fairly large level as opposed to just always hitting doctor groups or patient groups or all that stuff. But what I've learned over many, many decades, it generally is very true, that there's sort of a fine line. There's a moderate amount of exposure that's healthy, where too little is not good and clearly too much is not better. And we just have countless examples of that, where you think more is better, you will wake up and realize it's the opposite. Mm-hmm. And a good rule of thumb is finding where that moderate line is. And if someone's saying there's no moderate line there, that you can just keep going with it, that means there's a concern, that we either don't know the answer or you're betting on a horse that has no chance of winning. So In the old days, which was a few years ago, and I bet you, I'll challenge you to go look at any of your labs. You'll look at vitamin D blood tests. A lot of the labs used to say, for example, 20 or 30 to 100 is a normal level. And the labs would put 30 to 100. It wasn't necessarily based on any research. The idea that gigantic of a range is normal, I'm just trying to equate it with you. It's like saying, well, a normal total cholesterol is between 100 and 700. You would go, what is this nonsense? That's not true. So what we've learned now is vitamin D is being tested over and over again, is that too little runs you into problems, and too much is clearly running you into problems. And what it's doing is it's increasing the risk of what's called hypercalcemia, where your calcium level goes too high in the blood and wreaks absolute havoc, as you know, the oncologists know. And then that calcium spills over into the urine. It's called hypercalciuria. And then say hello to kidney stones and a variety of other, plus it's just bad for the kidney. And so now if you go home tonight or the next few days, just go to Mayo Clinic labs, for example. Go to a reasonable lab reference and you'll look at vitamin D tests, and it will say something now that, okay, we don't mind the 20, 30, 40, but when you start going to 50 and above, hypercalcemia, hypercalciuria may increase the risk of falls, may increase the risk of other things I don't want to tell you about that could scare you, because we're learning now finally with trials that what happens when you get too much. And then if you get too little, we've always known. But I always get nervous when people sell that more is better. I just feel like they're selling something. They're selling a gimmick. And it's so easy too. The other great story about vitamin D is vitamin D was tested by itself. I am perfectly fine with going to CVS or Walgreens and buying one of the cheapest vitamin Ds. Like CVS has a program called Tested to be Trusted. They test all their products. Why they don't advertise this more is beyond me. If I was working for CVS, I would go, listen people, you need to advertise your quality control. I have not personally found a relationship between paying more for vitamin D and necessarily getting more. In fact, people have to understand that in the over-the-counter world, you're allowed to be generic immediately. That's why you'll find a brand name at one of the pharmacies and you'll find a generic right next to it when it comes out. And it's the same way in a lot of supplements. And I know this won't make me a fortune in the future, but some of the cheapest supplement products actually have the most research and they have the most quality control. So I can buy a bottle of vitamin D for 600 IU or 800 IU units. I can pay $5, $10 and have enough for 6 to 12 months. This idea that people are paying a fortune for it is mind-boggling. They're being sold on something. So let me go further. So they finally decided to test really high dosages in generally healthy people that were getting older. The study was published in JAMA, Journal of the American Medical Association. It was by Burt et al. And they went to really high levels, like 10,000. They looked at bone health. They were just giving them more. And lo and behold, they found as they gave more over this 2-year trial, they found there was a higher risk of this increase of calcium and increase of calcium in the urine that was, concerning. And they also
really expected. We know vitamin.
And expected.
Yeah, but vitamin D affects calcium.
Yeah, it was happening. And then they found more bone loss at the higher dosages.
Wow.
So these are people that are doing these studies because they think they're going to find more bone, not more bone loss.
Right.
So there's a point where the body goes, I'm getting too much here. Let's shut this down. And I give the example of testosterone replacement therapy. When you give the body a ton of product that it normally can make on its own, sometimes the response is, hey, you obviously don't need us anymore. Let's shut this factory down. And let's shut it down permanently in some cases. So there are some people that take too much testosterone, they've been on it too long, and when they come off of it, the testicles aren't making it anymore. It's the same thing with someone taking too much thyroid medication. They overtake too many hormones. So you also have to be careful about taking too many pills on something that the human body makes when there's so many wonderful sources. We did a course with the students at Michigan. The only plug I'm going to make today is the last podcast I did was, I don't do many for Michigan Medicine. They asked me, it was called, Is Vitamin D Important? And I review all the data. It's free. Just go type in Michigan Medicine, Mark Moyad, Is Vitamin D Important? It's 20 minutes of where vitamin D looks promising and where it doesn't look promising as of a couple weeks ago. But what we did with the students and the residents last year, where they came to my house and we cooked salmon and we went through a quiz. And it's really interesting. So the quiz was, for example, if you like wild Alaskan salmon, is A, wild Alaskan salmon high in vitamin D? Is it B, high in protein? Is it C, high in potassium? Is it D, high in selenium? Or is it E, high in B12? And you know me, I like to joke around. Everyone's going, circling this. I'm going, it's all wrong. It's all the above. And that goes back to my point of healthy products like to travel in herds together. You know, these nutrients love to travel. People don't realize that salmon is a great source of B12. And it's a huge source of vitamin D. And if I was in the wild salmon market, I would be advertising that the vitamin D levels being found in some of the wild salmon can be 3-4 times higher than in other types. And that was studied by Boston University. So there's great sources of vitamin D. I think it's okay to get it checked, but it's especially important for those on hormone therapy for so many reasons. And please do not let someone sell you on the concept that more is better.
Thank you. And the 8 glasses of water a day. The reason this is a bane of my existence is your body doesn't digest water. And unless you live in Alabama and perspire all day long, everything that you imbibe is going to be urinated out, and oftentimes in the middle of the night. I have a lot of people coming to me on a daily basis complaining about urinary urgency, frequency, getting up at night frequently. And I ask them how much water they drink, and they're really proud of themselves. You know, I'm doing my 8 glasses a day, like somehow that validates them as a good human. And the roots of a lot of HTO intake go all the way back to the inception of the macrobiotic diet in 1920, which strongly encouraged a vegetarian type diet, which actually was way ahead of its time and quite brilliant. But they piggybacked this 8 glasses of water a day along with it, which if you ask the experts that I've talked to, the nephrologists, the kidney experts, the only people that will benefit from large amounts of water intake are people that have a history of kidney stones. That's right. That will help reduce that risk. But for the rest of us, I think we're mostly making ourselves miserable. And if you limit your water intake to just when you're thirsty, remember, food has water in it. Food has a lot of water in it. So if you're drinking a lot of water before you go to bed, you're going to be waking up at night. But am I wrong in any way? Have you found anything that would contradict that? I know this is Dr. Moyad, the reason I put that to him, Dr. Moyad has written books about alternative medicines, vitamins, supplements, herbal. This is really his expertise. So.
Well, you know, it's just that it goes back to just these principles that will guide you very well. We'll talk about a few more before we finish today. The healthy nutrients love to travel in herds together without ads. Part of the way you know you're eating a healthy product is its water content in general is very high. So 20 to 25% of your daily water intake comes from food. And so the people who eat very healthy foods, fruits, veggies, and they get a lot of healthy food tend to get a lot of water. And so a lot of people, again, will say it's this that reduces the risk of a kidney stone. Well, it could be also the foods they're eating because they're very high in anti-stone ingredients, right? So it's a wonderful thing to eat healthy food and get water from there. The second thing I've always told audiences and people my entire life is that there's a really good rule of thumb when it comes to water and it comes to dehydration, because it is true as we get older, we lose the ability to do a lot of things that we took for granted when we were in our 20s or 30s. Like when I go to a Michigan football game, and if I have a soda or something, I can't hold it. I got to run to the bathroom. Shoot, you take me 20, 30 years earlier, I can hold it for 4 quarters until we win the game, right? So things change. And one of the things that's changed is the sensors that tell us we're thirsty or not, or we're actually dehydrated. So if we can get into trouble as we get older. We don't know when we're hydrated or dehydrated. A good rule of thumb that is a general rule of thumb is I used to tell audiences all the time, just remember that after a workout especially, because like this morning when I went running, I looked for this, or after lifting weights, remember the concept of clear is cool. Clear is where you want to be. So you don't want dark urine, you don't want urine that's semi-yellow. ultimately after a workout or you put in physical activity, you want to drink enough water where you see clear urine. It's colorless. You're filtering now. You've done very well. You've hydrated enough that the urine is free of being concentrated and you're seeing nothing but clear come out. The reason why when you wake up in the morning and you haven't had much to drink the night before or you've had too much alcohol, the urine is completely yellow. It's fully concentrated. You're dehydrated. So clear is cool is a good concept. The idea that you got to pick a number, and when you achieve that number, you'll achieve nirvana and go to heaven, is crazy. It just sounds good. It's just trying to make things simple. But in the area of kidney stones, higher water consumption is good. But you can get, again, that consumption from a lot of food products. It doesn't have to just come from water. The area where people run into trouble as they get older is they get urgency. And the people who have suffered from overactive bladder know that their urologist or their team will tell them that be careful not to consume too many fluids, because that's going to make your urgency that much worse. It's going to make the bladder spasm. It's going to get you up in the middle of the night. There's clearly situations where more is not better when it comes to water. So I wouldn't use the 8 glasses. I never have. I use the clear is cool phenomenon. And it helps me make decisions in my own personal life after I do a workout, for example. So, yeah, I agree with you. It was a wonderful thing to say, but it's gotten a lot of people in trouble. In fact, if you really want to know the history of how it got people into trouble, is that the Boston Marathon used to just, and most marathons when you run them just used to give water. You'd go by and you'd go after a mile, they give you water. And then people would drink so much water, they developed a condition called hyponatremia. They diluted their blood to the point where they had seizures. So a young woman died at the Boston Marathon long ago. It was a case written up in the New England Journal of Medicine. They realized she was exposed to too much water during the race. And that study from Harvard of this young woman that died during the race led to, in many other cases, led to why when you do athletic events, you also get Gatorade or you get electrolyte drinks. It's not just straight water, because the body needs electrolytes too as you begin to deplete sweat, as you put in more physical activity. So it's part of the whole teaching tool.
Yeah, and the hyponatremia problem of too much water intake is a bigger problem as we get older, because our kidneys don't concentrate urine as well when we get in our 70s and 80s. So occasionally we routinely check sodium levels in the blood. Whenever we get someone's PSA, we get a basic metabolic panel that checks your kidney function, your potassium levels, your sodium levels. And if I have patients who, they otherwise feel fine, but you look at their blood test results and it shows that their sodium levels are low, I know that they've got a water fetish. They are drinking so much water, they are depleting their body of salt, and it can get very dangerous if it goes to an extreme and literally cause a seizure. So if you're tracking your sodium levels, you're protected, but not everybody is. If you have a desire to drink a lot of water, and if you're getting up into your 70s and 80s, make sure that you do check your sodium levels, because you can wash so much salt out of your system, it can become dangerous.
Yeah, and some of the antihypertensive drugs, some people take certain medications, diuretics, they can lose electrolytes. So these are good things to look at in the labs, which I know you and I have talked about, but there's a lot to this water game. And of course, the truth lies somewhere in the middle. It's not such an extreme situation. So hopefully that helps you a little bit. What was the other topic we were going to talk about? I thought
you wanted to cover more hormone blockade side effects?
Oh yeah, we wanted to cover more side effects. We were going to cover muscle loss. So we talked about this condition, and it is an epidemic condition, not just on hormone therapy, just at any age group today, and it's called sarcopenia. And sarcopenia, sarcos is from the Greek word meaning flesh, penia means a lack of or a deficiency of. There is no question that as you age, the body likes to lose muscle mass, and it starts at the age of 35, 40, and then it's a percent or two every year or two. You're literally fighting, and it's interesting that most of this research came from prostate cancer patients who were not necessarily on hormone therapy. We just realized that when you were younger and you worked out with weights, that you could take a few weeks off and your muscles would be just fine. When you're 40, 50, and 60, and you take a week or two off, you go so quickly down the slope that you are backed up for several months to get back where you were. So as you get older, the body, it takes a lot more effort to normalize where you were if you take a break of many, many weeks. So now you've got a drug that accelerates muscle loss on top of the muscle loss that you're already experiencing.
Hormone therapy.
Hormone therapy. And it is why we have become just religious about the idea that in all these amazing mechanisms that we've discovered in drugs and these wonderful things that we talk about in the meeting, we still haven't found a single drug that does better than resistance exercise at stimulating muscle tissue and not only making the muscle tissue larger, but making you stronger. So think about it.
Why is that so important?
Believe me. Well, why it's so important is not just for overall strength. We know it reduces fatigue. So one of the things that you hear about a lot with these drugs is I'm tired all the time. Well, what happens is when you put on more muscle mass, you increase metabolic rate. So you become more of sort of an energy powerhouse. Mm-hmm. So you're able to get more energy during the day. And so it's not just the skeleton, it's not just the muscles overall, it's the balance. So where people get in trouble too as they get older is they lose balance and they fall. So what they have found with lifting is it's not only heart healthy, it's not only muscle healthy, it's not only bone healthy, it's not only nerve healthy, it also reduces the risk of all these metabolic issues, increases your energy level overall, right?
Memory healthy.
And memory healthy too. Anything that I always say that's heart healthy is healthy from head all the way to the toes. But we've also learned that you don't need to lift more weights to become stronger and healthier. That was something we were taught that turned out not to be true as it got studied. And what I mean by that is one of the biggest problems with lifting weights is that people think as they get stronger, they have to go to a heavier weight. And the problem is as you get older, it just takes a moment to go to a heavier weight and suddenly you pull your back out or suddenly you're sidelined. So what they decided to do in Canada and other places, they decided to test the concept of you don't go to heavier weights, you just lift less heavier weights or lower weights at more reps. So instead of trying to go for 6, 7, 8 times like with a barbell or with an arm weight, you'll go 12, 15, 20 until you're experiencing fatigue. So you don't need to go up in weight, you just need to go up in more reps. So I still lift like a 25-pound little hand weight, and instead of doing 15 reps, I'll do 20 to 25 and I'm completely exhausted. What they ultimately found from these studies is that your strength and your muscle size was as good doing that as simply going up to higher and higher and higher weights. And that's personally what I've experienced too in my situation and my personal self as I've gone to less and less weight and I have less and less injury overall. So that's one thing you should take away from the lifting standpoint. Nobody is ever going to tell you, and I've seen this comment in a PCRI, where you're on hormone therapy that you're really excited to exercise and lift weights. It is a pain in the gluteus maximus. It is a pain in the gluteus maximus. But the beauty of it, and where I want you to find beauty, is that we have found this secret to maintaining all these benefits, and you don't need a prescription and you don't got to pay this high copay. It's there at your fingertips. And what we generally see is that, as I tell my kids and myself, is you're only one workout away from being in a good mood if someone's crabby. And in my world, all world leaders can only meet after they work out, right? Families can only get together after they work out. Husbands, partners, they can only have heated discussions after they work out. This world would be a much better place.
Amen.
So I'm on the treadmill this morning, and today I decided to do high-intensity interval training. I'm just going to go 3 miles. I'm going to go one really hard, one really soft, one really hard. By the first, I'm like, I'm so tired, man. I've been doing this meeting 15 years. How's it going to go? I hit mile 1. I'm feeling pretty good. I hit mile 2. I'm going, yeah, no, I'm feeling really great. This is going to be a great day. By mile 3, I'm going, oh, this is going to be the best meeting ever. There's no question in my mind. And then really, that's how it works. That's how the brain works. And it releases these neurotransmitters when you work out. So the other point I want to make about weightlifting, which doesn't get enough attention, does anyone know who Tenzing Norgay is? Tenzing Norgay it was the Sherpa that took Sir Edmund Hillary up to Everest the first time. And what I find so funny is this guy goes up to Everest with the Sherpa, and the Sherpa's like, yeah, come on, we'll go to the top. And he gets credit for being at the top of Everest, but meanwhile, this Sherpa's just going up all the time, right? So he's kind of not getting the credit, but he ended up getting credit. So he's kind of behind the scenes, not getting the love. So this is how I want you to think about lifting and muscle. The muscles, there are certain muscles that just get all the love in the world, and then the rest of them don't get any attention. But they are critical to the balance, to the strength, to increasing energy, and I wish we would push that more. So I'll just give you 2 quick examples. Everyone wants to see the bicep. Oh, if you're on the beach, check out my bicep. Nobody really wants to see the tricep. The poor old tricep is the tenzing norgay. It sits out here, but it makes up just as much volume as the bicep. So it is just as important to do weightlifting that helps stimulate the tricep muscle as it is the bicep, because of the sheer volume that the tricep takes up and in terms of keeping your strength. The second one is the quads. So the front muscle mass, boy, yeah, everyone wants to show you these. The hamstrings, no one gives a damn about. They just sit back here, they get absolutely no love, right? So when you're doing these leg extensions, when I'm doing it at the hotel, I'm checking out my quadricep, I'm feeling pretty good. I think my wife's gonna think I'm sexy when I come home. But then I realize there's these leg curls, right? And that works the hamstrings. And it's a pain in the ass. If you've ever tried these, you can do a ton of weight this way by using this massive muscle. But the hamstrings here, you can put on 10, 15 pounds and go, oh my God, I can barely lift this, because it gets no attention. It's really hard to exercise it. So, but what you're doing here is you're not only balancing this huge muscle with this huge muscle, that increases your balance, that increases the nerves, that increases nerve function, that increases skeletal function, and it also allows you to get symmetrical volume and benefit. So just remember about the tenzing norgay of muscles. Everyone wants to talk about this, but no one wants to work on this. Everyone wants to work on the bicep, but no one wants to work on the tricep. And that's the other concept that I wish would get attention. And it's not easy. This morning when I was trying to work my tricep and then my other tenzing norgay muscles, it was terrible. I'm lifting about 1/3 or half of what I'm lifting the other direction that's helping my quads. So it's something else that needs to be worked on when you're on hormone therapy, because all of it starts to go fast. It all starts to go fast. In fact, the Australians did a study that if you waited 6 months into hormone therapy, the chances that you would get back what you lost were minimal to nothing. If you started the day you got the injection or took the pill, you were able to maintain that amount of muscle mass. You had a shot at it. But if you wait a few months, you're already so far behind the 8 ball that you're struggling to get to where you need to go. And so I just find it interesting that for almost every side effect, so we call it cancer-related fatigue, CRF. We call it muscle loss. Or, for example, your blood cholesterol goes up, or you experience bone loss. Almost every side effect of hormone therapy has resistance exercise or aerobic exercise as an option to combat it. And I find that to be beautiful. It doesn't mean that I think it's so easy to go out there and do it. I just love that we have an option that doesn't cost a lot of money, doesn't make me go into the doctor's office every 2 minutes to get it, and this is something that if I do on my own, it's gonna help me from head to toe. And that's why we talk about it, and that's my speech on resistance exercise. If you like Nautilus, great. If you like free weights, great. People get way too caught up in what's the best. The one that you can stick to is the best, because it's so hard to do that 2 or 3 times a week. Some people told me as we were talking on in the side room, we were also taught that you had to take a day, like on a Tuesday, let your muscles relax, and then maybe let them relax and reorganize, 2 to 3 days later. And I'm going, well, where does that research come from? So they looked at consecutive versus non-consecutive weightlifting. Because my problem is, I'm really good for weightlifting Saturday and Sunday. Monday through Friday, I'm not very good. But I was taught I had to take a few days off. So they tested that during the week, even if you did 2 days in a row, and then you didn't do it for a couple days, or let's say you did it on a Tuesday and a Thursday, as long as you got those 2 or 3 days in, you got the same result. You didn't have to take 5 days off in between. So anyway, that's the speech that's taking me way over. And what's the next question? On any other side effects we didn't talk about? Why don't we run through a couple other quick things and we'll call it a day?
Yeah, I mean, that's, in real estate, it's location, location, location. In hormone therapy, it's exercise, exercise, exercise. And then I think it was totally appropriate to really dig into that. The only thing I would add is if you have financial resources, hire professional supervision. Not so much because you need it, you can probably do it on your own, but the accountability. Or join a club, or join a group of people, so you have some energy to keep doing it on those days when you just don't want to do it. That's the motivational side of it is very challenging, and whatever is necessary, do it.
I review for a lot of medical journals, like the Journal of Urology. I get to decide whose paper you get to see published. It's an incredible honor. So I get sent a lot of exercise ones, and one of my favorite was the ERASE trial. It was probably one of the biggest studies coming across in my career. They took active surveillance patients in Edmonton, at the University of Calgary, and it was one of the most widely read articles in medicine last year. It was in JAMA Oncology, and then there's another follow-up in the Journal of Urology. And they just had them essentially do exercise a couple days a week. They would come in versus a group that did not. These aren't active surveillance, not a hormone therapy. And within 12 weeks, not only their fitness was so much better, if you look at their level of anxiety and their just fear of progression and just all of these fears that people have and stress, all of those were reduced within 12 weeks. And what struck me, it was not the physical benefits that exercise brought them. That is probably not what motivates me anymore, and hopefully not for people going through hormone therapy. The mental health benefits are striking. They are so striking that you can literally tell the difference between two people who regularly exercise and not, in just terms of mood, in terms of stress, anxiety, something that doesn't get enough attention in cancer called catastrophizing. Catastrophizing is pervasive negative thinking, where you get a piece of bad news and your mind goes, oh my God, my PSA higher, I know the cancer's back, could this be metastatic disease? It's all very understandable. I had a catastrophizing moment many weeks ago. I had to go in for an early colonoscopy. I'm not quite 60, I'm 58, which if you do the math is 10 years younger than Dr. Scholz, which makes me incredibly happy. Sorry, I had to throw that in.
You take the cake.
No, the truth of the matter is I had to go in, there was an issue, I thought, oh my God, here we go. This is it. God's been too good to me my whole life. I'm going to pay the piper. Went through an extensive procedure. It turned out to be fine. They found a polyp, but what I worried about wasn't what I worried about. Went and worked out. Had a good day. And so what working out does is it reboots the brain. So when you start to go into pervasive negative thinking, it reboots you to think, wait a second, I'm good here. And that's why I'm saying that I just wish that the mental health benefits would be talked about even more than the physical health, because this is the challenge here as all of you go through these things. It's so challenging. And you have these moments, you have these good moments, and then you have these defeatist moments, and there's very little. And when someone goes, oh, just buck up, it's going to be fine, hey, that doesn't do it. And you have to find internal ways, internal circuitry to fix in order to get you to a better place. And so one of the ways you reboot is through aerobic activity. Resistance does it for some people, but this is what they're finding in prostate cancer patients, and I wish this would get a lot more attention, because it keeps you in the game. Yep. Because whether things are going well or not, unless you're okay here, it's tough to see it, right? And this is why, even if I talk to my son, it doesn't matter who I'm talking to, I always tell them to look for a partner that puts physical fitness at the forefront. I really think it's important for your partnership. I mean, your partner is such a key person in your life as you're going through whatever you're going through. One of the greatest things I love about my wife is, since the day I met her, is that she puts fitness and taking care of herself at the front of everything. Anyone that knows her, when she came to this meeting, if it's 8, 9, 9:30, I'm in bed. I'm not going to be drinking. I'm going to do this. I'm going to take care of myself. I'm going to do a workout, but not to the point of excessiveness. And that stuff rubs off on me and back and forth. And so another thing is, you want to surround yourself. They say you are who you surround yourself with. And it's very true. So when you're going through this, to go back to your point, what I commented to the researchers who are doing this trial is that you're not able to measure the benefit of what I call socialized exercise. So if you're able to go with a trainer, or you're able to go into a gym, and you're around other people, whether it's your partner or other men or women working out, there's an added boost that we can't document in data, but we know it exists, because we learned that from depression studies. If you take someone on antidepressants and they go into a social setting to work out, they're more likely to get a better response from their antidepressant versus just working out in isolation. So Socialized exercise is another component. If you can afford a trainer or a gym, or you're going to go in and adopt a new attitude on taking care of yourself after today, try to do it with a partner. It is very powerful, and it can get you away from what I call the stress, the anxiety, the depression, the catastrophizing that occurs with dealing with trauma and dealing with cancer and dealing with the overwhelmingness of life. And I hope you take some of that with you, because that's what's helped sustain me through some of these storms when I dealt with it in my own family. So, for what it's worth.
I'm glad we could emphasize it. Yeah, the fitness side of things is life buffets us, whether it's through cancer or other things. And if we have a for me, if I'm able to exercise, I have an exercise machine in my bedroom, and every morning it looks at me asking me, are you going to use me this morning? And the days that I say yes, I always wonder, why did I even question it? And the days that I say no, it's a different day.
You never regret a workout after the workout is another saying. Yeah. After the workout. It's not like I woke up at the hotel and there's nobody in the exercise room at 6 a.m., let me tell you. And I'm going, what in the hell am I doing here? And then you get into your routine and you know exactly why you're there. Yeah. Because I love how movies and TV shows makes life seem like you're feeling one emotion for an entire year. We are a vacillation of emotions, but one of the ways we can control some of the negative thinking, which we have to deal with. And I also say this is one of the greatest problems that I've seen in kids, getting rid of physical fitness in schools, and now we know it hurts their science scores, it hurts their math scores, and it hurts their socialization, and it hurts their mood. It hurts their mood. And to me, it was one of the biggest tragedies I've seen in this lifetime, that when I had to get a physical fitness medal when I was in high school or junior high, that we abandoned that whole concept. And now physical fitness is a dead concept as a class in school. I think that was a huge mistake that we'll ultimately realize that we have to bring back. So I'm talking about every single age group here being involved. And there is a concept in medicine called the ripple effect. It is a real effect. And any major exercise group has measured it, including Weight Watchers and dieting groups. The effect goes something like this. When one person in a circle of people starts to take care of themselves better, the chances that that behavior ripples to the rest of the people and they start paying attention to their health goes up dramatically. So what they learned, for example, in a very famous Weight Watcher study is they gave free Weight Watchers to one partner, they lost a bunch of weight, they became healthier, and they decided to look at the other partner that didn't get the Weight Watchers, and suddenly they were becoming healthier for free. Because they were tagging along. They were so excited about what their partner was doing. So I could sit here for 8 hours and go through the different benefits. And I just love how people talk about these neurotransmitters, serotonin. They talk about dopamine. Exercise gives you all that. It gives you that rush. It gives you that effect. And so, but it is not easy. I don't even for a second try to fathom what it's like on hormone therapy. It's just tough enough as I get older just to go out there and exercise, because the motivation drops. In fact, they call hormone therapy, I don't think I've shared this with you, they call it officially androgen deprivation treatment, ADT. I think they should rename it to, I came up with androgen disposition transition, meaning it changes personalities. It makes you more tired. It makes you more lethargic. It's very hard to get motivated, but I do think doing it with a partner, asking for help, is part of the way to get out of the gate. And I'm glad we sold it for 30 minutes here, because it's so funny how we'll sit at these meetings and talk about the greatest drugs in the world for side effects, and we haven't found a single drug that comes close to aerobic and resistance and flexibility exercises to combat most of the side effects of androgen deprivation treatment. We haven't. We used to hear from partners all the time, my husband's different. He's more labile. He's more irritable on hormone therapy. He's just different. He snaps. And you know, we're just starting to learn about what happens physiologically and mood-wise. And so I'm hoping that in the future we're selling this even more than we're selling it now to convince people. I really am. Yep. Do you want to say anything more about any other side effects? Should we call it a day? We've had quite a day.
Yeah, I think it's good to close on that note. The only thing I'd like to say is thank you again to the PCRI team and the audiovisual. Thank you for capturing all this for the, so it's going to go online.
Thank you, Dr. Moyad, and thank you, Dr. Scholz. I so appreciate your perspectives, and I know we all do together. A couple things I want to remind you of. You have time, whether you're in an advanced category or whether you're in newly diagnosed or in between. You know, prostate cancer is slow growing, but I don't want you to feel forced to treatment without having the proper education, the proper research into the side effects, and really holding your quality of life as equal in all of that. I understand this is a scary process, but please remember that PCRI is here for you. You're not alone. Our helpline facilitators are here to answer your questions, and also if you would like this channel, if you appreciate the videos that we do, please like this video. Give us the comments and the topic ideas or anything you want covered in the comment section below, and share this videos with your friends. I think it's important that all the videos on our channel, they're very topic related, and something that may be relevant to you can also be relevant to someone else. We really appreciate your support. If you would also like to partner with us as a 501c3 nonprofit and partner with us whether it's on a monthly basis or in an individual just one-time donation, we'd really appreciate it. No amount is too small. And I'd also like to thank our sponsors, Bayer, Janssen, Dendreon, Myovent, Astellas, and Pfizer. It's because of them that we were able to present this for free to all of you all around the world. We appreciate you. We know this is a hard journey, but our thoughts are with you. Please know you're not alone, and please reach out if you need help. Again, like this video, subscribe to our channel. We come out with new prostate cancer videos every week. And most of all, much love. Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more.
Cancer doesn't discriminate. It can affect any of us.
This is Living with Cancer is a program created to support all people in their cancer journey, especially those of us facing challenges.
Get resources for older people living with cancer. Understand the importance of screening. And find tools to help live life beyond your diagnosis.
Learn more at thisislivingwithcancer.com.
Provenge is an established cellular immunotherapy used to treat certain men with advanced prostate cancer. Provenge is customized to each individual and is made from his own immune cells. Immunotherapy is the prevention or treatment of disease with substances that may stimulate an immune response. The immune system has memory and can recognize substances it has encountered previously. Immunotherapy is designed to boost the immune system to target and attack advanced prostate cancer. This is why immunotherapy empowers the immune system to fight the cancer immediately and allow the effects to last over time. Indication: Provenge is a prescription medication used to treat certain men with advanced prostate cancer. Provenge is an established cellular immunotherapy and is customized to each individual by using his own immune cells. Important safety information. Before receiving Provenge, tell your doctor about any medical conditions, including heart or lung problems, or if you have had a stroke. Tell your doctor about any medicines you take, including prescription and non-prescription drugs, vitamins, or dietary supplements. The most common side effects of Provenge include chills, fatigue, fever, back pain, nausea, joint ache, and headache. These are not all the possible side effects of Provenge treatment. Provenge is made from your own immune cells, which are collected during a process called leukapheresis. The cells are processed, returned, and then infused back into the patient through an IV, intravenous infusion, approximately 3 days later. This process is completed in 3 cycles, about 2 weeks apart. Each infusion takes approximately 1 hour and requires 30 minutes of post-infusion monitoring. Provenge infusion can cause serious reactions. Tell your doctor right away if you have signs of a heart attack or lung problems, such as trouble breathing, chest pains, racing or irregular heartbeats, high or low blood pressure, dizziness, fainting, nausea, or vomiting. Have signs of a stroke, such as numbness or weakness on one side of the body, decreased vision in one eye, or difficulty speaking. Develop symptoms of thrombosis, which may include pain and/or swelling of an arm or leg with warmth over the affected area, discoloration of an arm or leg, shortness of breath, chest pain that worsens on deep breathing. Have signs of infection, such as fever over 100 degrees Fahrenheit, redness or pain at the infusion or collection sites. Tell your doctor about any side effects that concerns you or does not go away. For more information, talk with your doctor. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see accompanying full prescribing information.